That's the mass which was seen. Let's look closer.
And the organizer for giving me this opportunity.
That's the mass which was seen. Let's look closer.
I'd like to thank the organizer for giving me this opportunity.
That's the mass which was seen. Let's look closer.
I'd like to thank the organizer for giving me this opportunity.
Gracias. చేసి వెనకాల పిల్లలకి check.
That's the mass which was seen.
Check, check, law, check, all, check.
I like to thank the organizer for giving me this opportunity.
Check, law, check, all, check, law, check, all,
Hello. Check. 1, 2, 3. Check. Hello. Check. Hello. 1, 2, 3. Check. Hello.
check, law, check, law, check, all. Check, 1, check, check.
That's the mass which was seen.
Check, yes, one.
I like to thank the organizer for giving me this opportunity.
seen. Let's look what
I like to thank the organizer for giving me this opportunity.
That's the mass which was seen. Let's look what
I like to thank the organizer for giving me this opportunity.
The chairpersons to kindly start the session.
Good afternoon, everybody. I think this stage is nearly ready. We always start like that. And again, thanks Sanjay and the whole team for such a beautiful meeting over years. Now we are really into the real pancreas. And it's really great that Sanjay is starting with a affluency, disease of affluence. I hope so. And we had a affluent lunch over there. So it's right time to start with the affluent disease. And Jimulu will tell us, but let me tell you just before he starts, because to have a lighter mood, nearly 8-10 years back, a radiologist wrote that is fatty pancreas. I was thinking, I sent the patient for chronic liver disease, and he wrote fatty pancreas. Patient started asking, and I was just talking to Dr. Kunar yesterday, gentleman who will be entering to corporate world, just passed and asked me, Dr. Das, you are talking so many things, but this fatty, what is my prognosis? So young generation comes to you knowing everything, and they put you not in trouble, they would put you retrospectively thinking what exactly you need to tell this patient. I think Jamil will tell all of us over his time period. Anyone want to add anything? I think it's all yours.
Yes, thank you, respected chairpersons. At the outset, I would like to thank Dr. Mahesh Goenka sir, Dr. Sanjay and entire Kolkata Pancreas Club team for this kind invitation and opportunity. I have no financial disclosures. So the first description of fatty pancreas was described in way back in 1867, and it was related with a very rare case report of a phosphorus poisoning. In that, what they found that almost all the organ had a fatty degeneration. After that, there was no much scientific evidence. In 1933, Dr. Olive had first description from UK, where they found out that the obese individual in the autopsy, they had found that the fatty infiltration again was there in the pancreas. However, still then there was not much of a clinical evidence, but in last 1.5 to 2 decades there is a plethora of evidence nowadays because of the increasing obesity, increasing the recognition of the other metabolic disorders, as well as the change in the dietary habits, and more utilization of the non-invasive technologies like CT scan and MRI. We have found out that the fatty pancreas is not that much uncommon, and with the recent evidence what we have found out that it might be one of the most common benign pancreatic diseases when we do the prevalence studies. It can be an isolated part where the only pancreas is involved, or it can be a part of a generalized steatosis, where steatosis means an ectopic deposition of the fat. So here I would like to tell that there is a difference between a nomenclature, whether it is a pancreatic steatosis, fatty pancreas, or the only pancreatic fat deposition. So fatty initially considered to be the pancreatic steatosis, but however the steatosis is not the right nomenclature because it just shows that the ectopic deposition of fat within the pancreas. However, even the normal pancreas also has almost 3 to 5% of the fat. So the pancreatic steatosis, which was the earlier used term, is no more used, and it is an incorrect term. So even in the normal pancreas, almost 3 to 5% of the weight is made by the pancreatic fat, of which triglyceride and the oleic acid and the palmitic acid are the most common. And when there is an increased fat deposition, it is considered to be intrapancreatic fat deposition. So it is a continuous scale from 0 to 100, but when we divide it into binary, whether it's a physiological or a pathological, we consider it as a fatty pancreas, yes or no. So intrapancreatic fat deposition can be of 4 types. It can be because of the increase in the interlobular fat, where there is a fat deposition between the pancreatic lobule, intralobular fat, where there is a lipid droplet within the pancreatic acinar cells or the islet cells. It can be because of the pancreatic acinar to adipocyte transdifferentiation, or it can be the fat replacement of the dead pancreatic acinar cells. Having said that, there has been what is the prevalence. So in the population based study, what they have identified that almost 16% of the patient had a normal healthy control had a fatty pancreas when they used the upper cutoff of 10.4 in a MRI sequencing. And when they found out the risk factor, the presence of a central obesity, increasing triglyceride, and other insulin resistance was having a highest level of correlation with the fatty pancreas. Similarly, other studies, population-based studies from China also found out the similar levels, where the increasing triglyceride level had associated with the fatty pancreas. However, having said that, the larger Cosmos studies from the New Zealand, they have found out that almost 25% of the patient might not have a metabolic risk factor, because the BMI, waist circumference, or the visceral adipose tissue might not be directly correlated with the fatty pancreas. So not all the obese patient will have a fatty pancreas, and at the same time not all the fatty pancreas patient might be obese, or they might be having a metabolic risk factor or the metabolic syndrome. Similarly, there is also much correlation whether the fatty pancreas is just an extension of the fatty liver disease. So the autopsy studies have shown that yes, there is a high level of significance there between the macrovesicular fat and the interlobular fat, or the total fat within the pancreas. However, the prospective studies have shown that almost 50% of the patient might be having a discontrance. So only 50 to 60% of the patient have a both, that is a fatty liver as well as a fatty pancreas, but almost 40 to 50% of the patient might have isolated fatty pancreas or a isolated fatty liver. So TT within 25 to 30% of the patient themselves. So apart from the metabolic risk factor, there are other drug and toxin infection related or certain kind of a congenital risk factor can also be there. Regarding the diagnostic workup, transabdominal ultrasound is the most common. However, it is an operator dependent, and many times evaluating the entire pancreas might be difficult. And whenever we are comparing ecocity, we are usually comparing it with the ecocity of the kidney. CT scan, when we are utilizing it, is a non-contrast enhanced CT scan. There are various thresholds are there, but usually it is compared with the spleen, and pancreatic spleen ratio of less than 0.7 is considered to be a significant. In MRI, most commonly used is the PDFF signals. Other signals like ideal one or the ideal name sequence and the MRS can be also used. The most commonly used cutoff of more than 10.4 in PDFF is considered to be abnormal when we are considering as a fatty pancreas. EUS has been also tried, and they have shown that based on the echogenicity, whether we are able to see the pancreatic duct and the parenchymal salt and pepper dots are there or not. You can again differentiate whether the patient is having a fatty pancreas, and if yes, what are the grades of the fatty pancreas. Apart from that, systematic biomarkers like triglyceride level, HDL levels, glycosylated hemoglobin or the HOMA can also predict the risk of having a fatty pancreas. Another novel marker like turocolate and the 5-hydroxylysine or the sulfolithocolate, circulating level of TNF alpha, periostin, lipocalcin 2 can also are under investigation to predict whether the patient will having a fatty pancreas or not. Now, what are the clinical implications? Why we need to know whether the fatty pancreas is there or not? It can be just as a fatty liver disease. It might not be having that much amount of clinical significance, and with the drug and diet you can completely reverse it. But however, the clinical scenario is little bit different. So this was a study which was done in New Zealand, where they have identified 150 patients or the controls in 2012 to 2014. Then after that they evaluated them prospectively, and 50% actually developed the pancreatitis. When they identified what was the risk factor for the pancreatitis, the baseline MRI was showing that the increased pancreatic fat deposition ranging from scale of 1 to 20% had a highest level of risk of developing acute pancreatitis as compared to the patient who do not have a intrapancreatic fat deposition. And it was statistically significant irrespective of the age, gender, BMI as well as the etiology. Even the patient who had a biliary pancreatitis, in that also developing patients who have a gallstone disease, in that also developing a biliary pancreatitis was higher when there was a more and more amount of the intrapancreatic fat deposition. Similarly, patients who are undergoing on ERCP, again if the patient have a baseline higher level of fatty pancreas, and the chances of developing post-ERCP pancreatitis is higher, which is over and above the risk factor related to the age, non-dilated bile duct, or the repeated injection of or repeated insertion of guide wire within the pancreatic duct. So now the studies have shown that the presence of a fatty pancreas can be an independent risk factor for developing a post-ERCP pancreatitis over and above the conventional risk factors. Once the pancreatitis has been developed, the studies have shown that if the baseline pancreas is fatty, then the chances of developing a new onset diabetes is again higher, and it is directly linked with the intrapancreatic fat as compared to the normal diabetic patients, where there is the ectopic fat in the skeletal or the visceral are having a more association as compared to the intrapancreatic fat. Similarly, in a chronic pancreatitis, though the evidence is not strong, some studies from the USA have shown that the Cambridge criteria 1 to 2 are having a higher level of intrapancreatic fat deposition as compared to the normal individual or without having a chronic pancreatitis. Apart from acute and chronic pancreatitis, studies have shown that having a higher level of intrapancreatic fat can increase the risk of developing a pancreatic carcinoma. So it was again a study from a Mayo Clinic, where they have identified 32 patients who underwent a CT scan 1 month to 3 years prior to developing the pancreatic adenocarcinoma, and 117 control. So in that, the baseline higher level of intrapancreatic fat deposition was having a more risk of consecutive development of pancreatic adenocarcinoma compared to control, and it was over and above the development of a diabetes mellitus. Similarly, it was a study from Japan where they identified the patients who underwent pancreatic duodenectomy either because of the pancreatic cancer or because of the other reason, and what the other reason they used as a control, and they identified that even in the non-cancerous pancreas the histological pancreatic fat fraction was higher compared to the controls. Similarly, MRI PDFF as well as the CT induced pancreatic index was higher as compared to the controls. So then there is again a study from a USA where on almost 68 patients of a pancreatic adenocarcinoma who underwent a prior prior CT scan as compared before development of adenocarcinoma, and they have compared it with almost 200 controls, and what they showed that the increasing risk pancreas to spleen fat ratio, the more and more chances odds ratio of developing adenocarcinoma in future, which was over and above, which was compared to the controls. Similarly, once there is a development of adenocarcinoma, studies have shown that patients who are having a node positive are having a higher amount of a fatty pancreas and associated with a lower survivor as compared to the node negative. So based on this factor, recently there is one hypothesis has been developed by Dr. Maxim from New Zealand. What they have identified that the pancreatic disease is originating from the intrapancreatic fat, that is they have called it as a Pandora hypothesis, and what the hypothesis says that the fatty pancreas might be the driver for all the benign or the malignant disease which might happen in the future. The inflammation is because of the overwhelming lipotoxicity. Acute pancreatitis can develop because of the abnormal crosstalk involving the lipid droplets. The fibrosis and calcification are actually the reflective organs response in response to the lipotoxicity which has been generated by the fatty pancreas. Similarly, because of the intrapancreatic fat also increases the changes the milieu of the parenchyma, and that can also lead to more and more amount of the inflammation, and it can be a driver for the pancreatic carcinoma as well as the dissemination of the pancreatic carcinoma. And it is in contrast with the earlier hypothesis, which are the necrosis fibrosis, toxic metabolic, or the sentinel acute pancreatitis event. So according to this new hypothesis, all the risk factor of a pancreatic disease, fatty pancreas like age or the cholelithiasis, dyslipidemia, drug related genetic, iron overload disease or the metabolic syndrome, they can change the milieu of the pancreas and finally can culminate into either acute pancreatitis, chronic one, or the pancreatic cancer, or even in a long run diabetes or the diseases of the exocrine pancreas. Apart from these diseases, the fatty pancreas is also considered to be a risk factor of the post-operative fistula formation, where there is a post-operative pancreatic fistula where the softer pancreatic parenchyma, pancreatic duct size of less than 3 mm, and the BMI of more than 25 were considered to be risk factor for developing fistula after pancreatic duodenectomy. And in meta-analysis also, these have shown the highest odds ratio as compared to the other risk factors. Apart from development of the acute or chronic pancreatitis or the pancreatic carcinoma, the studies have shown that having a fatty pancreas is independent risk factor for developing a diabetes mellitus. So in this study was done in USA, where the MRI was done between 2008 and 2010, and after 10 years what they have shown that the patient who were having a fatty pancreas were higher risk of developing diabetes, higher risk of developing hypertension as well as a dyslipidemia. The risk was highest when the patient had both fatty pancreas as well as a fatty liver. However, having alone fatty pancreas is also was considered to be a risk factor in development of a future diabetes. Apart from that, developing a subclinical atherosclerosis is also documented in patients with a fatty pancreas as compared to patients who doesn't have a fatty pancreas, even irrespective of the BMI. Regarding the treatment options, because it's a newly diagnosed or a newly recognized entity, there are few options are available, and majority of the options are, I would say, preclinical or only a case series. A robust randomized trial only dedicated for the fatty pancreas is still not yet available. However, the role of a diet modification, especially with the low carbohydrate diet, has been evaluated in a randomized setting, where they have shown that the low carbohydrate diet, especially combined with the physical activity, has shown to reverse the fatty pancreas as well as reverse the pancreatic morphology as compared to the low fat diet. So to conclude, Fatty pancreas is nowadays an increasingly recognized condition with more and more prevalence. It has got a complex interplay between the metabolic syndrome, non-alcoholic fatty liver disease and diabetes. Having said that, the more and more pathogenesis has not been evaluated in a prospective trials. Multiple clinical implication including acute pancreatitis, pancreatic carcinoma and the post-operative fistula formation is there, and as of now there is a very limited amount of clinical data are available to know the therapeutic options, whether we can reverse it or not, and even if we reverse it, what will be the future or the long-term clinical implications. Thank you everyone, and happy to take any questions.
I think excellent, Jibil. To start this show, I think it's a really unique presentations. Initially I started and told you two things. One is that how should I answer the gentle young man? What is my prognosis? And I said that ultrasonologists or radiologists started picking up nearly a decade back and started rather teaching us that you treat them. The main issue comes, the same gentleman, young gentleman asking me, what is my prognosis? Dr. Das, tell me, rather than telling all these things. So same thing if you look at WHO guidelines, when they see morbid obesity or obesity without a comorbidities, and patient comes to us, to you, with a fatty liver disease, MASLT, and you don't have diabetes, you don't have other disease, and WHO guidelines says you don't treat them. You don't prognosticate them that you are going to develop this, you are going to develop this. Don't create a panic over there. This may be those 18 to 25% patient who are fatty but fit and will not develop any disease, and they will go on having a normal lifespan, maybe 70 years, 80 years. So a person, young person or an adult or an elderly, coming to you with just a fatty pancreas given by a radiologist, how much to prognosticate, how much to go further and tell him or her on the first occasion you're meeting him or her in your OPD or in your clinic, what should he go? And that's the most important part of your talk.
Yes, sir. Very, very pertinent question. So, regarding the fatty pancreas, there are more unanswered questions as compared to the answered one. I would say there are no longitudinal large trials are there, or the studies, even observational studies are there, that let's say the patient has developed a fatty pancreatitis and fatty pancreas, what will be the prognosis over a span of 10 years. Whatsoever data I have showed there in a very dedicated form. Only one large study is available which was done in USA over a span of 10 years, where they have shown that the development of a diabetes increases much higher, but again it was a part of a larger trial. So in New Zealand right now the Cosmos studies are being conducted, where they are following all these patients in metabolic disease patients in a prospective manner for a long term. So as of now, whether let's say the patient has developed, again come to you for a fatty pancreas, the only thing you can offer is to have some amount of a dietary modification, lifestyle modification. Apart from that, there are no drugs as of now which has proven to treat. But except for that, if there are other comorbidities are there, then you need to control that comorbidities.
Any one more question? Anyone from the Dr. Kuna, Dr. Wenka, Ajay sir, Roop? Anyone from Dr. Mahapatra?
Yes, sir. Sir, as of now, only MRI, because, yes, sir, PDFF. Yes, sir. So, MRI, PDFF, all the studies, including the retrospective, they have also used the MRI, PDFF. If MRI, PDFF is not available, or if it is out of reach, then we can use a non-contrast CT scan, where they have compared the attenuation pattern of pancreas versus spleen, and if the ratio is less than 0.7, the studies have used it as a marker of a fatty pancreas. However, having said that, there are only 2 autopsy studies are available, where they have shown that the correlation of MRI, PDFF and the intrapancreatic fat is much higher with the MRI compared to CT, because having a pancreatic biopsy is again a very difficult, so there are not major studies are available.
Thank you, Jamil.
Thank you, sir. Thank you, everyone. Thank you.
So thank you, respected speaker and our honorable chairpersons, for the excellent session. Now we move forward to our next session. To chair this session, may I request Dr. Gautam Roy sir, Head Department of Gastroenterology, Biashing Hospital, to kindly come on the stage, sir. May I request Dr. Anirban Chatterjee, Senior Consultant Gastroenterologist, Woodlands Hospital, to please come on the stage. I also request Dr. Apurva Shiva sir, Senior Consultant Gastroenterologist associated with Fortis Hospital, Kolkata, to please come on the stage. And finally, but not the least, I also request Dr. Krishanu Bonik sir, Consultant Gastroenterologist, Liver and Gut, Kalyani, Nadia, West Bengal, to please come on the stage. Our speaker for this session, it's no introduction, he is Dr. Ajay Kumar, Director of Gastroenterology, associated with BL Kapoor, Max Super Speciality Hospital, New Delhi. Requesting chairpersons to please start the session.
It's an interesting session this afternoon. Fluid management in acute pancreatitis, the swinging pendulum. We all know how important fluid management is, particularly if managed well, and how it leads to better outcomes. Without wasting much time, Dr. Ajay Kumar, please.
Thank you, Mr. Chairman. Thank you, Dr. Konar and Dr. Sanjay, to give me this opportunity to be here. Well, acute pancreatitis management has always been a challenge. There is no single specific medicine which has helped to change the natural course of the disease. We have had a number of medicines, Tracelol, Lexapan, early statin, octreotide, somatostatin, but all of these have fallen off the track. The only thing which is considered to make a change in the natural course is the fluid management. So it becomes very important for us to understand the nuances of the fluid management in the patients of acute pancreatitis. There are a number of questions which are raised as far as the fluid resuscitation is concerned. I like to touch upon them one by one. First is, why should we do that? There are three major things that we need to know about acute pancreatitis. I've talked about the dynamic process, time-dependent illness, but I like to mention here that the hypovolemia, here it is secondary to two things, that is the microcirculatory dysfunction as well as the loss of intravascular volume, and there is both the pooling, redistribution of the fluid as well as the loss of fluid. Both the things are there. And this is beautifully shown in this diagrammatic presentation, that if you have local inflammation, leads on to the leukocyte activation, cytokine release of IL-1, 6, TNF, and leads on to oxidative stress. And this is something which leads on to the microcirculatory dysfunction, which leads on to the exudation of the fluid. And this fluid loss can be quite significant, and this also causes into systemic inflammatory response. And that this further leads on to the intravascular fluid loss because of ileus and GI losses, and also the increased capillary permeability. That this is something which happens, and this is something which leads on to hypovolemia and distributive shock and multi-organ failure. The point that is raised, that is the fluid variation is the same in mild or severe pancreatitis. Well, people believe that there is a difference because the cytokine release is not so much. But I'll address this question a bit later as well. Now, once we have understood the importance that the fluid loss is massive, and people say it can be up to 5 liters fluid may be lost here in the beginning. So question is, patients need fluid. Patient comes to us in the triage with shock, then obviously we start looking at it. The question is how fast you have to give it and when to give it. Outcome of this illness is influenced by promptness of intervention, and first few hours are important to prevent multi-organ failure, worsening of SIRS, and extension of necrosis. I think that's the most important thing that we need to look at. And now let's look at when to give, what is the evidence for us. Fluid saturation in first 48 hours varies between 1.5 to 5 liters. And it works more when there is a SIRS. And there is a study by Wandorf, which is a 340 patients versus 94 patients comparing early versus late fluids, and it says that surge is more common when you are giving it late, that is a 10% versus 23%, and so is organ failure, and more with the non-severe than the severe. So that actually indicated that possibly all types of severity of pancreatitis should receive the fluids. And those who do not receive 1/3 of cumulative 72 hours fluid requirement in first 24 hours have high mortality, and on the basis of which Gardner had published the first study of an aggressive fluid which came into disrepute later on, but of course now he's on board and writing editorial for the waterfall trial also. So when to give, I have shown what is the evidence and what are the current guidelines, whether you look at the American or look at Canadian. The fluid resuscitation is likely more important early in the course of the disease, that is within the first 24 hours. The practical problem that we face, at least at our tertiary care centers like ours, patients don't reach us within first 24 hours. So it is important for us to educate the physicians and who are the first contact doctors in the management of acute pancreatitis, that this particular aspect has to be reinforced. Now third question is what fluid to give. Now we all know that fluids are basically colloids or crystalloids. Briefly touch upon high molecular weight colloid, that is a hydroxyethyl starch. There's data available on that. Of course, there's data available on albumin, data available on combination of albumin with normal saline and so on. And if you look at the data on that, it's a very ringer versus starch, that hydroxyethyl starch has higher mortality and it has a higher risk for renal failure. And Martineau's meta-analysis showed it had a higher organ failure and higher serious adverse events. So HES, albumin and glucose-based fluids remain controversial with limited supporting evidence and potential risks. And now let's come on to the crystalloids. I like to see here that I like you to focus on saline, Ringer's lactate and plasmalite, the second and third and fifth one. If you look at the and you compare with the plasma's characteristics, if you look at this important thing, that saline, the biggest criticism of saline is the chloride, and the chloride level 154 is much higher than Ringer or plasmalite. And if you look at, the theory is, or the data evidence is, that saline causes hyperchloramic acidosis. Except for Japan, I've seen all the guidelines, almost all the guidelines have spoken against saline and spoken for Ringer's lactate. And there is a data available which I'll share with you right now. But I like to focus on another issue, that is the osmolarity. That though we have data on Ringer lactate versus saline, but we don't have much data comparing plasmalite, which has a much better osmolarity comparable to plasma. So theoretically, it should have the same outcomes or maybe a better outcomes than that. So the perceived advantages of Ringer over normal saline is that decreased hyperchloremia and regulation. It is also anti-inflammatory, regulation of toll-like receptor-mediated inflammation with a reduction of local inflammation around the pancreatic gland. And this is something which is a meta-analysis, most quoted one by Zoltol, though there's one meta-analysis come even this year and from China, and also shows almost the similar results. But that is it shows the odds ratio of the comparison with the Ringers, that in all the aspects like ICU admissions, local pancreatitis complications, that Ringer is better than normal saline. And if you look all around the guidelines, crystalloids are preferred, colloids can be harmful. Some people have advised that if albumin is too low, then you can add colloid or albumin at that stage. Ringer lactate or a balanced crystalloids preferred over normal saline. And there is an ongoing Waterland trial. After the waterfall, we have all heard Waterland trial, which in fact 2 Indian centers are also part of that. 41 centers, 15 countries, and 723 randomized patients. I think this year we should be looking at the results of this particular trial. Roop might be knowledgeable about what is the outcome of that trial, but that will probably give the final answer. But as the things stand today, we use ringer lactate. Now, that's the more difficult question. How much? How much when we talk about how much total fluid and what is the rate of infusion? Both the things are important. And first, let's be clear about when we are using the word of aggressive means 3 ml per kg per hour, moderate means 1.5 ml per kg per hour. Basically, debate is between aggressive and moderate, and of course, both preceded by a bolus. Now, this is, I think, the huge data on that, number of trials, meta-analysis, but I think this waterfall trial has given us a final answers, which is an international open label, goal-directed, randomized clinical trial, aggressive versus moderate fluid resuscitation. 18 centers from 4 countries. And that has shown us, one, that steady rate of initial resuscitation, that is 1.5 ml per kg per hour. So moderate, not the aggressive. And bolus of 10 ml per hour only if there are signs of hypovolemia. Now that's a difference between the current guidelines and what it shows. They have not given bolus to anybody except for this suspect there is a hypovolemia, then they will give. While the guidelines mention give a bolus followed by the steady rate of infusion. And careful clinical and hemodynamic monitoring during first 72 hours to avoid fluid overload. Because it has been clearly shown that the risk of mortality goes up if you are over-aggressive in giving the fluids, and that's the reason you need to be closely monitoring that. And even diuresis in patients with fluid overload in the first 72 hours is most likely beneficial and certainly not detrimental. Please, but remember one thing, this trial was actually terminated prematurely because the results were such that the ethics board did not allow them to continue, so they could not give the final analysis. But this is the conclusion, that is the early aggressive fluid resuscitation resulted in more fluid overload without improvement in clinical outcomes. So the guidelines, current guidelines across the board, different countries, societies, that you give bolus 10 ml per kg followed by moderately aggressive fluid of 1.5 ml per kg per hour. And as I've already mentioned, it has to be ringers, it has to be started within the first 24 hours and as early as possible. Then in whom, question is, do you give it in mild also? Most of the data talks about moderately severe and severe, but yes, some people believe that yes, because it will not give you time, it's a dynamic situation, you might as well give it in first 24 hours and then reassess the patient. But that's a point of, some people have talked about over-aggressive causing harm also, but I think in a mild, you are safe enough to go for a moderate resuscitation. Now, last question, how to monitor? You have, as I said earlier, it's a dynamic process, can worsen after initial presentation. So continuous monitoring and assessment of fluid requirement is warranted. And we know that hypoperfusion is bad, but we also know that hyperperfusion is bad. And how do we achieve the optimal? These are the criteria which I have mentioned here in none else but any critical care fluid shock patient. This is what is usually blood pressure, heart rate, capillary refill, respiratory rate, passive leg raising. So there's nothing very special about it. But the general goal-directed therapy, the target is mean arterial BP minimum 70, hematocrit to bring down to around 40 or less than 40, and urine output to achieve 0.5 to 1 ml per kg per hour. And question is, how do you monitor these patients? The invasive, no, we don't like to put central lines because these patients are already prone to infections. We don't like to do that. Always use non-invasive, and your all ICU residents should be competent, and you should have the equipment there to have IVC diameter and the lung ultrasound, and ultrasound based IV size measurement is the best way to monitor them. So I conclude my presentation by summing up that fluid resuscitation is necessary. Early the resuscitation, better the outcome. Crystalloids the ringer lactate is better than normal saline. Colloids only in small number of patients when albumin goes down less than 2 grams. Amount of fluid, total fluid in first 24 hours should be around 3 liters but never exceed 4. And rate of infusion is 1.5 ml per kg per hour. And you will monitor by checking the urine, hematocrit and CVP. And duration of resuscitation, most important, is the first 48 hours. So the only word of caution that when the patients have organ failure like oliguria or patient has associated comorbidity with the cardiac, then you have to be cautious. All these parameters will go haywire. Thank you very much.
Thank you, sir, for that illuminating talk, clearing some of the nebulous areas. It's a very controversial area. So the topic is now open for discussion. Any questions? Senior gastroenterologists in front. So Dr. Goenka.
Ajay, excellent talk as usual. So there was an article in Gastroenterology published about 3 years back which they said that paradoxically we should be more cautious in severe pancreatitis but can be more liberal in mild to moderate pancreatitis because the capillary leak is more when there is severe pancreatitis. So can we be more liberal in the relatively less severe acute pancreatitis?
No, the whole data that we discuss is predominantly in severe acute pancreatitis. In mild pancreatitis, the data is not there, but there is a thought process that it may be initial first 24 hours, which you consider as mild, it may turn out to be how hemodynamically it changes. So, is there any harm in giving adequate fluid to them? Answer is probably not. So, one can give, and especially the harm could be if you have aggressive fluid, this thing. But you are talking about moderate fluid, so that should be safe enough.
Any other questions, please?
Can we know what is the objective of waterfall trial as a follow-up the
water length?
Water length. AIG are the two participants.
AIG is not a part. I think SIDS.
Surat and Kalinga. Kalinga. No, the two Indian centers. One is Dr. Mehta and Kalinga.
So their goal is to, the results are not yet out. I mean, still I think they are doing some analysis, but they want to look at which type, is it ringer lactate or normal saline? So that's the main premise.
That's the type of fluid, type of crystalloid.
Results, I mean,
I think people are waiting. I think they should be out anytime. This is being, because more than 700 patients were recruited there.
Yes. Any other question from the audience? Okay. Thank you, sir. Thank you for a very nice and objective presentation. We close this session here. Thank you.
So thank you, respected speaker and honorable chairpersons, for the excellent session again. Now we move forward to our third session. To chair this session, may I request Dr. J.R. Mahapatra, Senior Consultant Gastroenterologist, Peerless Hospital, Kolkata, to please come on the stage. May I request Dr. Dilip Todi, Senior Consultant Gastroenterologist, Narayana Hospital, Howrah, West Bengal, to please come on the stage. I also request Dr. Joyanto Mukherjee, Senior Consultant Gastroenterologist, ILS, Salt Lake, Kolkata, to please come on the stage. And Dr. Shubhobroto Ganguly sir, Senior Consultant Gastroenterologist, Spandon Hospital, Kolkata, to please come on the stage. Our speaker for this session is Dr. V.S. Ravindra sir, Senior Consultant, Director of Gastroenterology, Fortis Hospital, Bengaluru. Requesting sir to please come and requesting chairpersons to please start the session.
Good afternoon. So our next talk is post-ERCP pancreatitis moving towards zero incidence. whether it is a practicable option or not, I think none other than Dr. B.S. Ravindra from Bangalore will be talking about this. Okay, Ravindra. Hi, Ravindra. You can start.
First of all, I would like to thank Dr. Sanjay Banerjee, Dr. Konar for organizing this wonderful single theme pancreatic update. I think the topic which is allotted is, are we going towards zero incidence in post-ERCP pancreatitis? It's like asking a question in air travel, are we going to have no accidents? I think that's what we all have very recently we saw, which is air travel is the most, they call the most robust travel what has been man-made thing. But even there we had very recently an accident. I think that's why zero incidence, I think that's an ideal thing what we can really look. Let me look at we all know what is post-ERCP pancreatitis. Anybody post-ERCP develops an abdominal pain, amylase goes to more than 3 times, or he needs a hospitalization, then we call this as a post-ERCP pancreatitis. Then I thought, what is the incidence which has been seen across? Peter Cotton in 1991, I think these were the doyens of ERCP at that point of time. They had a post-ERCP pancreatitis of 2% and mortality rate of 0.2%. And then Freeman and colleagues, they had a pancreatitis rate, it was in 1996, 5.4% mortality and then 0.1% of the 5.4% post-ERCP pancreatitis and 0.1% of mortality. That was our doyens who were there at that point of time. Dr. Nagi, Dr. Amit Mahadev, Dr. Goenka is here, Dr. Chandrasekhar, all these 4 people. That's the era of around 1990. And then let us look at this 2010 to 2020, what happened? That is, this was the largest study which maybe 1.2 million people in America, and then the post-ERCP pancreatitis rate was 4.5%. And then in 2015, what was the post-ERCP pancreatitis? 8% in Europe, 9% in Asia, and 13% in America. And then this is a very recent study which showed post-ERCP pancreatitis in 2022. In Japan, the issue is they put a stent without a sphincterotomy. That's why they have a post-ERCP pancreatitis rate of 20%. But if they had done a sphincterotomy, the post-ERCP pancreatitis rate was 3.9%. Means somewhere we are, the post-ERCP pancreatitis at this point of time, we are between 3.5 to 9.7%. Even today, we have 14% post-ERCP pancreatitis in high-risk patients. Nothing much has changed from 1977 to 2022. The severe pancreatitis rate is 0.5%, mortality rate is 0.1 to 0.7%. The only data which I could see is from 2022 from Dr. Puri's group. They had 17,000 ERCPs which were done, and pancreatitis rate, if you look at, we are all very clear, we are the best in ERCP across the world. Because the pancreatitis rate, everybody says ERCP pancreatitis rate is less in India compared to the West or America. This was around 1%. That means we are almost reaching towards, in India is almost reaching towards a negative, almost we are achieving that ideal thing. And then what are the factors which causes post-ERCP pancreatitis? This is very, very important to know whether we can achieve a zero incidence in post-ERCP pancreatitis. One is we have patient factors, second one is the procedure factors, and then the endoscopic factors. I think we are all very clear, the definitive evidence for a post-ERCP pancreatitis is somebody who has already, we are doing an ERCP for a post-ERCP pancreatitis, the risk is highest. Patient who is a female patient, that is highest risk. And then we have a suspicion of SOD. Once again, SOD is same. Female, young patient, non-dilates, normal CBD, normal pancreas, normal bilirubin, and end-stage renal disease. I think these are the suspicion of SOD. Means whenever you think you are doing an ERCP in a female, young patient, normal CBD, normal pancreas, normal serum bilirubin, that means you have a high risk for pancreatitis. Of course, end-stage renal disease is one more patient-related factor for post-ERCP pancreatitis. And what are the procedure-related factors during post-ERCP pancreatitis? I think we are very clear. We had a difficult cannulation. You have cannulated the pancreatic duct. You have injected the pancreatic duct. Then the chances that post-ERCP pancreatitis are very high. And one more thing is, if you are unable to clear the stone clearance, and then you have done a balloon sphincteroplasty in a native papilla without a sphincterotomy. I think this is very uncommon in India because we always do a sphincterotomy. And then pre-cut is once again a risk factor for post-ERCP pancreatitis. And then intraductal ultrasound, I don't think we are doing much now with the availability of good MRCP and endoscopic ultrasound in very small percentage of cases. Now, I think this is a very, very important papillas we should look. If you have a type 2 papilla, that's a small papilla, you have got difficult cannulation and 20% risk of pancreatitis. All this type 1, type 3, type 4, we have normal post-ERCP pancreatitis rate that is around 2%, 6% or 7%. But whenever you see this, I think we have to be careful. Such a pancreas, such a papilla, we have a higher risk of pancreatitis. And then coming to the endoscopist related factors, if you have a less experience, you will have more time and then more time to cannulate, and then you will have more post-ERCP pancreatitis. But this is a study from Europe. I don't think it's applicable in India because in trainees and non-trainees, the ERCP rate was similar, because in those countries, the person is just behind and then the moment there is a problem, they take it over. But in India, I don't think this study is not valid. And what is the rate of post-ERCP pancreatitis? If you cannulate in 5 minutes, you have got 3% to 4% post-ERCP pancreatitis. If you take more than 5 minutes, it goes to 10%. If it is more than 5 minutes with a PD cannulation, the risk of post-ERCP pancreatitis to the tune of 16%. And then normal CBD, if you just cannulate even going into a PD, you have got 4%. That's why you cannot make zero incidence. That's why I told there is less chance that will become zero incidence. And if you inject contrast, 8% post-ERCP pancreatitis. If you put a guide wire into the PD, you go up to 16%. If you both inject as well as guide wire, there is 22% risk of post-ERCP pancreatitis. And then how can we move towards a 0% pancreatitis? The best way is to avoid unnecessary ERCPs. The best thing is you do a good MRCP and EUS guided ERCP. I think this is a very good study from Japan which showed that now we are 4,000 gastroenterologists, we are around 2,000 endoscopic ultrasound instruments are there across India. This has shown if you do an MRCP, even do an MRCP, after that you do an EUS, still you can have 35% stone. That's why now it is the time we have to do EUS guided ERCPs rather than MRCP guided ERCPs. That's why, but MRCP was done and later on EUS was done, EUS was almost 100% in detecting CBD stones. That's why EUS has got an excellent sensitivity specificity for CBD stones, especially in acute pancreatitis. You do a EUS first followed by ERCP, 2/3 of your ERCPs will get cancelled. That's why especially in acute pancreatitis CBD stone, EUS guided ERCP is a must. I will show you a real life scenario in 2010 when we started endoscopic ultrasound. See, this is a patient with acute pancreatitis, a very good radiologist. He is one of the best radiologists of Tamil Nadu. And then he writes gallstone, CBD stone and pancreatitis. This patient was sent for an ERCP. Very beautiful image. No MRI can give this image like this. You have a dynamic image, no CBD stone. This patient didn't undergo a ERCP, and then the post-ERCP pancreatitis risk is very, very low. You avoid ERCP, unnecessary ERCP if you do EUS guided ERCP. And one more real life scenario, this was once again a patient, lower CBD stricture, sent for an ERCP, you do an EUS guided ERCP. I think everybody in the audience, they can just see it is a small tumor in the ampulla. Then this patient avoided an ERCP, this patient straight went for a Whipple's operation, and then an unnecessary ERCP is avoided. Now let me see what are the things we can do to go towards zero pancreatitis. The ASG, ESG, both they have given the guidelines. The most important thing at the moment is NSAID prophylaxis. That's what we should do. And then the rectal suppository, that is both indomethacin as well as diclofenac 100 milligram. This is mandatory. It is mandatory before we do an ERCP. And then if you do a pre-ERCP rectal NSAID, the chances of post-ERCP pancreatitis is 4%. But if you forget and give the NSAID after ERCP, the percentage goes to 8%. That's why just like PPI, we have to make it remember 30 minutes before your ERCP, put the over on suppository, that's the thing. Otherwise, the PEP rate goes by another 4% extra. And then, where should we not be giving this rectal NSAIDs? One is if there is an active peptic ulcer disease and renal insufficiency. These are the only two indications where we don't give NSAIDs before ERCP. And then if rectal NSAID can't be given, that's when this IV fluids which ESG recommends 3 ml per kg per hour during ERCP and 20 ml per kg per hour after ERCP, followed by 3 ml per kg per hour. But I think this is also a controversy which is there. But if you cannot give rectal NSAID, I think this is one strategy we can always use. And then suppose patient we cannot give rectal NSAID, fluids cannot be given, then there is still an option of sublingual nitroglycerin. This is the study from US core group which still advocates 5 milligram of nitroglycerin can still be given if you don't have an option of NSAID as well as IV fluids. That's when we can do. And then during intra-procedure, can we do something to achieve zero incidence? I think the ESG recommendations are very clear. Do a wire-guided cannulation, don't put contrast. I think in India, that's why we are the best in ERCP across the globe, because we don't inject and then we don't delineate. We are all good at ERCP with wire-guided and cannulation, that's the reason. I think the steps of ERCP, which is mandatory, stable scope, see the morphology, identify the orifice, plan the trajectory, avoid excessive trauma, start with a sphincterotome and O25 guide wire. I think that's the key. And then inadvertently, if you do a PD cannulation, then do a double wire guided technique or a transpancreatic biliary sphincterotomy. Means put the guide wire in, go to the left upper quadrant, put the sphincterotome there, you will achieve the CBD cannulation. And then what type of stents we should be using in preventing post-ERCP pancreatitis? I think very, very clear, 5 French stent, 5 centimeters. But even if you cannot cross the head, you put a 5 French stent, 3 centimeters. This is very, very important thing what we should always look into. And then the most important thing is after you put a PD stent, do an X-ray and then see that it has been removed, it has gone out, or remove it after 2 to 4 weeks. This is very, very important when we place a PD stent. And if cannulation fails, don't go on doing more than 45 minutes. Early pre-cut is the key that prevents post-ERCP pancreatitis, but it has to be an experienced endoscopist. That's very, very important. And then one more important thing to avoid post-ERCP pancreatitis is if you do a balloon sphincteroplasty, do a small EST, do a small sphincterotomy and balloon dilatation. It has to be it should not be more than 30 seconds. Do it only for 30 seconds. This is a very, very important concept. Biliary sphincteroplasty, if you are doing, do it for 30 seconds with a small sphincterotomy. If you do a balloon sphincteroplasty in a native papilla, just like the Japanese they do, you have to keep the balloon for 5 minutes. This is very, very important. If it is kept for 1 minute, the high risk of post-ERCP pancreatitis. And then always in India, it is a concept. We do a sphincterotomy before putting a stent. That's why our pancreatitis rate is 3% to 4%. Whereas in Japan, they don't do a sphincterotomy. That's why their post-ERCP pancreatitis rate is around 20%. And then suppose, what are the post-procedure prevention, what we should do? The best thing means, yes, even though we just saw Dr. Ajay Kumar sir told, the trials which have shown aggressive therapy is not more useful. Even the flight trial which has come has told that this fluid business may not work in ERCP. But still, when they did this trial, they found that the severity reduced. That's why ASG recommends if you can do a 20 ml bolus post ERCP followed by 3 ml per kg per hour for 8 hours, but not very ideal in Indian situation because we do ERCP and send them by evening. We don't keep them for 8 hours. It can be used in very high risk patients. High risk patients means patient has got a pancreatitis and then you are doing an ERCP. That patient will be there in the hospital. That's why you can do this strategy there. Or patient has already undergone a post-ERCP pancreatitis and then you are doing another ERCP, then you can use this strategy. I think this was the very famous waterfall trial which showed aggressive hydration didn't make any major difference. And then this is the FLUIT trial which showed that when they have used already rectal NSAID, when they give fluids, there was not much of a difference in post-ERCP pancreatitis. That's why the aggressive fluids, what we were thinking, start 500 ml before, 500 ml during, and 500 ml later, that may not work as per this trial. I think what can we do? I think finally can we do for near zero incidence of ERCP? First thing is avoid unnecessary ERCPs. CBD sludge, CBD microlith in your ERCP finding, if you do, that is an unnecessary ERCP what you are doing. And post-pancreatitis, patients has got a dilated CBD, LFT is becoming normalized, don't do an unnecessary ERCP there. That's when we end up with post-ERCP pancreatitis. And then which are the high-risk patients that we need to look? If you have a pancreatitis and then you are doing an ERCP, we have to be careful. Young female, normal bilirubin, normal CBD, that's the high risk for post-ERCP pancreatitis. I think it's time that we should do EUS guided ERCP rather than MRCP guided ERCP. because 30% ERCP gets cancelled when you do an EOS guided ERCP rather than MRCP guided ERCP. I think that's very, very important. All patients should get a rectal endomethacin 30 minutes before, just like PPI 30 minutes before, rectal endomethacin 30 minutes before. And then if NSAIDs cannot be given, then if wire guided cannulation is mandatory, and then if you cannot cannulate PD, or if you inject the dye, then please put a 5 French 5 centimeter stent. Even if you cannot cross the head, 5 French 2 centimeter or 3 centimeter stent is sufficient, it's good. And then pre-cut early, and then intra-procedural hydration. I don't think this is a controversial area, but probably this can be used if you have a ERCP with pancreatitis, ERCP in bile duct leak, ERCP in hilar cholangio, or ERCP in young patients. The new concept which has come in DDW, no more ERCPs for pancreas divisum. Only caveat Dr. Reddy told was, you have a pancreas divisum and you have got a cathepsin mutation, that's the only thing you should do ERCP. I think this is a very, very big trial which is going to make change in ERCP management. No more ERCPs for pancreas divisum, except in some genetic mutations. And no PD stenting in ampulectomy. This is due to big trials which may do, but with 20% serious adverse effects. Nano robots, what we are seeing, probably what Dr. Reddy told, which can happen in some time, they will go inside and then they will do, probably then we will have zero incidence. Otherwise, in 2025, zero incidence is impossible. Only thing it is possible is if you don't do any ERCP. Then only you can have a zero incidence. Zero post-ERCP pancreatitis experience is important rather than achieving zero ERCP pancreatitis. Thank you very much for your kind attention. This is our team. Salutation to the greatest guru.
Thank you, sir, for your excellent presentation. I think audience have a lot of questions, and any comments from Goenka sir? Unas sir.
Mentioned something that higher rate of perforation as compared to pancreatitis. That AS Puri experience you mentioned.
Yes. In fact, Indians had a higher rate of perforation rather than pancreatitis. Probably we are more aggressive. 1% pancreatitis rate is what is there in India, because this is a large 17,000 patients.
Sir, you have mentioned rectal NSAIDs is almost...
No, I think the mandatory rule is the moment you touch papilla, always put a NSAID, whether you are doing a stent exchange. In fact, we had ERCP stent removals had pancreatitis. One of our patient, when we removed a ERCP stent and then do a balloon sweep after that to confirm, patient had a very severe pancreatitis. That's why it is mandatory whether you do a stent exchange or stent removal, better put a NSAID which is very, very less expensive, put a stent and then remove. I think that's an idea which we should follow. Why to take unnecessary the risk?
Yes.
Even though we don't have a data at this point of time.
May I ask a question?
Yeah.
After how many cannulations of the pancreatic duct would you prefer to give a pancreatic duct stent?
I think the recommendations are very clear now. You have one PD cannulation or even PD, you have dye you have put. Better to place a PD stent. That's the thing what the literature is. But one cannulation and then one guide wire going inside, or even one this thing close, means at the end of the thing you put a PD stent. That's the best thing to do.
Sir, simple guide wire insertion into the PD, does it increase?
Yeah, see, even that's the whole concept which ESG mentions. One cannulation or even one the dye goes inside. That's I showed you. Without even CBD entering into the guide wire entering into the PD, I showed one of the study. The problem was 4%. Once you enter PD, 8%. Once you do put dye, 12%. Both 20%. That's why better put a stent once you enter the PD.
Dr. Ravindra, I think AI is helping us a lot to decide what we should do. In fact, Dr. Goenka has a lot of experience. I think, rather than me saying, I think Dr. Goenka will be able to tell us. AI is doing this pancreatitis, whether we can predict and go ahead like that, select patient.
What Kinshuk is talking about is an article which was published in GI Endoscopy early this year, which we collaborated with Johns Hopkins Hospital, and we have tried to develop an AI-based pancreatitis risk score prior to doing an ERCP. So there are 23 variables. So you enter which of the variables are present, it will give you a possibility of what is the risk of pancreatitis in this patient. And it also says that if you put a stent or you do an IV fluids or you do an NSAID, how the risk will be reduced. So this has been validated both by the investigators as well as outside, and seems to be coming up in a good way. to predict the risk of pancreatitis.
Yeah, I think that's a very good idea, but still we can means with all the AI, I think zero incidence is, I don't think it's impossible.
We're not talking of zero incidence, we are only talking of predicting.
Yeah, I think that's a good idea, because the app-based things will definitely help in a big way for.
And we also, the same group, looked at guide wire issue which we are talking about. So the previous concept was that opacification of the pancreatic duct increases the risk. But now with this study, we also published recently that even 2 entry of the guide wire into the pancreatic duct increase the risk significantly. So I think you rightly said that guide wire entry should not be considered as not increasing the risk. Even the guide wire entry without putting the contrast can increase the risk of post-ERCP.
Yeah, I think once PD entered, put a stent. That's the whole thing.
So the only, I would say that if your guide wire has come out, don't waste your time to negotiate again to put the stent. That may increase the risk rather than decrease the risk.
I think that was the big thing, especially that was the trial which DDW showed. Post-ampulectomy, people start trying and then start putting PD stents, and then that's when they ended up with lot of pancreatitis. That's why if you cannot enter PD, that's okay. But don't make one more attempt to cause post-ERCP pancreatitis.
I think there's a tendency of the technician. Once you find it is in the PD, they always try to pull it out. So you have to tell them, even if it is in PD, just stay there. I will put a stent.
Then leave it. Then if you have gone out and then come out, then better to leave it rather than putting one more go inside the PD.
So,
yeah.
And also for the type 3, they have done pre-cut papillotomy, revisiting pre-cut papillotomy really, upward, up to down. That is
I think, this was the
wonderful results with very low incidences of.
I think this was the very small, I think, but very difficult in these small ampullas, which can have 50% cannulation rate, because the chance that this is the papilla where even everybody will be very unhappy to do a PD, the pre-cut, because there is nothing to cut much here. Here you can do a very good cut, here you can do a very good cut, here you can do a very good cut. Even here, this is the type 2 papillas. When you do a pre-cut, there is a high risk that we end up with pancreatitis, because there is nothing much to cut here. It's already, it's very, very dangerous situation where we are in.
So thank you, sir. Due to time constraint, we are concluding the session here. Thank you very much for your excellent presentation.
Thank you, sir, for providing your valuable insights, and also respected chairpersons. Now we move on to our next session. To chair this session, may I request Professor Moushumi Basu Madam, Head of the Department of Community Medicine, IPGMER Kolkata, to please come on the stage. I request Dr. Karamveer Chakravarti, Director and Senior Consultant Gastroenterologist, Woodlands Hospital, Kolkata, to please come on the stage. I request Dr. P.P. Bose, Senior Consultant Gastroenterologist, Peerless Hospital, Kolkata, to please come on the stage. And also Dr. Deepika Kedia, Senior Consultant Hepatologist associated with Kothari Medical Center, Kolkata, to please come on the stage. The speaker for this session needs no introduction. He is Dr. Mahesh Kumar Goenka, sir, but to go with the custom, it is my honor to read out his introduction. Dr. Mahesh Kumar Goenka is Director and Head, Institute of Gastrosciences and Liver Transplant Unit, and Director of Medical Education at Apollo Multi-Speciality Hospital, Kolkata. He is also the convener of Special Board of Medical Gastroenterology. He is a National Board of Examination. He was the former President of Indian Society of Gastroenterology and Society of Gastrointestinal Endoscopy Society of India. He is the current Editor-in-Chief of Journal of Digestive Endoscopy. He is also the recipient of Master Award for American College of Gastroenterology. So, requesting all to please stand out of reverence to Dr. Mahesh Kumar Goenka, sir. Requesting Mahesh Kumar Goenka, sir, to please come. Requesting Professor Moushumi Basu Madam to kindly felicitate sir with a shawl. Sir. Thank you, sir. It is our honor to have you as our speaker. So, requesting Dr. Mahesh Kumar Goenka, sir, to kindly start your deliberation, sir.
Thank you, everybody, and it's nice to see this pancreas update, which we started about 3 years back to gradually improve the stature. And we have a great gathering here. though it's a very brief meeting of half a day, but the topics which has been chosen are of real clinical interest. So my job to talk to you in the next few minutes is to talk about natural history and consequences of recurrent acute pancreatitis. When people like me and Ajay were doing our DM way back in 1988-89, we were told that pancreatitis have two aspects. One is acute pancreatitis and one is chronic pancreatitis. And there's no relationship between the two diseases. They are independent diseases and do not mingle with one another. We have come a long way in the last 30-35 years to understand the relationship between the two diseases, and that's what mainly I'm going to dwell in the next few minutes. So whenever a patient with acute pancreatitis is admitted to us, there are few questions which are asked by the patient and the patient's relatives. What will be the present treatment and the outcome? What are the chances of recurrence of this disease, and what will be the long-term consequences? They often say that will the pancreas become healthy again, or will there be some damage chronically for the pancreas? So let me just define for the youngsters the recurrent acute pancreatitis. At least two well-documented and separate attacks of acute pancreatitis with near complete resolution for more than 3 months in between the two attacks. That's the definition of acute recurrent pancreatitis. There is no confusion about it. There's a huge list of causes of recurrent acute pancreatitis. That's not the purpose of my talk, but basically they are toxic metabolic group, infections, mechanical, autoimmune, and miscellaneous group. And we have to also understand that if you've ruled all of them out, then only you call it idiopathic recurrent acute pancreatitis, if you ruled out all of those causes. So the idiopathic recurrent acute pancreatitis is gradually shrinking in its percentage. We have been a part of this apprentice group, and we are looking at the various etiology of acute and acute recurrent pancreatitis. This slide is only to show that geographical variations exist between the different parts of the world in terms of the etiology of acute recurrent pancreatitis. So the consequences of recurrent acute pancreatitis can be classified into development of chronic pancreatitis, development of diabetes mellitus. I'm sure this aspects there'll be a little overlap between the subsequent talk. Exocrine insufficiency, can it happen after recurrent acute pancreatitis? What about osteoporosis? And does recurrent acute pancreatitis increase or decrease the lifespan of an individual? So this is a slide taken from All India Institute group, which followed a particular patient, and this is when the patient had acute pancreatitis, acute recurrent pancreatitis, then chronic pancreatitis, same patient. So you see how nicely it has been described that an acute pancreatitis can progress to chronic pancreatitis, both as terms of ERCP as well as by EUS. So now we understand that there is a relationship between acute pancreatitis, acute recurrent pancreatitis, and chronic pancreatitis. This gives the summary, this slide, that if there are 100 patients with acute pancreatitis, 79 will have no further pancreatitis. 21 will have recurrent acute pancreatitis, and of that, 1/3 will develop chronic pancreatitis. So 1/3 of recurrent acute pancreatitis will develop chronic pancreatitis, and if you have 100 patients of acute pancreatitis, 8% are going to develop chronic pancreatitis, and remaining will have no progression to chronic pancreatitis. Age, severity of acute pancreatitis, duration has no relationship with development of chronic pancreatitis, but etiology, alcoholic more than biliary, and males more than females are likely to develop chronic pancreatitis. Now this is the natural history, a continuum for disease. So acute pancreatitis, 22% will have recurrent acute pancreatitis, 1/3, 35% from acute recurrent will become chronic pancreatitis, and a small percentage will develop pancreatic cancer. Now this is also interesting data which says that more the attacks of recurrent acute pancreatitis, more is the risk of chronic pancreatitis. So here, with the second attack, 1% risk, with third attack, 16% risk, with fourth attack, 50%, and that it plateaus between fourth and the fifth attack. So the risk of pancreatitis after the fourth or fifth attack is almost 50%. Now why this happens? This age-old SAPE hypothesis, not many people believe in this, but sentinel acute pancreatitis event, where there is sentinel event, necrosis, fibrosis sequence, there is aberrations in the repair or inhibition of inflammation leading to more episodes, there may be a continuing triggering factor, and all these lead to recurrent acute pancreatitis and finally chronic pancreatitis. This has been shown in the mouse model also, that if more the attacks of recurrent acute pancreatitis, there is more inflammation and then subsequent fibrosis which develops. So recurrent acute pancreatitis ultimately with multiple attacks, even in the animal studies, have shown to develop to chronic pancreatitis. So what is the relationship between genetics and development of chronic pancreatitis in patients with recurrent acute pancreatitis. There are two studies, one from India and one from Europe, which has looked at the relationship. The Indian study was done in children from SGPGI by Dr. Ujjal Poddar, and it shows that those who have genetic mutations, irrespective of what genetic mutations you have more chance of developing chronic pancreatitis. The other study actually showed that CFTR mutation does not increase the risk of acute pancreatitis in a setting of recurrent acute pancreatitis. SPINK1 in fact delays the development of chronic pancreatitis. So there is some contradictory data and more work need to be done in this situation. So that was about the first consequence, which is recurrent acute pancreatitis developing to chronic pancreatitis. Now let me now address to the second issue, which is diabetes of exocrine pancreas, DEP, or as we call it a type 3C diabetes mellitus. So just to classify, post-pancreatitis diabetes mellitus is called PPDM, post-pancreatitis diabetes mellitus, which can be acute pancreatitis or acute recurrent pancreatitis, which is called PPDM-A, and one which follows chronic pancreatitis is called PPDM-C. Of course, pancreatic cancer-related PDM is called PCRD, pancreatic cancer-related diabetes, and cystic fibrosis-related DM is called CFRD. So these are the various types of diabetes of exocrine origin, exocrine pancreas. Now, what is the percentage of these? If you have 100 patients with diabetes mellitus, majority, as we know, is type 2 diabetes mellitus. Small percentage, maybe 1 to 2% will have diabetes of exocrine pancreas and type 1 diabetes mellitus. If you look at diabetes of exocrine pancreas, majority followed pancreatitis. You see this color, which shows majority of post-pancreatitis, a small percentage is pancreatic cancer, and a very small percentage is cystic fibrosis related diabetes. If you look at post-pancreatitis diabetes mellitus, surprisingly, majority are following acute pancreatitis or acute recurrent pancreatitis, small percentage after chronic pancreatitis. It's because possibly we are seeing more acute pancreatitis than we see chronic pancreatitis, but this data is interesting. So this is a systemic review and large study which shows that increased diabetes mellitus compared to general population, the odds ratio is 2.1 to 2.54 in various studies. So definitely increased risk of diabetes mellitus. It is some of the studies show that it is not related to severity of acute pancreatitis, not a consistent finding, and this is not transient. It actually requires insulin on a long-term basis. So what increases the risk of diabetes mellitus after acute pancreatitis? This is a large study which shows alcohol-related pancreatitis, more recurrences, age more than 65 years, and male sex. These are the individuals who are more likely to develop diabetes mellitus after acute pancreatitis. Now, why acute pancreatitis leads to diabetes mellitus? These are some of the hypotheses: persistent low-grade inflammation in the pancreas, dysfunction of pancreas gut-brain axis, lipolysis of adipose tissue, insulin resistance, and loss of islets of Langerhans. All of them can be the reason behind development of hyperglycemia and diabetes mellitus after pancreatitis. Now, this is interesting, and I thought I'll share this with you. This is Perseus. This abbreviation has been I would say extracted out of this pre-diabetes self-assessment screening score after acute pancreatitis. So Perseus is a Greek semi-god, and this can be useful, and I think this is a menu for some of the DNB or DM thesis which can be done in our academic institutes, that after acute pancreatitis, using very simple data which are anthropometric, socio-demographic, lifestyle-related personal and family history, you can score the risk of development of acute pancreatitis followed by diabetes mellitus, and the score can go from 0 to 215, and a cutoff value has been found to be 75. So the area under curve is as high as 0.88, and if you want to prevent post-ERCP, post-acute pancreatitis diabetes mellitus, target can be smoking and obesity. So this is the variables which is used for Perseus score. The age, so more than 65 years, a score of 19 is given. Male sex, 7 score. Waist circumference, then look at the physical activity. Current smoker, 28 score. Use of antihypertensive medication, 27 scores. Etiology other than alcohol and biliary, 5 score, and so on. So this score can be used, and here the moderate pancreatitis and severe pancreatitis is also looked into. So a score of more than 75, as I said, can predict that these patients are likely to develop hyperglycemia and diabetes mellitus. So let me move on to some of the other things. Exocrine pancreatic insufficiency. We often say that after acute pancreatitis, there's nothing, everything will come back to normal, but it doesn't in all cases. So it may be a good idea to do a fecal elastase at least in these patients after a follow-up of few weeks, because some of them are going to develop exocrine pancreatic insufficiency. And this was a systemic review, 8 studies, 234 patients, not very large number, which found exocrine pancreatic insufficiency in 29% of the patients after acute recurrent pancreatitis. So a significant proportion will develop exocrine pancreatic insufficiency. We have a talk or a panel discussion shortly on PERT therapy, and I wonder whether we'll be discussing this also, whether after acute recurrent pancreatitis also PERT therapy has some role to play or not. So this also should be considered as one of the consequences. Osteoporosis has been reported after chronic pancreatitis, but has been reported also after recurrent acute pancreatitis. And in Taiwan, in 4,016 patients, the hazard ratio of osteoporosis was 1.27, and more the recurrent acute pancreatitis, more is the risk ratio. It goes to 4.8-fold if there are more than 3 attacks. And so this is also something to look at. Mortality is not increased after recurrent acute pancreatitis. After recurrent acute pancreatitis, the mortality is in fact decreased compared to acute pancreatitis because there is not much of an inflammation, there are more fibrosis, and so inflammatory response is less, and so the mortality is less for recurrent acute pancreatitis compared to others. So last couple of slides, I'm saving some of the time for Sanjay. Preventive strategies. What can be the preventive strategies? As we know, preventions can always be primary, secondary and tertiary. When we talk about primary prevention, it's the general population who develop acute pancreatitis. Secondary prevention will come after acute pancreatic episode or recurrent acute pancreatitis or chronic pancreatitis, and tertiary prevention will be to prevent and control diabetes mellitus, exocrine pancreatic insufficiency and osteoporosis. So we need to work at all the 3 levels, and gastroenterologists will play an important role for the education for primary prevention, judicious use of drugs, avoiding heavy alcohol. Secondary prevention again will include proper treatment of acute pancreatitis, removal of known etiology, and tertiary will be to take care of PPDM, EPI, and development of chronic pancreatitis, and of course pancreatic cancer. So all these are preventive strategies for the consequences of recurrent acute pancreatitis. So measures which are easily reversible are stopping smoking, alcohol, microlithiasis to be taken care of, colorectal cyst, hypercalcemia, hypertriglyceridemia, ampullary tumors, pancreatic tumors, and AIP2. All these should be treated to prevent recurrent acute pancreatitis and consequences of this. To summarize, ladies and gentlemen, acute pancreatitis and recurrent acute pancreatitis and chronic pancreatitis are a continuum process. This is different from what we were taught in our DM days. Around 30% of recurrent acute pancreatitis can progress to chronic pancreatitis. Other sequelae of recurrent acute pancreatitis include PPDM, exocrine pancreatic insufficiency, and possibly osteoporosis. There is a need to have a preventive framework. There is a knowledge gap for understanding of pathogenesis and impact on pharmacotherapy. Thank you very much.
Wonderful summarizing recurrent acute pancreatitis and chronic pancreatitis as usual. And we will now ask questions. If there are any questions for the chairperson, for the speaker or chairpersons, you can kindly ask.
Yes, Jaideep.
Most of these cases are not that severe. You can at home itself. If you develop such situation, take 2 or 3 IV fluids and some NSAIDs rectal.
I can't hear you. Can you repeat your question?
Can you advocate domiciliary treatment instead of admission, even for a short duration?
For acute pancreatitis?
Or recurrent acute pancreatitis? Because most
I think
of
this
them
is
are not severe.
This is a question which Ajay would answer better because with his talk. But I would say no patient of acute pancreatitis should be treated at home, because as Ajay told, first 24 hours may not tell you what severity it is going to develop. You need to watch these patients for some days. So I'm not comfortable in treating any patient with acute pancreatitis home. This is in contrary to GI bleed. GI, we use various scores and say that this patient can go back from home from the emergency itself. But I don't think acute pancreatitis should be treated at home. Maybe we can keep them in the general ward and watch them for some time, and then if the patients become stable, you send them home or the patient goes to the ICU. Do you agree, Ajay?
Oh, yes, absolutely, absolutely. Mahesh, as usual, very elaborated, very clear messages. There are a few questions. I mean, this is one disease entity which I think there are a lot of unanswered questions still. And my question is that after the first episode of acute idiopathic pancreatitis, are there any predictive factors that patient will behave like a recurrent pancreatitis? Because you see a lot of young children with the acute pancreatitis of unknown etiology and keep on coming back. And do genetic studies, second question, genetic studies help us in changing the natural history, or of course they will help us in family guidance, but do they change the natural history or any treatments in the pipeline?
I just come to you the second question first. I think I mentioned in one of the slides 2 studies which have been shown. One from Ujjal Poddar in SGPGI, which says that anybody having any genetic mutation, and they've clubbed all genetic mutations in one, which is possibly not correct, will have a higher chances of developing chronic pancreatitis. Whereas the other study from Europe has shown that those who have CFTR mutations, they do not have increased risk of chronic pancreatitis, but those who have SPINK mutation are actually protected and they may not develop chronic pancreatitis. But I think these are early days and we need to have more data to validate these, whether the relationship of genetics with this. About your first question about at the end of the first attack, can we describe? I think it's very difficult at this moment. The only thing which has been seen is that those who are smokers, those who are obese, male, alcoholic etiology, are more likely to have recurrent acute pancreatitis and more likely to have all the consequences. But I think, again, we need to have more data. So this talk of mine is more thought-provoking, and I think more work can be done, and it also gives us an opportunity to do more research work related to this.
Dr. Goenka, there is just one question. In our country, most of the, at least in recent times, most of the acute pancreatitis which we are getting are related to alcohol. So there is an argument which was also there before, that chronic pancreatitis already existed before the start of the first episode. So in these cases, should we screen for chronic pancreatitis even during the first episode?
I would agree with you that when there is an alcoholic pancreatitis and is coming to you for the first time, if you evaluate, a significant patient of them will already have an underlying chronic pancreatitis. But this may not be shown in MRCP. You may have to do an EUS because the parenchymal changes will be seen on EUS, will not be seen on the MRCP. But having said that, you have to also understand that any disease will start sometime. So alcoholic pancreatitis also must have started sometime as the first attack of acute pancreatitis, which may have been mild. So while you should investigate these patients for already existing chronic pancreatitis, if they do not have chronic pancreatitis, they are likely to develop chronic pancreatitis over the period of time. Alcoholics are more likely to develop than biliary, as we all know.
Sir.
Yes, Jamil.
Yeah, excellent talk, sir. One comment is that in our routine clinical practice, what we have observed that this kind of RAP, when we do EUS, they actually having, they usually have early signs of a chronic pancreatitis. So early chronic pancreatitis is usually very difficult to differentiate from a recurrent acute pancreatitis only on a clinical basis, and you need EUS to differentiate whether the patient has already developed the chronicity or not.
I think very important point, Jamil, you have raised that we stay in a tropical country, and it has been shown that even in normal individuals who never had attack of pancreatitis, if you do an EUS, you'll find some of the criteria of in the parenchyma, 3 criteria may be still positive. So they never had pancreatitis also. So I think we need to develop our own criteria for diagnosing underlying chronic pancreatitis in this setting. And just looking at 1 or 2 changes in chronic pancreatitis in EUS may not be the correct way, because some of these changes are already existing in the general population.
Yeah, because the revised Japanese criteria for early chronic pancreatitis, initially in 2012 they did not include the clinical features. Now they have also included the clinical features that the early chronic pancreatitis can also present with recurrent episodes of pain.
Agreed.
So
agreed.
In that scenario, it becomes overlapping with the recurrent acute pancreatitis.
So the idea is only to say that there is all intermingled.
Yes,
I think there is not clear margin between acute pancreatitis, acute recurrent pancreatitis, and chronic pancreatitis.
Yes.
Hi, because of lack of time, we've been asked to close this session.
Thank you.
So I think any other questions have to be asked during tea time. Thank you.
Thank you very much.
So thank you. It was our pleasure to have Dr. Mahesh Kumar Goenka sir among us, and also thanks to our respected chairpersons. Now we move on to our next session, which is on diabetes and pancreatic diseases. To chair this session, may I request Professor Shamor Banerjee sir. He needs no introduction. He is father figure in field of medicine and diabetology, currently associated with Vivekananda Institute of Medical Sciences, Kolkata. Requesting sir to please come on the stage. I also request Dr. Ononno Chattopadhyay, Senior Consultant Internist, Asian Institute of Immunology and Rheumatology, Kolkata. Requesting madam to please come on the stage. I request Dr. Joyita Bhaumik, Associate Professor, Department of Gastroenterology, AIMS Kollani, to please come on stage, and Dr. Kaushik Munshi sir, Professor, Department of Medicine, associated with KPC Medical College, Jadavpur, to please come on the stage. So, requesting chairpersons to start the session. Our speaker for this session is Dr. Sunil Dadhit sir. He needs no introduction. He is Professor and Head, Department of Gastroenterology, Jodhpur Medical College, Rajasthan. Over to you, sir.
Good afternoon. We all know how pancreas produces diabetes, but at times pancreas itself gets a victim of diabetes. To know in detail, we have with us Dr. Sunil Dadhit. We welcome you, sir. He will speak on diabetes and pancreatic diseases.
Thank you. At the outset, let me thank Dr. Sanjay for giving me this topic. And the topic was given to me for the first time. I think I read this, diabetes and pancreatic disease. I think diabetes is because of pancreas. So I thought I'll change the title and change this to diabetes of exocrine pancreas rather than the endocrine pancreas. This confusion is not recent. This confusion is there since ages. Earlier it used to be called as a pancreatic diabetes or a pancreatogenous diabetes, and then the ADA called in 2002 it is a type 3C diabetes, merely because it was present at the type 3 and the C location, and nothing else was the science behind it. Later, this group sub-classified this type 3C pancreatogenic diabetes into congenital, acquired, paraneoplastic and other. Acquired is the most common, and chronic and acute pancreatitis, and the paraneoplastic is pancreatic cancer associated diabetes mellitus. But as Dr. Goenka said, the recent and most widely accepted classification is diabetes of exocrine pancreas, and predominantly it has got three components: post-pancreatitis diabetes mellitus, which is due to either an acute or a chronic episode of pancreatitis, pancreatic cancer related diabetes, and the cystic fibrosis related diabetes. And he already told us the frequency of occurrence of type 3C, which is uncommon if you talk about the all patients of diabetes, but there is a significant overlap between the type 2 diabetes and the type 3C or a diabetes of exocrine pancreas. And among the all patients of diabetes of exocrine pancreas, it is the post-pancreatitis diabetes which is predominantly more common, and among them, as the acute, as Dr. Goenka said, is more common than with the chronic. The second most common cause of diabetes of exocrine pancreas is pancreatic cancer. So I'll restrict my talk to diabetes of post-pancreatitis as well as and the pancreatic cancer related diabetes. Recently, WHO also has classified diabetes type 1, 2 and the other specific types. In another specific type, they have described the diabetes of exocrine pancreas. And again, there are various subtypes. So coming to the diabetes due to acute pancreatitis, this is the most important slide. Whenever a person, adult, comes to you with a history of diagnosis of pancreatitis, if he has A1C more than 6.5, a high fasting glucose, the first thing is to go for autoimmune markers. If they are positive, he has type 1 diabetes mellitus. If the autoimmune markers are negative, if there is no overt, there is no past history of diabetes prior to the onset of pancreatitis, or he develops a diabetes like abnormal A1C in the high glucose within 3 months of onset of diabetes, onset of pancreatitis, then it is type 2 diabetes mellitus. Means diabetes existed prior to the occurrence of acute pancreatitis, and within 3 months there is an unmasking of the type 2 diabetes after an episode of acute pancreatitis. And if he just develops a hyperglycemia and no A1C level rise within 3 months, it is just a stress hyperglycemia. And if everything whatever above is not there, and he develops abnormal A1C, high glucose after 3 months of onset of acute pancreatitis, then it is labeled as post-pancreatic diabetes mellitus, or it could follow a acute episode or a chronic episode of pancreatitis. So the spectrum of dysglycemia in patients with pancreatitis varies from stress hyperglycemia to unrecognized diabetes to a new onset of diabetes. So why does diabetes develop in patients with acute pancreatitis? There are various theories. The commonest theory is acute necrotizing pancreatitis leading to loss of beta cells, leads to insulin deficiency, and as a result of pancreatic necrosis or surgical necrosectomy or a percutaneous drainage, there is a loss of these cells, and that leads to pancreatitis. But diabetes does develop in patients who do not have non-necrotizing pancreatitis. So there are other factors as well, and the role of autoimmunity plays a very important role. Because of inflammation, necrosis, there is induction of autoimmunity which selectively destroys these islets of Langerhans. So there is a loss of beta cells, there is a local inflammatory response. This triggers the genetic susceptible. In genetic susceptible patient with autoimmunity, IL-6 leads to insulin resistance, and there is a lipolysis and various many other factors. Even the animal studies have confirmed there is a loss of islets of Langerhans in patients who develop diabetes following the acute pancreatitis. So it is a multifactorial with loss of beta cells, islet cell mass. And one thing is very important, you see, there is insulin secretion reduction, and then at the same time there is a insulin resistance. So this pathogenesis of post-pancreatitis diabetes mellitus has got both components, loss of insulin as well as the insulin resistance. So it has a unique feature of hyperglycemia, hypoglycemia event, because when there is a loss of islets of Langerhans, both beta, alpha and other hormone secreting cells are lost. So there is no compensatory increase in glucagon when they develop hypoglycememia. So it is called a brittle diabetes, and there is an increased requirement of insulin, especially early in the course of disease, and there is a decreased risk of diabetic ketoacidosis because there is no glucagon response, and it has got associated exocrine insufficiency. If you treat the PEI in these group of patients, there is improvement or the better control of diabetes mellitus in these group of patients. So how common it is? Initially the PPDM was thought to be transient phenomenon, but this meta-analysis published in 2014 cleared everything out. 24 studies, around 1,000 plus patients, first episode of acute pancreatitis, pooled prevalence around 23%. So after the first episode of acute pancreatitis in a large majority of patients followed over the period, most of them developed around 1/4 of them developed diabetes mellitus, and this risk increased exponentially over the period after the pancreatitis occurrence. Means at the end of 5 years the risk is 2.7%. Another meta-analysis, very large, 1131 studies, around 13,000 patients, the risk is 23%. So the natural history of diabetes mellitus after an episode of pancreatitis, as the duration goes, the risk, the prevalence increases. In first year it is around 15%, at 5 years it is around 40% of them will develop diabetes. So the natural history, all patients of acute pancreatitis, some of them will develop stress-induced hyperglycemia, and very few will develop the diabetes mellitus. So what decides? Who decides who will develop diabetes and who will not develop diabetes? So it is the risk factor of diabetes mellitus. There is a large study, a meta-analysis, 50 studies, 76,000 plus patients, and they studied 34 risk factors which can predict the occurrence of diabetes following an episode of acute pancreatitis. This is a complex forest chart. I just summarize it. The odds of having diabetes post-pancreatitis significantly higher in patients who had significant pancreatic necrosis, who had moderate to severe acute pancreatitis, hypertriglyceridemia, organ failure, CKD, liver cirrhosis, recurrent AP, obesity, alcohol as the etiology, and dyslipidemia. So all these are the risk factors for the occurrence of post-pancreatitis diabetes mellitus. If you summarize all the risk factors, it is common in males, common in younger age, recurrent acute pancreatitis more common, exocrine insufficiency more common, severity, necrosis, and other factors are deposition of fat after the acute episode of pancreatitis, obese people, dyslipidemic people, people who are having family history, fatty liver, smokers, who underwent surgical necrosectomy or a percutaneous drainage due to a peripancreatic collection, they are at risk of developing post-pancreatitis diabetes mellitus. This is an interesting study, association between the glycemic status and the risk of pancreatitis. So they studied the population figures into 2009, around 42 lakhs patients, and they followed them up to 2018. And look for those the patient who developed acute pancreatitis. So the risk of developing acute pancreatitis was higher in patients who had diabetes mellitus, and this risk was very commonly like exponentially associated with the impaired glucose tolerance or the clinical diabetes mellitus. So the people who had diabetes mellitus, they are at higher risk of developing acute pancreatitis. Again, no diabetes, with diabetes, there is a high risk of developing, and with all complications, with higher grades of blood glucose levels, there is an increased risk of developing an episode of acute pancreatitis. So the glycemic status worsens, the risk of acute pancreatitis increases. So acute pancreatitis and diabetes mellitus has got bi-directional relationship. That means you have an acute pancreatitis episode, you are more likely to develop diabetes mellitus. If you already have diabetes mellitus, you are more likely to develop an episode of acute pancreatitis, and there are various theories which are put forward to explain this hypothesis. It's another very interesting study, a population-based study, and there is a large number of patients included. They divided all patients who had diabetes into two groups: diabetes without prior pancreatic disease and diabetes with a prior diagnosis of pancreatic disease. So they followed them all, diabetes with pancreatic disease, diabetes without pancreatic disease, and the requirement of insulin was much higher in patients who had diabetes and pancreatic disease, and also the other complications. I just summarize it. So diabetes of exocrine pancreas is more likely as compared to type 2 diabetes to require insulin therapy, to develop hypoglycemia, to develop all kinds of macro and microvascular complications, and they have higher all-cause mortality. So if you have diabetes, if you have pancreatitis, a history, then it is more severe compared to the type 2 diabetes mellitus. So whom to screen for diabetes after an episode of acute pancreatitis? There are no clear-cut guidelines, but ideally all patients should be screened within first year, more frequently, every 6 months. HbA1c should be done, and then subsequently you can do it on annual basis. How to manage? It is very difficult to treat. Baseline A1C is higher than those of type 2 DM, and they require the higher doses of insulin and higher requirement of insulin in these group of patients. Metformin remains the best drug in these group of patients because of reduced risk of hypoglycemia, reduced risk of pancreatic malignancy, and the better outcome. But the other compounds like OHA, the incretin-based therapies like GLP-1s and DPP-4, they itself can precipitate acute pancreatitis, should be avoided. Sulfonyl ureas, they can be used in association with insulin as insulin sensitizing drugs, but the SGLT2 inhibitors should be avoided in these group of patients. So overall, mild diabetes up to less than 8 HbA1c level can be treated by oral drugs. Otherwise, most of them will require insulin for the management. Coming to the second part, post-pancreatic diabetes mellitus due to chronic pancreatitis, just few slides. In a meta-analysis, the new onset of diabetes after chronic pancreatitis, 15 studies, around 9,000 patients, the incidence of new onset diabetes is around 30% following chronic pancreatitis. Again, this risk increases as the duration of pancreatitis increases, same as that of acute pancreatitis. This is a very interesting study. The people looked at the factors which can predict which CP patient are at a greater risk of developing diabetes mellitus. So they looked for all the factors, concurrent DM, pre-pancreatitis DM, post-pancreatitis DM, and they found that people who had pancreatic features and the risk factors for diabetes, they are at high risk of developing diabetes following the chronic pancreatitis. So the risk factors could be a surgical resection of distal pancreas, age, duration of disease, smoking, calcification, male sex, and the family history of diabetes mellitus. Again, patients with chronic pancreatitis are at greater risk of developing pancreatic cancers, and the pancreatogenic diabetes mellitus with chronic pancreatitis is a pre-malignant state. So in a patient who have post-pancreatitis diabetes mellitus, he is high risk of developing pancreatic cancer. Coming to the last part of my talk, pancreatic cancer-related diabetes mellitus. In an initial study by Suresh Chari et al., published in I think 2001 in gastroenterology, they did the experimental study in all patients who had pancreatic cancer, acute and chronic pancreatitis, and they found that people who had pancreatic ductal adenocarcinoma, there was very high prevalence of diabetes mellitus, and this diabetes mellitus was new onset in most of them, and there is a significant weight loss in these group of patients. Subsequently, the same group did a population-based study around 2,000 patients, and they found that the patients who had higher age and diabetes are more risk of developing and the odds of them having pancreatic cancer was much, much higher compared to the expected ratio of them having pancreatic cancer. And they defined the clinical red flag signs in new onset diabetes that put a person at high risk of developing pancreatic cancer: unintentional weight loss with hyperglycemia, lean or normal body BMI at the diabetes onset, a rapid requirement of insulin, and the concurrent epigastric pain. How to differentiate between pancreatic cancer-related diabetes mellitus and the type 2 DM? It is very, very important as far as the clinical practice is concerned. Type 2 DM starts at the age of 40 and 50s, whereas pancreatic cancer-related diabetes mellitus starts after the age of 50 years, mostly at the age of 60 years. And there is a weight loss paradox. This is very important. A patient with type 2 diabetes mellitus, if he loses weight, the diabetes becomes better controlled. As against a patient with pancreatic cancer-related diabetes mellitus, he will lose weight because of cancer. At the same time, diabetes will worsen. So this is a paradox you need to understand very carefully, and there are other differences by which you can differentiate between these two categories. The epidemiology in a large meta-analysis, 88 studies, around 27,000 patients. The risk of having cancer is more in patients who are diabetic. Duration of diabetes, recent onset of diabetes, highest risk among the absolute number. Last few slides. Every increase of 10 milligram of fasting glucose adds to 14% relative risk increase in patient of developing pancreatic cancer. In the Indian trial, I think around 2,000 patients, new onset diabetes was very common in all patients who had pancreatic cancer. So diabetes, pancreatic cancer is a diabetogenic state. Diabetes associated with pancreatic cancer is predominantly new onset, and following surgery for pancreatic cancer, there is a resolution of diabetes mellitus. This is the study by Suresh Chari group, a patient who developed pancreatic cancer, and they looked for the last 5 years what has happened to them. So those who developed pancreatic cancer, 5 years ago they started having hyperglycemia, they started having a new onset of diabetes. So the disease goes as back as 5 years prior to the onset of cancer. And they proposed the various theories. The predominant is humoral diabetogenic factors are secreted by the pancreatic cancer cells, and that leads to diabetes mellitus. If you remove the tumor, everything comes back. So how to screen them? A person who has come to with diagnosis of diabetes mellitus after the age of 50 years, look for new onset diabetes. If it is present, then always screen them for the presence of malignancies by either CA19-9 level or by doing CT scan or endoscopic ultrasound. Last very interesting study, nationwide nested control study. They took all types of patients of pancreatitis, post-pancreatitis, diabetes mellitus, type 2 diabetes mellitus who developed pancreatitis, patient who had only pancreatitis, patient who developed only type 2 diabetes mellitus. So the patient who developed post-pancreatitis diabetes mellitus, the risk of development of malignancy is 4 times. If PPDM patient had a shorter duration of diabetes, the risk is 8 times. Again, if they require insulin, then the risk is 17 times. So the development of post-pancreatitis diabetes mellitus is a killer as far as the development of malignancy is concerned. Among the drugs, metformin is the only drugs. Insulin should be avoided in this group of patients because insulin induces IGF-1, which is mutagenic and mitotogenic and aids to the further progression. So ladies and gentlemen, to summarize, post-pancreatic diabetes mellitus is increasingly being recognized as a long-term sequelae of the disease of exocrine pancreas. After an episode of acute pancreatitis, it is a distinct clinical entity, different mechanism, different natural history compared to type 1 and type 2 diabetes mellitus. Necrosis, fibrosis involves both exocrine and endocrine pancreas and all cells of endocrine pancreas, so it makes it a brittle diabetes, difficult to control. There is a bidirectional link among all phenotypes, and new onset diabetes plus weight loss, the risk of pancreatic ductal adenocarcinoma is very high. These patients require a close follow-up, especially patient who develops post-diabetes, post-pancreatitis diabetes mellitus. The risk is again very high. Metformin is the only oral compound which is very effective in this group of patients. Insulin is the mainstay of therapy as far as the post-pancreatitis diabetes mellitus is concerned, but insulin should be avoided in pancreatic cancer-related diabetes mellitus. Thank you very much.
Any question from the audience or any comments? Sir, you want to add anything? Any question from the floor? So thank you. Just I want to pass few questions that routinely do not go for screening the pancreas at the very beginning of the diagnosis of type 2 diabetes. We go for the non-alcoholic fatty liver disease or different term, whatever you use, that is very predominant. But data are upcoming that probably we'll have to think of screening the pancreas at the onset of the diabetes and from time to time. Acute pancreatitis well accepted, chronic pancreatitis well accepted, and pancreatic carcinoma can happen from diabetes, and diabetes itself can lead to the development of the pancreatic carcinoma. The risk factors for all three have been discussed, that is diabetes. The main factor for diabetes is the insulin resistance, then obesity, then hypercalcemia, then hypertriglyceridemia, then another important is also alcohol and smoking. So try to avoid these factors in cases of type 2 diabetes with pancreas. I want to learn from learned gathering whether at onset every type 2 diabetes should be screened for pancreatic disorder or not. That is not at the present moment routine. But I just like to differ from the speaker that he is repeatedly telling don't give insulin in pancreatic cancer. I accept metformin is the drug of choice. Second drug of choice is pioglitagen, which will lower the blood sugar, also suppress the IGF-1. Small dose voglibos can be used if there is no gastric disturbance. But in cases of pancreatic cancer or post-pancreatitis, the blood sugar remains very high. I accept insulin is carcinogenic, but if the blood sugar is very high, we have no other option. Sulfonylureas should not be used, gliptin should not be used, GLP-1 should not be used. And if I keep the blood sugar level at high, accepting that insulin is carcinogenic, then the carcinogenic process and the diabetic process will be all aggravated. So after metformin, after pioglitagen and voglibos group of drugs, if blood sugar is not controlled, we will have to, I think, use insulin. Better insulin, newer insulin like degludec, aspart are less carcinogenic. There are data with us. They are less teratogenic than the older like the NPH insulin, etc. Ultimately, we will have to control the blood sugar coming down. Thank you for your present hearing.
I think, sir, the insulin analogs are better compared to the insulin alone.
Aspart and degludec long-acting is better in terms of carcinogenesis. But what I believe, if I cannot lower the blood sugar, it remains 400, 500. Then the hyperglycemia induced risk factors like the lipidotoxicity, the insulin resistance, etc., TNA, PALPA, interleukin 6, and multiple factors will aggravate the malignancy also. So we will have to balance between this. Use the higher, newer synthetic insulins, which are least carcinogenic, least hypoglycemic. Actually, we are also merging towards the degludec and aspart or its combination. Thank you.
Thank you, sir.
But any comment from you, sir, regarding routine screening of pancreatic function at the diagnosis of type 2? Routine.
Sir,
we go for lipid, we go for kidney, we go for the liver now, routinely.
Actually, it depends upon the age of onset of diabetes mellitus, sir. So what I was emphasizing upon is, if the onset is in the elderly, like 50 plus or a 60 plus age group, a new onset of diabetes at that point of time without a family history, then you should suspect underlying malignancy in development. So they should always be kept under regular follow-up, and they should always be screened on regular basis regarding the development of pancreatic cancer.
Thank you. Madam, anything to comment?
It's excellent talk. It is quite understandable that pancreatitis is followed by diabetes, but is there any reason why the diabetic patient is more prone to have pancreatitis?
Because they also have the risk factors for pancreatitis, like in the form of they are obese, they have metabolic syndrome, that again is a risk factor for development of acute pancreatitis.
Okay.
So there is a bi-directional relationship between.
I think it is not very common, no? The diabetic patient developing pancreatitis. Is it very common?
They are more common to have because of fatty liver, gallstone, so they can have more gallstone-related pancreatitis, and then because of metabolic syndrome and other,
Okay.
they are not.
Thank you, sir. Thank you.
Thank you. I declare this session to be closed. Thank you.
Thank you, our esteemed speaker and our honorable chairpersons for the excellent session. Now we move forward to our next session, which is on genetic testing for pancreatitis. To chair this session, may I request Dr. Srikanto Goswami, Associate Professor, National Institute of Biomedical Genomics, Kalyani Nodia, to please come on stage. I also request Dr. Bhashwati Acharji, Senior Consultant Pediatric Gastroenterologist, Manipal Hospital, Mukundapur, Kolkata, Dr. Ognivo Dotto, Consultant Gastroenterologist associated with Manipal Hospital, Broadway, Kolkata, and Dr. Debapratin Raut, Consultant Gastroenterologist from Charnock Hospital, Kolkata, to please come on stage and start the session. Our speaker for this session is Dr. Shondeep Pal, Senior Consultant Gastroenterologist associated with Narayana Hospital, Mukundapur, Kolkata. Requesting Dr. Shondeep Pal, sir, to please come on the stage and start your deliberation. Over to you, sir.
Good afternoon. This is going to be a very interesting session where Dr. Pal will deliberate the necessity of genetic testing in pancreatitis. So this will actually lead us to the personalized treatment and towards like more like precision medicine and accurate diagnosis of the disease and dissecting the hereditary component. So, Dr. Pal.
Yeah, thank you. First of all, I would like to thank Sanjay Da and Konar sir for this opportunity. So my topic is genetic testing for pancreatitis. Why, when, what and how. So this is not a very common topic that we discuss in our conferences. So it was tough for me also. So I will try. So let me start with a background. Genetics, as we know, is the study of genes. And genes are sections of DNA that are found inside every human cell. And each person has about 20,000 genes, and this DNA is tightly wrapped, as we all know, tightly wrapped together in structures called chromosomes. Now, these few terms are very important because whenever we read any article, we see SN, SNPs or polymorphism. So, what does this mean? So, single nucleotide polymorphism, it means a variation at a single position in a DNA sequence among individuals, where a single nucleotide is replaced by another, so which results in mutation. So again, mutations can be of two types, gain of function mutation and loss of function mutations. And according to this, the various diseases manifest. So now there are two types of diseases, so you always hear one is autosomal dominant and another is autosomal recessive. So autosomal dominant means, the gene is located on the autosome, and here the dominant means only one copy of the mutated gene is needed for the condition to be expressed. So if we see this, if a parent has a mutated gene, there is a 50% chance that the child will inherit the gene and the associated condition. Similarly, autosomal recessive means, again this is autosomal, so the gene is in the non-sex chromosome and two copies of the mutated gene are needed for the trait or disorder to manifest. Now if you see the pancreatic diseases, hereditary pancreatitis is autosomal dominant, whereas cystic fibrosis is autosomal recessive. Now, how do genetic disorders happen? So, different things can happen. As I said, there can be mutation, a part of the chromosome can be missing, which is called deletion. Then genes can be shifting from one chromosome to another, which is known as translocation. There can be an extra or missing chromosome, or too few or too many sex chromosomes can be there. Now coming to pancreatic disease, now pancreas is a mysterious organ because see the pancreas is located in the body, deep inside the body. It's not accessible to physical examination. It is well protected from the environment and there is a retroperitoneal location and it is invisible to standard radiographic examination, doesn't have bone, and also biopsies are very dangerous to do in pancreas. Still we get pancreatitis which is very severe, and at times we all know acute pancreatitis can be life threatening and chronic pancreatitis has got a lot of comorbidities. So why still the diseases in pancreatitis occurs? This majority of these are associated with genetic polymorphisms. So I am trying to come to that. So if we see chronic pancreatitis, the first figure, this is a normal pancreas where you can see the purple parenchyma and you can see some grayish structures with the islets of Langerhans. Now as the chronic pancreatitis progresses, if you see the mild to moderate, it is replaced by a fibrosis, and in the severe form it is only fibrosis. Now, genetic testings, though these are not easily available everywhere, but these are very powerful tools that have been developed. If we can do it correctly in the correct patient, and because the results are 100% sensitive and specific for the detection of a specific DNA sequence. Now, if you look at the Mendelian disorders, now the Mendelian disorders, they have a clear defined inheritance pattern and are caused by a single gene and often present at birth and have unique, well-defined features. Now, these genes which are there in pancreas are the CFTR gene, which is responsible for cystic fibrosis, PRSS1 gene, which is responsible for hereditary pancreatitis, and SPINK1 for familial chronic pancreatitis. But the limitation of genetic testing in pancreatitis is 95% of the pancreatitis cases are not Mendelian genetics. And the most genes, they do not fit into the pathology based definition, and the reports are given by geneticists or pathologists who are not seeing the patient. So that this is the reason that we don't do genetic studies in all patients, or it does not correlate with the disease. Now, coming to the first question which Sanjay asked me to answer, why should we do genetic testing? Because it helps in identifying hereditary pancreatitis, it helps in risk stratification. We can identify genetic risk factors that allow clinicians to assess the likelihood of developing pancreatic cancer or chronic pancreatitis. And early intervention can be done. If we know that this patient has got for example, I will come later, cathepsin B gene mutation is there in a patient who has pancreas divisum, this patient can develop recurrent acute pancreatitis. So early intervention can be done. Personalized management can be done. If possible, family planning, it will help in family planning, and also improved understanding of the disease. And also it can help in differentiating idiopathic cases, and also as said, for monitoring and follow-up of the patients. Now, coming to when. So what are the indications of genetic testing? Not all patients will ask for genetic testing. So any patient who has got a family history of idiopathic chronic pancreatitis, recurrent acute pancreatitis, or childhood pancreatitis, relatives with known mutations which is associated with hereditary pancreatitis because this can lead to malignancy, unexpected pancreatitis in a child, idiopathic chronic pancreatitis in patients less than 25 years old, acute recurrent pancreatitis of unknown etiology, or patients who meet criteria for participation in research. So these are the usual indications when we should ask for genetic testing. Now, Ajay sir had asked one question in the last talk, like, how do you see, like, does this, if someone is predisposed, how does that help? Like, will genetics help us to determine? So if you see this figure, relative risk and the time here, so these two curves, if you see, the first one is the high risk. That means those group of patients who have genetic mutation. And this low risk means who doesn't have genetic mutations. Now the environmental factors are same for both these groups, but those group which has got genetic manifestation, they manifest as acute pancreatitis. So because the environmental factors, alcohol, biliary sludge, whatever may be the cause. So if these are same for both the groups, if only those patients who have genetic mutation, they will manifest the disease. So as this has been described, there are two hit model for pathogenesis of pancreatitis. First hit is of course the polymorphism in genes, and the second hit is the environmental risks, as the previous figure also explained. So there are various genes which has been studied. The most common are those three genes. Apart from that, there are calcium regulated genes, CTSB gene, CFTR, the claudin gene, and there are certain polymorphisms also. These are the various genes and the polymorphism which appears, which is present in the chromosome. And the genes, the at-risk genes can also be divided into assigner risk genes and the ductal risk genes, PRSS1, then SPINK1, these genes are responsible, the pathogenesis occurs in the acini, whereas the CFTR is, and the calcium regulated genes are, they are mainly the pathogenesis occurs in the ducts. So these are the various mutations, and similarly these genes have also been divided into disease causing and disease modifying. The PRSS1 is a disease causing gene, whereas PRSS2, 1 and 2 is a disease modifying gene. This is again the pathogenesis, like how these genetic mutations affect the pancreas. The PRSS1 gene, they affect the trypsinogen activity and the endoplasmic reticulum stress. Likewise, all genes have got their own pathogenic mechanism. Now, a little bit about the genes. I'm not going into the details. Trypsinogen has got 3 genes, PRSS1, 2, 3. And here the mutation that occurs is a gain of function mutation, and it is associated with hereditary pancreatitis. But in India, PRSS gene mutation is not associated with chronic pancreatitis. Now next comes the SPINK1 gene. It's an trypsin inhibitor and acute phase protein secreted by SNR cells, and this prevents premature activation of zymogen. So if there is a mutation, then premature activation of zymogen occurs and can lead to pancreatitis. And here the mutations cause a loss of function mutation, but the polymorphisms are generally weak and very few individuals with the mutation develop pancreatitis. Similarly, there is chymotrypsin C gene. It encodes chymotrypsin C, a digestive enzyme. It is also produced by the SNR cells in the pancreas. Again, the mechanism is with zymogen granules, and prematurely activated trypsin is destroyed by CTRC. So if there is a mutation, then this premature activation occurs. So these are the other genes. I am not going into the details of this. This is the cathepsin B gene. Then there is calcium sense receptor gene mutation, CFTR gene. The impact of CFTR gene mutation continues to be debated. There are variants in this gene that are strongly associated with pancreatitis. Almost more than 1200 mutations have been described, and the chances of pancreatitis increases by 900-fold. Then there can be mutations in pro-inflammatory cytokine genes, in claudin gene, carboxypeptidase gene. So if you see over the period of time from 2012 to 2018, genetic testings are increasing. But what can we expect? Like if we do a genetic testing, the results might be positive, it might be negative, it can be inconclusive, or sometimes it can be unexpected. So these are various Indian studies from Rupda's group. Rupda has shared these articles with me where they showed that claudin 2 gene is associated with idiopathic recurrent acute pancreatitis and chronic pancreatitis. So again, this study, this cathepsin B gene polymorphism is associated with tropical calcific pancreatitis. Again, study from AIG. Then this is another study which was reported in PLAS 1 where they showed that claudin gene and MORC4 gene associated with chronic pancreatitis. So I will skip this. Let me discuss this one. This was discussed by Dr. Ravindra. Like the pancreas divisum increases the risk of recurrent acute pancreatitis in patients with polymorphism in the cathepsin B gene. So this is important because if someone has got a mutation in cathepsin gene and has got pancreatic divisum, we have to do sphincterotomy in this group of patients. Now, how genetic testing is done, this is not my topic. So the biochemists and our geneticists, they will know, but usually it's a sample collection. The technique is PCR and of course the DNA sequencing. I don't know much about DNA sequencing except that these are the new methods of DNA sequencing, which is Sanger sequencing, next generation sequencing, specific gene sequencing, and the duplication analysis. So to conclude, recurrent acute pancreatitis and chronic pancreatitis patients with genetic mutation should be followed as they have high risk of developing pancreatic exocrine insufficiency, diabetes mellitus, and pancreatic cancer. But this is the most important thing, genetic testing is not a routine diagnostic measure. And in future, due to modern sequencing technologies, genetic screening of pancreatitis patients might become even more relevant in understanding the underlying pathophysiology and potentially identifying possible therapeutic targets. So thank you. With this, I invite you all to our annual conference, which is on 22nd, 23rd, and 24th August. Thank you.
Any questions from the floor? Thank you for this excellent talk. Anybody?
Dr. Paul, do you think of...
Yeah.
I have a question. There are genes which can predict recurrent acute pancreatitis. Are there any genes which can predict which recurrent acute will go on to develop chronic?
So you are asking, are there any genes which will predict that acute pancreatitis will go into chronic pancreatitis?
I think Dr. Rupajyoti can answer this better.
Yeah, I am not
because
very
they have done
sure.
a lot of studies.
So one particular gene is probably difficult, but if we have a panel of genes, the combination, like what in our experience, if we have cathepsin B with SPINK, because again it has to be a disease modifier combined with a disease causal. We don't see the hereditary pancreatitis gene, one or two cases are coming up, but if you see multiple genes, especially cathepsin B, and PRSS, one of the variants of PRSS, these combinations are present, and the chance of progressing to OCP is higher. Rather than having one single.
I have one point to mention. why, when, as I do pediatric gastroenterology, so what happens to us is that whenever there is recurrent acute, then we always have to answer why this is happening. So for that, actually nowadays we end up doing quite a lot of genetic tests, because if you don't have any structural problem, apart from pancreas division, if you don't have long common channel or colorectal cyst or all the other structural problems, then we often end up doing it. So nowadays, there was a time when we used to do it, the whole exome sequencing at 60,000, now we are doing at 12,000. So patients are more now coming up and they are doing it. So we are finding around 60 to 70% they have some gene mutation. Sometimes they are unidentified genes, but sometimes we do find SPINK, CFTR and other mutations, and few also TRSS1. So, and even Rupajyoti they had their studies, and in few patients from our place also they have cathepsin and claudin 2 mutations. So these are coming up quite a new way, and we can follow up these patients and see how many of them are actually developing chronic pancreatitis, or they are at what age they are developing.
Yeah, so that is the indication, like you have to do genetic test in patients, pediatric patients who come with pancreatitis.
All recurrent acute.
Or recurrent acute pancreatitis.
Usually we do.
Idiopathic recurrent acute.
Idiopathic is also there, but
So one caveat testing is what method we use. Nowadays the increasing can is good for exome sequencing for diagnostic purposes, but not recommend exome for diagnostic. That is should be restricted for research. The problem is you will see lots of mutation with unknown significance, so that scares the patient, scares the doctor. No one knows what to do. So whatever we know currently based on the which are associated, those specific mutations.
Yeah, we actually write down. We write down all the genes. Especially I got it from your studies because of all those genes. We put it down and we specifically ask for you have to follow and do all these genes. And then if you find some other mutations, we will correlate clinically. Because sometimes we come up with new mutations that is not correlating clinically. So that we have to also mention sometimes to the patients, and you have to do a lot of counseling with them if it is some unusual. But if it is the usual, then we can counsel them accordingly.
So can we think of a gene panel which could soon come to the clinic?
They have,
We actually have now several thousands of genetic testing reports. We are trying to pick up a group of genes that is strongly associated, because again we need to find out some polygenic risk factors. This is not just the genes, not just the clinic, it's a combination of gene and environment. So that's what we're trying to do, find a polygenic risk score, including few of the commonly associated genes, because all genes are not causal. Many of them are associated.
Exactly.
So we find the risk factors on the clinical side also. So in that combination, probably a combination of cathepsin B, SPINK1 homozygous, cathepsin B, and one of the variant of TRSS. These three strongly associates with the progression of pancreatic problem.
Good. Thank you. Thank you, Dr. Pal. Yeah. If there are no more questions, we declare the session as closed.
We should close the session. It was an excellent session. Thank you.
So thank you, respected speaker and honorable chairpersons. So now we will shortly begin with our inauguration session. So it is a delight and great pleasure to welcome everyone to our third session of our Kolkata Pancreas Update 2025. This annual academic meeting is dedicated for advancing knowledge, sharing recent advances and fostering collaboration in the field of pancreatic diseases. This update session will provide a dynamic scientific program featuring eminent national experts from the field, and they will enlighten us on the recent advances in the field of pancreatology and gastroenterology. So now, to begin with our inauguration session, it is a pleasure to welcome Dr. Ashokananda Konar sir, our organizing chairman. He needs no introduction. He is the Senior Director Associate of Gastroenterology associated with Peerless Hospital, Kolkata. Requesting sir to please come on the stage. Now it is a It's time to welcome our chief guest. It is an honor to welcome and have among us Dr. D. Nageshwar Reddy sir, who is the recipient of the second highest civilian award, Padma Bhushan Award. Sir needs no introduction. He is the chairman and founder of Asian Institute of Gastroenterology at Hyderabad, which is the biggest gastroenterology hospital of the world. Welcome, sir. Now I request our special guest, Dr. Mahesh Kumar Goenka, sir, Senior Director and Director of Medical Education of Gastroenterology, Apollo Multispeciality Hospital, to please come on the dais. And finally, I request Dr. Sanjay Bandyopadhyay, sir, our Organizing Secretary, Senior Consultant Gastroenterologist associated with ILS Domdom, to please come on the dais, sir. Now I request to kindly felicitate our dignitaries on dais with the flower bouquets. Requesting to present our flower bouquet to our organizing chairman. Requesting our events team to kindly felicitate our dignitaries on dais. Thank you, sir. Now I would request all our dignitaries on dais, respected faculties, to kindly come forward for our lamp lighting. Requesting our events team to kindly play Saraswati Vandana.
I would also request Professor Ajay Kumar sir, please come to the dais. He is one of the senior most gastroenterologists of this country.
Thank you. Now is the time for launching of our book, Advances in MASLD, a comprehensive guide for physicians, requesting our chief guest and special guest, sir, and all the dignitaries on dais to kindly launch the book. So may I request the authors and the editors of the book, Dr. Shambhu Samrat Samajdar, also to please join us for the book launching. And we have our editor, Dr. Sanjay Bandyopadhyay, sir. So thank you. Now I request our chief guest, Dr. Nageshwar Reddy sir, to kindly address our august audience.
Friends, I think it's a great occasion today that we're seeing the third Kolkata Pancreas Club meeting coming on. In fact, I remember the first one where we met in a much smaller place, and subsequently I think last year was bigger and is getting bigger every year. I'd like to congratulate Ashok Anand Kunar and Sanjay for keeping this on at such a high level. In fact, the only other pancreas meeting we have every year is the one which is by the official society of Pancreas Club, which happens once a year. But this meeting in fact is as large as that, the topics are as diverse, and I think it's as interesting. So I think this is a very unique conference with a niche area, and I'm so glad to see that the registration is going on increasing every year. Pancreas, of course, is an organ which we as gastroenterologists haven't paid much attention to, but in recent years there's an increasing new areas that are coming up. For example, like MSLD, the fatty pancreas is another very interesting area, and a lot of new metabolic problems associated with that. Similarly, I think the genetics area is expanding, as you can see, and of course endotherapy is established in many areas but still evolving in some areas. So we have a lot of things to discuss in this area, and I'm sure these meetings are going to be extremely useful in terms of stimulating all the people working in the area of pancreas for further enhancing knowledge in this area. Again, I'd like to thank organizers Ashok and Sanjay for giving me this opportunity, and of course me and Mahesh have been together in this meeting from the beginning itself, and I think it's a very good impetus to the juniors to go along. Thank you.
Thank you, sir. Now I request Dr. Mahesh Kumar Goenka, sir, our special guest, to kindly address the audience, sir, with your valuable remarks.
So I'll be very brief. Good afternoon, everybody. I think the meeting becomes big when people like Nageshwar Reddy, Ajay Kumar, Roop, Jyoti Chalukdar are here. So that adds to the importance of the meeting. And I'm very happy that Kolkata with Dr. Konar and Dr. Sanjay Bandyopadhyay are organizing this meeting now regularly. And I'm sure it will become annual event for all those who are interested in pancreas and for gastroenterologists. I wish this meeting a great success, not only this year, but in years to come. Thank you very much.
Now I request Dr. Sanjay Banerjee, sir, to finally give the vote of thanks.
I profusely thank Professor Reddy, Professor Goenka, all our faculty members, teachers, seniors, those who have graced this occasion, and because of their blessings we can reach to this stage. I also thank the hotel authority, the pharmaceutical houses, my staffs at the Kolkata Gastro Care Unit, because of their participation and help this was possible. And finally, before I end, I just want to tell you that an artist was asked at an award function, which is your best painting? Because he was a famous artist. So he was asked, what is your best painting over the last 30 years that you have painted so many? He replied that my next one is going to be my best painting. So let us aim for a better tomorrow rather than on this achievement of today. Thank you very much.
Thank you, sir. Now we move forward to our next academic session. So this is a panel discussion on pancreatic enzyme replacement therapy. To moderate this session, may I request Dr. Sanjay Banerjee, sir, Senior Consultant Gastroenterologist and our Organizing Secretary, to please come on the stage, sir. And as eminent panelist for the session, we have Dr. Devashish Mishra, sir, Associate Professor, Department of Gastroenterology, IPGMR, Kolkata, requesting sir to please come on the dais. I request Dr. Sunil Barun Das Chakraborty, Senior Consultant Gastroenterologist, Ruby General Hospital, Kolkata. Dr. Yogesh Harwani, Senior Consultant Gastroenterologist, Nobel Institute of Gastroenterology, Ahmedabad, Gujarat. And Dr. Partho Saruthi Patro, sir, Senior Consultant Gastroenterologist from Nightingale Hospital, Kolkata, to please come on the dais. So over to Dr. Sanjay Banerjee, sir, to start the panel discussion.
Good afternoon. So we have very illustrious panel. Most all are my juniors, but still they are no names in their fields. Our topic or discussion is pancreatic enzyme replacement therapy. Not only chronic pancreatitis, we will briefly touch other facets of pancreatic diseases. As we all know, pancreas is an unique organ, both endocrine as well as exocrine, and on exocrine part it produces many enzymes, many proenzymes which get converted into enzymes, And the classic example of pancreatic exocrine insufficiency is chronic pancreatitis, and then there are other causes in which we get insufficiency of the pancreatic enzymes resulting in diarrhea and steatorrhea. Now, overall in chronic pancreatitis, the prevalence of exocrine insufficiency is around 60 to 75% and a little less in children. And we have many guidelines on the usage of pancreatic exocrine enzymes in pancreatic enzyme therapy in patients with exocrine insufficiency in chronic pancreatitis, and I think this learned audience knows most of these guidelines. The SEG 2020 guidelines is what mostly followed in country like India. So my first question to Dr. Sunil, what is your preferred test to check exocrine pancreatic insufficiency in chronic pancreatitis amongst these four? Because I think almost four are available in the market. So which one you prefer?
Fecal elastase 1 level is the most commonly used and most preferred test.
And not 72 hours stool.
72 hours fecal test is the gold standard, but it indicates the fat content of the stool. It doesn't differentiate between the exocrine deficiency or other cause of malabsorption. If I want to differentiate from the pancreatic exocrine insufficiency, then you have to go for fecal elastase level. It indicates the patient has an steatorrhea or fat malabsorption. This is the gold standard for fat malabsorption.
Suppose a patient of chronic pancreatitis is already getting enzyme supplement. So which test would you prefer?
The fecal elastase level, because each level is doesn't altered by the enzyme therapy.
So fecal elastase is the answer, yes. Fecal elastase is the test, though it's not as gold standard like 72 hours fecal fat, but then that is quantitative, but that's cumbersome to perform and carry out. Fecal elastase values are not get altered by on the patient who are getting enzyme replacement therapy. And almost again I go back to those guidelines. Almost all the guidelines, be it Japanese, UK consensus, AGA and United European, all say that to diagnose pancreatic exocrine insufficiency you have to do fecal elastase. There are only two caveats that fecal elastase should be estimated in non-diarrheal stool, because diarrhea itself can cause an elevation in fecal elastase. So fecal elastase is, we all know, this requires very small amount of feces. It's stable at room temperature for 3 days, and this is there are many points in favor of it and hardly any point against. So next question to Dr. Debashish Mishra. So when you in your practice, do you check for exocrine pancreatic insufficiency? Do you routinely do to all your patients of chronic pancreatitis?
No, the answer is no. I don't do.
Any specific group in which you do or you don't do? You diagnose chronic exocrine insufficiency based on other features?
Mostly I rely on the clinical feature. One of the important point is that in Indian context, the patients might be having a low fat content diet. So in that case, the overt manifestations of the exocrine insufficiency might not be there. In those cases, if we try to identify the exocrine insufficiency, we can do. But as the treatment of it is a costly one, and the person who is not having a symptom obviously will not like to have a costly medicine for a symptom which is not present in him. So routinely I would not go for pancreatic exocrine insufficiency testing.
So rightly what he said, even in symptomatic patient, none of the guidelines recommend testing for pancreatic exocrine insufficiency. And it's a little bit puzzling, because for pancreatic exocrine insufficiency you need to, in chronic pancreatitis you expect pancreatic exocrine insufficiency, but even in symptomatic patient, and this is when there is high pretest probability of clinical suspicion of pancreatic exocrine insufficiency, which most of the guidelines, particularly American College of Guidelines, say that patients with pancreatic cancer or chronic pancreatitis with classic symptoms, trial may be initiated rather than testing. And particularly in pancreatic carcinoma, the NICE guidelines also says start with PARTI rather than testing for pancreatic exocrine insufficiency. Now question to Dr. Jogesh. So once you have decided on giving a pancreatic enzyme, so what should be the character of ideal enzyme preparation?
So the ideal enzyme will be replacing an enzyme which helps in digestion of proteins and fats. So ideally the preparation should be that it should withstand the acid of the stomach. It should not, denaturization should not occur in the stomach if acid is present. It should get released directly into the duodenum. That means it should be enteric coated. A microspheres 2 mm now enteric coated granules are available, which directly mix with the chyme and they release in the duodenum.
Otherwise, ideally, we should have 30,000 international units of lipase in the pancreatic enzyme supplement, because this much enzyme is required to prevent steatoria. Although it is only 10% of the total enzyme which is released by pancreas, but 30,000 international unit lipase, which each meal will prevent steatoria and also reverse the symptoms, and it should be taken at the initiation of the meal.
Okay, so question to Dr. Partho, yes, some of which Dr. Jogesh has covered. What is the preferred dose of lipase that used at the initiation of therapy?
30 to 40,000 international unit per meal and 15 to 20,000 unit with snacks.
So you will only give pancreatic enzyme or to give something else to improve its efficacy?
Sometimes acid suppressors can be.
Acid suppression.
Yes.
So that yes. Okay. So question to Dr. Sunil again. How do you assess the response to therapy? So once you have given what Dr. Partho said, 50,000 or maybe 30 to 50,000 for meal, 25,000 for snacks.
Access to the response is basically assessed by the clinical mostly. The patient, either patient has a weight gain or not after the quantified time period of the replacement therapy. Then we assess for the stool volume, whether stool volume is reduced or not. We assess for the visibility of the fat in the stool or not. Mainly on the clinical symptom and patient symptom. And the patient, there is a reduction of the abdominal pain or bloating sensation, reduction of the flatulence. All these are basically assessed to response to the therapy. If we need an objective response to the therapy, then we go for a fecal fat estimation, or sometimes within carbon, radioactive carbon mixed as a triglyceride therapy. They recently introduced the carbon-13 mixed triglyceride breath test. So these two objective assess the response.
So basic points to assess are actually symptoms, symptomatic improvement or not, including body weight, because most of the patients with exocrine insufficiency suffer from weight loss, even if their diabetes status is controlled. So improvement in the weight, control of symptoms, and particularly with emphasis on fat-soluble vitamins, because we know in chronic pancreatic insufficiency we have lots of A, D, E, K, almost all vitamins are deficient. So assessment of fat-soluble vitamins could also be another important criteria. So this is the way we assess response to PERT therapy. But Dr. Debashish, suppose you have non-response, patient is not improving, no symptomatic improvement, no weight gain, and nutritional parameters are still lagging behind. So how will you control?
So first of all, I would like to check the compliance, because the enzyme replacement therapy is costly and most of our patients are not so economically sound. So first of all, I would like to check the compliance, whether he is taking the proper dose. Number two, if he is taking the proper dose, whether he is taking it correctly. So the better option would be to take the enzyme replacement formulations with the meal rather than taking it prior to the meal or after the meal. So whether they are taking it properly with the meal, and if they are following it correctly, then I would consider about adding acid PPI or H2 receptor blocker, as we have just discussed a few minutes back. And if it is already been done, then I would also try to give an empirical dose of rifaximin to treat small intestinal bacterial overgrowth that can occur in this group of patients. We don't routinely do testing for SIBO in chronic pancreatitis, but probably empirical therapy with rifaximin will help.
So yes, apart from increasing the dose or for correct admission, checking the compliance and adding PPI, maybe H2RA and PPI at times twice a dose, one of the important issue, particularly country like India, is small intestinal bacterial overgrowth. And we have a paper, I think, from CMC Vellore, where in patients with chronic pancreatitis, there was on GHBT, glucose hydrogen was nearly 29% SIBO, and on jejunal aspirate culture, more than 1/3 of the patient had also SIBO. And similarly, one study reported by Professor Ghoshal and he has also done a review of the literature, nearly 14% patients of chronic pancreatitis, and I think he is also undertaking a work at Apollo presently, on nearly 14% of patients, which he reported in 2014, 14% patients of chronic pancreatitis has SIBO. So this assumes importance, because patient not responding, as Dr. Devasi said, we may go for a trial of rifaximin in this patient. So my question to Dr. Jogesh, does PERT improve quality of life?
Certainly, there are multiple studies abroad as well as in India, and studies have shown that if adequate dose of PERT is given to a patient with chronic pancreatitis, there is improvement in bloating, abdominal pain, and it increases the consistency of stool, decreases frequency of stool, and also improves steatorrhea. So certainly there will be change in quality of life. And study from our country, a multicentric study was there in 2013 in pancreatology, and they have also shown the same findings. So it will definitely improve the quality of life.
So one of the most landmark study in this field in Canadian Journal of Gastroenterology that reported that there is increase in quality of life, but there was 90% compliance, which is difficult in our practice, and they included only 70%, and the quality assessment included those what they apply for malignancy patient. This was not specifically tailored to chronic pancreatitis patient, but nevertheless there are subsequent many other studies, I think there are all over the world, which showing that pancreatic enzyme replacement improves the quality of life of this patient. Now Dr. Partho, because this is something very personal to you, what according to you is the major challenge of treatment with PERT? Why personal? Because I will share that paper.
First is there is no ideal dose for PERT. Second is compliance to the medication, compliance to the timing of the taking medication. Third is cost. And
so I think cost of the therapy is enormous, particularly in a country like India, what enteric coated micro or mini micro spheres we use. And Dr. Partho's group with Dr. Khaunis Das, they have reported a study from Kolkata where nearly 76% of patients has catastrophic healthcare cost, those who are on chronic regular PERT, and they have poor compliance. Because of poor compliance, they had inadequate response with lower BMI and overall lower calorie intake. I think this was, they reported in Digestive Disease and Sciences in 2021. So this is their paper. Any comments or question from the members in the audience? Dr. Rupjyoti Talukdar, Dr. Sushant Sethi, sir. Up to now, regarding pancreatic enzyme replacement.
So just now, there was a point on the compliance, right? So that is very important. Another thing that has to be added to the advice is take normal diet. Because that is something is missing in the advice. Even doctors, nurses, even patients themselves do not eat adequately. So that is very important. I don't know if this is going to come back. When you prescribe PERT, it has to have an advice to take normal diet. Otherwise, PERT is not going to work if you don't take it.
Okay, so well taken your points. Oh, yes, sir. Huh. Yes, yes.
Vegetarians, there is no preparation available.
Yes.
I think that becomes a big challenge.
Yes, sir. So any comments from the members in the panel up to this? No. So we go to the final and third round of questions to our esteemed panelists. Now these questions are a little bit tricky and a little out of sync. So Dr. Sunil, does pancreatic enzymes, because we have this practice of seeing many prescriptions where pancreatic enzymes are particularly tablets, the non-enteric coated formulations are routinely prescribed for many digestive disorders. So do you have any solid evidence to suggest that they do help in non-pancreatic digestive disorders, maybe functional dyspepsia, maybe IBS?
Sanjay, that is a very tricky question, but basically there is no evidence to use the PERT therapy in a non-pancreatic disease patient without an exocrine insufficiency. But sometimes it's used as a PERT therapy in a group of non-pancreatic patients. Those patients is at a low doses and for a shorter duration to improve the health status. In a patient with severe malabsorption, severe malnutrition patient, we can give a protein therapy at the low doses and for a shorter duration to improve the health condition. For that reason, in some patients, the patient have been disturbing bloating or abdominal fullness that may hampers the quality of life for a long. Then that can be used for a shorter duration for a low doses for a while only. But for a long-term PERT therapy in a non-pancreatic disease without exocrine insufficiency, there is no hard and fast.
So I think this is a practice prevalent also in United States of America. Dr. Dhiraj Jadav's group has done and shown that 60 out of 100,000 patients in the community do receive pancreatic enzymes for non-pancreatic digestive disorders, though they receive for short period of time. But there are some definite indications. I think gastrectomy, post-gastrectomy, some cases of celiac disease not responding, celiac not responding.
Severe Crohn's disease with malabsorption.
Yes. I think there are literature to support that this specific group of particularly post-gastrectomy patients, and there are a lot of literatures on that. Post-gastrectomy, they do respond to pancreatic enzymes to some extent.
Post-gastrectomy, post-pancreatic surgery patients, post-Whipple's a group of patients for Whipple surgery, post-Whipple surgery.
So my question, this is a tricky question for Dr. Devas is, do you use PERT for management of pain in chronic pancreatitis?
Mostly no, but the reason behind that is most of our patient that we see in our setup is alcoholic patient and those with calcific pancreatitis. In a small subgroup who having non-calcific chronic pancreatitis, probably side branch dilatation, we still try with the enzyme replacement for management of pain, but mostly for calcific pancreatitis, alcoholic background, we would not go for that.
So we have, I think, the two meta-analyses, one by Peter Banks' group showing that they are not useful, and again another study by from PGI group in Cochrane Review in 2008 showing that is that I just request comment from Dr. Rupjyoti Talukdar. Do you really think pancreatic enzymes, because some of the companies are now promoting that?
Physiology of the enzyme and pain.
Yes.
It is supposed to reduce the pancreatic secretion into the gut. I'll speak on that later in my talk. So a non-enteric coated is important. Enteric coated won't do that because we need to release those trypsin in the duodenum. Number one, there are no non-enteric coated available in India. We just concluded a randomized control trial.
Audible, not audible.
Non-enteric. It's not working. Yeah. So in that randomized control trial, there was no difference in pain between the placebo and the enzyme. So as of now, the conclusion will be non-enteric coated enzymes do not help in pain. So that will be the conclusion.
So most of the guidelines also recommend, including SCG guidelines, they say this should not be used for the control of pain. Dr. Sushant Sethi.
Whatever improvement was there, it's not because of pain, it's because of flatulence, dyspepsia and other resistance. So basically pain was not.
Okay, thank you. So my question to Dr. Jogesh, again tricky, is there any role of pancreatic enzyme in acute pancreatitis?
So now basically pancreatic enzymes is mainly indicated for those patients who have exocrine pancreatic insufficiency, and this will depend on the loss of volume. So evidence says that post-acute necrotizing pancreatitis leads to exocrine pancreatic insufficiency. So if all patients with acute necrotizing pancreatitis on follow-up, if they present with weight loss or if they present with bloating, increased frequency of stools, in them my personal experience is, and study also says that we should give pancreatic enzyme therapy, and this helps to reverse the symptoms as well as increase body mass index. Now how long to continue is a question. In chronic pancreatitis we have to continue for an indefinite period, but in acute pancreatitis we usually stop when the patient has gained adequate weight and reversal of symptoms.
I think a group of patients of acute pancreatitis, actually alcoholic, severe necrosis, they do show features of insufficiency, but how to tackle that and how long to continue and what is the long-term outcome? There are studies, just a randomized double-blind parallel group study that has shown no difference. Basically, Kaplan-Meier estimates has shown that there is both the curves showing a similar course and no difference between placebo and enzymes. This is the only double-blind study, though there was less weight loss, less flatulence, and to some extent improved quality of life. Now, question to Dr. Partho: is there any role of PERT in pancreatic carcinoma?
In pancreatic carcinoma, pancreatic exocrine insufficiency is very much common, but it is not routinely recommended. But if patient is having weight loss, maldigestion, malnutrition, steatoria, then it should be given. There are conflicting data about pancreatic enzyme replacement therapy in pancreatic cancer. In some data, it is showing that it causes improvement in body weight and even survival benefit. But some data is showing that there is no survival benefit, no weight loss improvement.
So I think there are many studies, yes, in pancreatic carcinoma, particularly those in the head maybe after resection or unresectable, because they have a high prevalence of pancreatic exocrine insufficiency. The oncologist commonly prescribe for pancreatic enzyme replacement therapy. There are many papers. The problem is that most of the retrospective has shown that survival benefit, but RCTs have not shown survival benefit. So that is the problem. So the pancreatic enzymes do have a role in management of pancreatic carcinoma, particularly post-resection cases. I think that should be the message. So this is the end of our panel discussion. I thank all the panelists for educating us and also the members of the audience to take part in it. We proceed for the next session. Thank you.
Thank you, eminent panelists and our moderator, sir, for the excellent session. Now we move forward to our next session, which is on pain in chronic pancreatitis management. To chair this session, may I request Dr. Jaydev Roy, Senior Consultant Gastroenterologist, associated with Sri Aurobindo Seva Kendra, Jodhpur Park, Kolkata. I request Dr. Shubhamoy Das, Consultant Pediatric Gastroenterologist, Apollo Multispeciality Hospital, Kolkata. Dr. Medidi Cruz, Madam, Director, Health and Lifestyle Clinic, Kolkata. And Dr. Amitabh Roy, Senior Consultant Gastroenterologist, associated with Unity Gastro and Liver Hospital, Agartala, Tripura, to please come on the stage. Our speaker for this session is Dr. Sushant Kumar Shetty, sir, Senior Consultant Gastroenterologist, Apollo Hospital, Bhubaneswar, Odisha. Requesting our speaker to please come on the stage and requesting our chairperson to start the session without further delay.
Yes, Dr. Sushant to deliver on pain and chronic pancreatitis. Most of the patients, more than 95% pain is the main problem. Dr. Sushant, please.
Very good afternoon. At the outset, I am thankful to Dr. Sanjay Banerjee, Dr. Kumar sir, to give me this opportunity to talk about pain in chronic pancreatitis, the management options. Pain is the most common symptom of chronic pancreatitis, affecting over 80% of patients during the course of their disease, and it is the main driver of morbidity in the disease, leading patients to seek treatment. So if we look at the natural history and burden of pain in chronic pancreatitis, approximately 50 per 1 lakh populations, they do have the prevalence. And patient typically describes their pain as a dull, sharp or nagging sensation in the upper abdomen, which can radiate to back and often present after or worsen by food intake. In natural history studies, pain was observed in the initial presentation to 75% of patients and present during the clinical course to the tune of 85 to 97%. Another fact is the patient with early onset of disease and those with alcohol etiology are more likely to have pain, and according to the burnt-out hypothesis, majority of patients with chronic pancreatitis, they achieve lasting pain-free status during the clinical course. So typically nowadays, the pain of in chronic pancreatitis are type A or type B. Type A is the intermittent pain episodes with pain-free interval, but the more common type B, to the tune of 45% of individuals they present with type B, is a constant unremitting pain punctuated by acute exacerbation with more severe pain, which is clearly found to have significantly worse quality of life and higher rates of medications use, hospitalizations, disability, even independence of pain severity. Unfortunately, chronic pancreatitis, the pain has not been shown to correlate reliably with imaging finding of the disease. Pain effect on mental health and quality of life. Studies showed a high prevalence of anxiety and depression in patients with chronic pancreatitis, and patients with symptoms of anxiety or depression are more likely to report pain. That means those who are having chronic pancreatitis, they will have more anxiety and depressions, and those who are having anxiety and depressions, they will more manifest the pain. Pain and depression correlated with elevated AN-acetyl level and choline in the left hippocampus and left prefrontal cortex region of the brain. In fact, until recently, the pain was supposed in people thought that the pain is because of ductal obstructions, and which occurs in chronic pancreatitis because of stone, stricture or both. Once the ductal clearance is achieved, the pain will be gone. But until recently, the paradigm has shifted. So few patients or subset of patients, even after ductal clearance, they continue to have pain, which provoked the scientists to think there is some extra pancreatic pathophysiology of this pain, pancreas pain. What could be those extra pancreatic pathophysiology? So basically these problems could be wearing problems where the neural mechanisms, it could be central and peripheral, spinal or cortical. So wiring problems from central sensation or cortical sensation. Some impaired problem like impaired inhibitory pain modulations or pancreatic nociceptions, pancreatic neuropathy and neuroplasticity. Or could be a problem inside the pancreas where pancreatic ductal hypertension, pancreatic parenchymal hypertension, pancreas morphology. Local complications may lead to the pain pathophysiology like pseudocyst, peptic ulcers, splenic vein thrombosis, and adverse effect to the opioids. Opioids many times they cause hyperalgesia. So and complications to surgery, endoscopy therapy, small bowel overgrowth, they also could have contributed for the pain. So the pain is multifactorial complex in case of chronic pancreatitis, so difficult to manage. Coming to central sensitization in chronic pancreatitis, central sensitization is heightened pain sensitivity due to changes in the central nervous system. The key features are widespread hyperalgesia beyond the pancreas regions, and identified by pancreatic quantitative sensory testings and central sensation status may predict outcome of invasive therapy. Some newer drugs optimize patient selections for interventions as well. So these are the structures in the brain which are responsible for the pain sensitizations or modulations: anterior cingulate cortex, nucleus tractus solitarius, insula, periaqueductal gray matter or PAG. And what the target? Because basically if we understand better the central sensitizations and nociceptions, we can target the future molecules which can be beneficial in case of pain management. There, agents like gabapentins could have been some role. This is the innervation of the pancreas and novel regulatory pathway. So methods to assess pancreatic pain could be one-dimensional, like visual analog score, which is not usually beneficial. So many times multidimensional scales, which usually predicts the severe aspect of pain, intensity, locations, etc. should be studied. Quantitative sensory testings or pancreatic quantitative sensory testings can be used. So it is classified into major three phenotypes: widespread hyperalgesia. Even if apart from the pancreas locations, there will be hyperalgesia. That means it tells that there is some central sensitization problems. Segmental pancreatic hyperalgesia, no hyperalgesia. Patients with widespread hyperalgesia, clearly they have low quality of life, higher constant pain, greater overall pain burden. So early QST studies predicted response to pregabalin therapy, so that is the only thing could be seen beneficial. So once we know the pathophysiology of pain, how to treat, it could be treated by pharmacology, endotherapy, surgery, adjuvant therapy. So coming to analgesics, WHO recommends stepwise implementation of non-opioid analgesics, including acetaminophen of NSAIDs, followed by weak opioid analgesics to strong opioid analgesics. Though the step ladder pattern should be followed. However, NSAID are clearly associated with GI toxicity and nephrotoxicity, so should be used in caution. And if you are using opioid analgesias, this risk and benefit ratio must be weighed, and the complexity of these opioid drugs, the adverse effect, the long-term opioid therapy leads to hyperalgesia, that should be kept in mind. And tramadol is usually commonly been given, but it is weak opioid analgesias. However, despite of all the therapy, only 25% they benefit from the pain. Support for pain in chronic pancreatitis, we just have a panel discussions. It is not recommended as such, but if a patient is improving with PAT, then uncoated contain large amount of protein should be given. Antioxidants in a multiple antioxidants combination should have shown some benefit in the management of pain in chronic pancreatitis, not a single antioxidant. And when it is combined with pregabalin, then it might be beneficial. So in pain management, indications for treatment: pain pattern sufficient intensity, primary pancreatic pain, the malnutrition, red flags for lifestyle, that should be taken into considerations. Nutrition should be optimized, that is very important. The advice against smoking and alcohol should be continuous process. And if a ductal obstruction is suspected, then endoscopy or ESWL should be considered. PCA, SSRI, SNRI, cognitive therapy, they have their role in this armamentarium. Once pain is there, the pain should be treated with simple drugs like acetaminophen, then non-opioid analgesia, NSAID and opioids if required. And if opioid is, and sometimes antioxidants, they have plays their role. If opioids are given, then patients should be followed, and other alternative therapies should also be taken into considerations. So once pharmacotherapy is gone, then next endoscopy versus surgery. So idea of endoscopy is, when considering endoscopy or surgical management, the ASG they recommends in painful chronic pancreatitis and obstructed main pancreatic duct, they suggest in patients with no contraindication to surgery, ASG suggests surgical evaluation before initial adopt endoscopy management. Because of irreversibility in nature, usually people and the patients they avoid surgery, but ASG recommends to initial evaluations of patients for surgery if they are the candidate of surgery. Otherwise, in patients with contraindication to surgery or those who prefer a less invasive modality, ASG suggests endoscopy management as the initial approach. Endoscopy therapy is in painful chronic pancreatitis is based on the rationale that pain is related to an outflow obstructions, ductal obstruction either because of stricture, stone or both. ERCP can achieve empty drainage by sphincterotomy of the major and minor papilla, short-term stent placement or by pancreatic stone extraction, usually after fragmentation with extracorporeal shockwave lithotripsy. If clinical success can be obtained with less than 5 endoscopic interventions, the patient will probably achieve long-term favorable outcome. It has been seen with this approach, 60% experience complete or partial pain relief, both in short, that means less than 2 years, and long-term more than 5 years follow-up. The guideline is more or less clear as the recent recommendations. So the best candidates for successful treatment of painful chronic pancreatitis with first-line endoscopy therapy are patients with distal obstruction of the main pancreatic duct, single stone and or single stricture in the head of the pancreas, and early stage of the disease. In patients with painful pancreatitis and main PD stone, the ASG suggests that management strategies should be based on stone, location, and radio opacity. For radiopaque stone more than 5 mm and in the head, neck, or body of the pancreas, ERCP with or without pancreatoscopy or ESWL alone should be done. After ESW and with no spontaneous stone clearance after adequate fragmentations defined as the presence of fragments less than 2 to 3 mm, after ESW, our aim is or target is to make the fragment 2 to 3 mm. So usually we consider ESW more than 5 mm stone. Performing ERCP with or without pancreatoscopy. For radiopaque stone less than 5 mm, any radiolucent stone or contraindication to ESW, ERCP with or without pancreatoscopy should be done. Removal of ERCP alone with interventions are successful in less than 15% of chronic pancreatitis patients. The decision to choose pancreatoscopy or ESW is largely based on local expertise, availability, and ESWL for radiopaque stones are generally considered for more than 10 mm because they are not available to endoscopic therapy. Pancreatoscopy is likely to be difficult in the presence of stricture with stone upstream from the stricture, so it has to be taken into considerations. Optimal timing when the studies suggested comparing early endotherapy with wait and see strategy, they had shown the increased atrophy of the pancreas if you are waiting to do the endoscopic therapy and trend towards improved pain control is seen in early therapy. So, early endotherapy is indicated. So, this is the factors associated with complete stone clearance and pain relapse occur more frequently in patients with incomplete removal of stone after the initial therapy and in those with the MPD stricture. Number of stents, whether single stent or multiple stent, plastic stent versus metallic stent. The ASG suggests placement of single or multiple plastic stents for the initial treatment of dominant PD strictures. A largest possible diameter PS then can be safely deployed, around 10 pens should be applied, and avoidance of forceful or traumatic placement with a gradual upsizing will be necessary. When you putting a stent, after 3 months you should gradually upsize that to another size. Use of metal stent, FEC fully covered semi-self-expandable metallic stents for patients with persistent or refractory PD stricture without failed initial stent placements are not recommended routinely. They have significantly delayed adverse effect. So, these are the pre-ESW and post-ESW some pictures, pulverized stones. However, FCMS can be used if multiple stents, plastic stents are options in case of refractory pain or symptoms. US guided celiac plexus block, if all other armamentary is exhausted, then it can be an option in those in non-obstructive small duct disease not amenable to endoscopic or surgical therapy decompression or in patients who have side effects to opioid or preferred opioids. But please remember, less than 60% of patients get pain relief with an US guided celiac plexus block and it is unsustained. That means less than 6 months. So, no studies have compared CPB with placebo, so that questions their efficacy. US guided over percutaneous approach, the study was done. It is clearly US guided celiac plexus block is beneficial than endoscopic approach. I mean, that means then percutaneous approach, I am sorry. So, optimal time for surgery in painful chronic pancreatitis. Current evidence on the timing of surgery of painful chronic pancreatitis suggests a beneficial role of early surgery, that is within the first 2 to 3 years after diagnosing or symptom onset. For patients who had equal to or fewer less than 5 endoscopic procedures, or for patients who have not yet required opioid analgesia for medical pain treatment. Somebody is taking opioid analgesia for longer periods, the central nociceptions, those things have been changed. Even if pancreas ductal obstruction, everything has been taken care of, the pain may not go. Surgical options for pain are classified into 3 categories: decompression, focusing on ductal hypertension; resection, focusing on inflammatory masses and stones in the pancreatic head; and combined procedures. And these are the procedures. Main pancreatic duct dilatation is there, then pancreatic head lesion is not there, side to side pancreatic xenostomy, otherwise phase procedure, celiac plexus block or neurolysis. Total pancreatomy to be considered in main pancreatic dilatation is not there, use of opioids and distal pancreatomy. So, these are the basically surgical modalities we are using in case of pain management. TPAT, the total pancreatectomy with islet cell transplantation has been increasingly offered to pediatric patients, especially those with hereditary etiology of chronic pancreatitis, and to both children and adults with refractory pain. Currently offered only in major tertiary care centers with islet cell isolation capability, and ongoing observation study is going on. In multi-center effort aimed at clarifying the risk and benefit of the practice of this procedure. Chemical pancreatectomy is interesting subject. A novel therapeutic approach, infusion of acetic acid has been shown in result to non-regenerative near complete ablation of exocrine pancreas while preserving islets. So it can be an option as non-surgical therapy, may be translatable human through ERCP inhibitors in futures. Adjuvant therapy include antidepressant, anxiolytic, anticonvulsant. As I said, the pain mechanism in chronic pancreatitis is beyond pancreas, so all these things has to be addressed. And glutamate modulators such as acetyl L-carnitine also showed some promise, ALC potential targets, so also the vitamin D in some studies. The two novel therapies, neuronal tracts, nitric oxide synthase inhibitor, NOS inhibitors, and stem cell infusion have been investigated recently in a model of CP. Vitamin D I have already told about. Lacosamide, anti-epileptic agents believed to reduce the effect of opioid-induced hyperalgesia is ongoing. So once you use lacosamide, then opioid use can be optimized. Numerous clinical trials of antifibrotic agents are also on the way. So ladies and gentlemen, to conclude my talk, I will be saying abdominal pain is the foremost complications of chronic pancreatitis. Pain can be related to recurrent or chronic inflammations, local complications, or neurogenic mechanism with corresponding changes in the nervous systems. That means it exists beyond pancreas. For pain relief, current guidelines recommend a simple stepwise escalation of analgesic drug with increasing potency until pain relief is obtained. Abstinence from alcohol and smoking should be advised strongly. Pancreatic enzyme therapy antioxidants may be useful in initial treatments, but not recommended. Endoscopic treatment can be used especially with the evidence of ductal obstruction and may be combined with pancreatoscopy with EHL, ESWL, etc. Behavioral intervention should be part of multidisciplinary approach to chronic pain management, particularly when psychological impact is experienced. The type of surgery depends on morphological changes of the pancreas. Finally, neuroanalytic interventions and neuromodulations can be considered in difficult patients. Thank you for your patient listening.
Thank you, Dr. Sethi, for that excellent and comprehensive talk on chronic pancreatitis. Is there any question from the audience?
Before the audience, I have a question for sir. So we deal actually pediatric and adolescent patients, which is most difficult part to deal, especially having pain with chronic pancreatitis. So at a time, nothing seems to work. Pregabalins, neuromodulators, amitriptyline. So those who have ductal hypertension, we refer to therapist, for endoscopic therapy. So how many sessions can be practiced before we consider surgery to be upfront?
So recommendation is, yes, that's a good question. Recommendation now is that, so before surgery, the evaluation should be done whether he is a candidate for, before endoscopy, you said for endoscopy, evaluation should be done whether the patient is a candidate for surgery. There is no contraindications for surgery. If there is contraindication for surgery or patient prefers less invasive modality like endoscopy, then ductal clearance, the ideal candidates which you can achieve ductal clearance should be chosen. So less than 5 is the target, less than 5 endoscopic therapy, endotherapy for ductal clearance should be chosen. And if it's stone, it depends on the stone size. If less than 5 millimeter, then you try for endoscopic therapy. If it is more than 5, you try for ESWL, more than 10 for sure ESWL. EHL can be combined with ERCP. We are having that luxury of this.
That we are doing, but I think sometimes we go on repeat. As endoscopists, we feel very, stimulated to try endoscope.
That has clear advantage because once we are doing ERCP, EHL, you can combine. That is for sure. And ESWL is not available everywhere.
ESWL we are practicing. I'm saying that referring to surgeon. Suppose 4 sessions, 5 sessions, and we are achieving some success. That is 6 months, 1 year pain free. Then again coming back with pain. So that's what's the number of sessions.
That was the practice earlier. Nowadays also the patient and doctor both prefer less invasive modality because of irreversible nature of the surgery. But this is what the guideline says.
Yes, doctor.
Very nice talk, Dr. Sethi, as usual. Following on from Shubhamoy's question, really. Now that we have had results from the ESCAPE trial of 8 years follow-up, early surgery has been conclusively proved to be better in terms of follow-up with the 8-year follow-up vis-a-vis endoscopic therapy, JAMA surgery publication. What are your views on it?
We are talking of pain management in chronic pancreatitis. In pain management, if ductal clearance is achieved completely, then surgery and endotherapy both are equal. If ductal clearance is achieved completely.
Yeah, but early surgery, this is the 8-year follow-up from American centers, multi-centers.
So that is the reason they are recommending the patient must be evaluated for surgery before you refer to endoscopy, unless there is some contraindication is there. Basing upon that study only, they are recommending this. Yeah,
Thank you.
agreed.
Thank you.
Thank you so much, Dr. Sethi.
Thank you.
And
Thank you so much.
Conclude this session.
So we are concluding the session. Thanks from all of us.
So thank you, esteemed speaker and honorable chairpersons, for the excellent session. Now we move on to our next session, which is on innovations in pancreatic endoscopy. To chair this session, the session is small intestinal bacterial overgrowth in chronic pancreatitis. To chair this session, may I request Professor Pradeep Bhaumik sir, Head of the Department of Medicine, Agartala Government Medical College from Tripura. I request Dr. Saptarshi Vishnu, Director, Bengal Institute of Gastroenterology, Bardwan, West Bengal. Dr. Shashwata Chatterjee, Senior Consultant Gastroenterologist, CMRI, Kolkata. And Dr. Devjoy Shao, Senior Consultant Gastroenterologist, Vinayak Multi-Speciality Hospital, Kolkata, to please come on the stage. We have as speaker for this session, Dr. Uday Ghoshal sir, who needs no introduction. He is Senior Consultant Gastroenterologist and Chief Luminal Gastroenterology Mortality of Apollo Multi-Speciality Hospital. Requesting Dr. Uday Ghoshal sir to please come on stage and start your deliberation, sir.
So thank you. I must thank the organizer for giving me this opportunity. And I was listening, lot of people, speaker before me, were referring to small intestinal bacterial overgrowth. So I think the stage is set to talk about bacterial overgrowth in chronic pancreatitis. The patient of chronic pancreatitis have all the setting to have small intestinal bacterial overgrowth, and there are consequences. For example, patients of chronic pancreatitis are often diabetic. They are often using narcotic analgesic which reduces gut motility. PPI is rampantly used in them, and therefore there is acid suppression. Many of them are alcoholic, and alcohol reduces further gastric acid secretion and may predispose to small intestinal bacterial overgrowth. So there is enough reason that they will have bacterial overgrowth. Second thing is, bacterial overgrowth will have consequences. For example, we are all referring to that they have maldigestion only. We are not thinking they can have malabsorption as well. Maldigestion is contributed by the insufficiency of pancreatic enzyme, and malabsorption result from bacterial overgrowth. And this will cause diarrhea, bloating, dyspeptic symptom, and patient can confuse that which is all related to pancreatitis only and which are not related to pancreatitis. Many of them are malnourished, and bacterial overgrowth can contribute to malnutrition and malabsorption. So what I would do is that we have recently completed a meta-analysis of all the studies in the world on bacterial overgrowth in patients with chronic pancreatitis, and I'll deliberate on this. This will be of clinical use, but also this will be for use for those who want to have a research question, and I think Calcutta young people are very, very enthusiastic now. So maybe we can do a multicentric study in Calcutta on bacterial overgrowth. So what is bacterial overgrowth? When you have bacterial growth in the small bowel in excess of 10 to the power 5 colony forming unit in the upper gut aspirate. But now we have revised the definition, and the definition is if somebody has more than 10 to the power 3 colony forming unit per ml of aspirate, this is also bacterial overgrowth, and it has important physiological consequences. So we typically use small bowel aspirate culture but it is cumbersome, it is invasive, and it really requires good microbiology support. So the office-based tool is just doing a breath test. And many of you might be having the breath test machine. Do not do lactulose hydrogen breath test to diagnose bacterial overgrowth. This is absolutely fallacious. You do glucose hydrogen breath test, interpretation is also easy. You know why? If you have a peak of more than 12 parts per million above basal hydrogen, you have bacterial overgrowth. On the other hand, if you have a peak in methane, 10 parts per million above basal, you have intestinal methanogen overgrowth. So two entities. One is hydrogen producing bacterial overgrowth and methane producing bacterial overgrowth. Whereas hydrogen producing bacterial overgrowth causes diarrhea, methane producing bacterial overgrowth causes constipation. Now this is what I was speaking about. Let us look at how common is small intestinal bacterial overgrowth in chronic pancreatitis. Till now, I could retrieve only 13 studies in the world on small intestinal bacterial overgrowth in chronic pancreatitis, and good part is of these 13 studies, 2 studies originated from India, which is also a proud moment that India contributing to the science of the globe. Now I'll come to those studies. This is the meta-analysis. You can see that in meta-analysis what we do is that you retrieve the data from each study. Now what you do is that what is the frequency of bacterial overgrowth given in that study, you tabulate. Now this is the size of the square means the sample size. Is the sample size big or is the sample size small? For example, look at this. This is a big sample size study, whereas this one is a smaller sample size study. And what you can see here, almost 25 to 30% patients who were studied in this had small intestinal bacterial overgrowth. This is proportion analysis. That means we are not talking about odds ratio. We are talking about all the studies that evaluated small intestinal bacterial overgrowth among chronic pancreatitis. There may not be any control population. What is the frequency? The frequency is 25 to 30%. And this, you can see, the small square means the confidence of this study is less. So this is 95% confidence interval, and you can uniformly see wherever there is a study which is big in sample size, 95% confidence interval is narrow. Whenever there is a study which is small in size, the 95% confidence interval is wide. That means taking a study which is small sample size, your confidence to conclude that bacterial overgrowth is there in chronic pancreatitis is much less than taking a study which is big in size. And here is the calculation of odds ratio. So what is odds ratio? You look at that what is the odd of having bacterial overgrowth among patients with chronic pancreatitis compared to control. So that means very simply, if I don't use statistical terminology such as odds ratio, if I have an odds ratio of 4, means if I have chronic pancreatitis, I have 4-fold greater risk of having bacterial overgrowth than a fellow who does not have chronic pancreatitis. Okay? So this is the odds ratio. Obviously, odds ratio can be obtained from the studies which studied control as well. Those studies which did not include control, we cannot calculate odds ratio. Odds ratio of 1 means there is no relationship. Odds ratio more than 1 means there is a positive relationship. Greater is the value of odds ratio, higher is the risk. Now let us look at why should they have bacterial overgrowth. I told you in the beginning. One more story I tell you, that patient of chronic pancreatitis, they are immunodeficient in their gut. You know why? Because in our gut, God has given, nature has given a substance. And this substance is called prodefensin. Prodefensin is released from Paneth cell, and this is an antibiotic-like substance. The prodefensin is converted to defensin, and this is done by trypsinogen or trypsin. Now, once the defensin is formed, this is an antibiotic, and this controls the number of bacteria inside our gut. Now, patients of chronic pancreatitis are immunodeficient. Why? Because obviously they have less conversion of prodefensin to defensin, which is the active antibiotic-like substance. So this is one reason. Other reason, we physicians are responsible. We keep on writing PPI, PPI, PPI. In fact, in ISG, we did not bring a document to say when you should use PPI. We said why you should de-escalate PPI. That means as a gastroenterologist, often in my clinic, I actually de-escalate PPI. And it is very difficult because once you have given PPI for more than 12 weeks, his gastrin level is very high. And the moment you stop his PPI, he will have automatic hyperacidity. This is caused by PPI. So therefore, PPI causes bacterial overgrowth. Here is a meta-analysis, and those patients in whom PPI is used in excess, that is the reason. Now, what could be the factor influencing? This is from that meta-analysis paper, which is currently under review. We looked at the data in which what could influence. We looked at, is it related to region of the study? For example, if you do in a tropical country, maybe more bacterial overgrowth than temperate country. Is it related to the female? Because female may have less gastric acid, slow gut motility, can influence. Is it related to diagnostic method? For example, some author might have used jejunal aspirate culture like Velour group did, or some author used glucose hydrogen breath test. Is it related to number of alcoholic pancreatitis in that study, because alcohol predisposes to bacterial overgrowth? Is it related to diabetes? Diabetes, in fact, in our study that we published in Pancreatology from SGPGI, we found the predictor of bacterial overgrowth was presence of uncontrolled diabetes. Is it related to pancreatic exocrine insufficiency, or is it related to previous surgery? There were some studies which did show that some of these factors are important. But when we put them into meta-analysis model, we found no factor was important. That may be because the sample size in meta-analysis you pull the data, and therefore some studies which showed that it is important, another study which is big size that could dilute that conclusion. But in meta-regression is a method of meta-analysis where we can do regression like logistic regression within the meta-analytic model. And in meta-regression, one thing was very, very clear. If somebody used an upper gut aspirate culture for the diagnosis, like Velour group did, they found half of the patient of chronic pancreatitis had bacterial overgrowth, then your frequency will be much higher than if you use glucose hydrogen breath test. It basically tells you the world literature today has underestimated the frequency of bacterial overgrowth. It must be much higher. This is because of glucose hydrogen breath test, which is less sensitive. Now, what are the unanswered questions? Is there a relationship between SIBO, symptom severity, steatorrhea, malnutrition? Truly speaking, hardly much conclusive data. And can you imagine a patient of chronic pancreatitis come to you, absolutely skin and bone? Now this fellow has pancreatic enzyme insufficiency. He has self-imposed restriction of the fat, which is the strongest or biggest source of calorie. And now this fellow has further maldigestion and malabsorption because of SIBO. There is no data. So that basically means there is an ample scope for study. Now, of 13 studies that we pulled, only 5 reported on effect on antibiotic treatment on bacterial overgrowth, only 5. And these are all non-random design, like they picked and choose people and gave some antibiotic and reported like this, that we treated some of these patients with antibiotic and there was some recovery. So hence there is a beautiful scope for doing a randomized control trial in patient of chronic pancreatitis, having bacterial overgrowth, randomize one limb, only standard treatment, all endotherapy that we do, and other limb just also give in addition bacterial overgrowth treatment and document bacterial overgrowth eradication. And I tell you, these studies individual center can't do because the number will be small. So you have to join hand. We have to just collect the data by an online electronic system, and the India should report like China, big studies. We have now in Apollo started this. So all patients who are referred to us, at least, not every patient, because people who are treating chronic pancreatitis, they decide whether he would like a pancreatic enzyme exocrine insufficiency assessment or not. And we do fecal elastase, but we have started this novel technology. This is not fecal Sudan. Here what we do is that we do fecal Sudan, look at number of fat droplet, look at size of each droplet and area of the droplet, and it gives a very good correlation with quantitative fecal fat. Small intestinal bacterial overgrowth is also known in chronic pancreatitis, but hardly any study. Doing such study is difficult because most of these patients will be on pancreatic enzyme replacement therapy. I will not talk about pancreatic cancer. So therefore, I would say that meta-analysis of 13 studies, the meta-analysis is under review now, so it will be probably published, showed that we have more question than answer. Whatever whole world did in last 50 or 70 years is just to say how frequent is bacterial overgrowth, but we don't know what is its significance. We don't know what came past. Did bacterial overgrowth come past or did pancreatitis come past? Thank you so much. I must invite you for our Congress, Neurogastroenterology Motility Association Congress, which is going to be held in Calcutta in August 30th and 31st. Thank you so much.
Thank you, sir. Thank you very much. As usual, Dr. Uday Ghoshal, this is a very nice presentation. And definitely we have explored a new area of SIBO, and I believe there will be some question. Dr. Konar sir is ready to ask you some questions.
Uday, just I want to ask you, what about this lactose breath test? You said you should not do. Can you explain why?
Yeah, you see, lactulose hydrogen breath test was popularized by Mark Pimentel. And I remember about 20 years ago when I used to go to SCG, Mark will be on the stage and talking about lactulose hydrogen breath test. And he found all IBS patients, as high as 90%, they were having bacterial overgrowth. So that means according to Mark, there is no IBS in this world, all are due to bacterial overgrowth. But what was the basic fault in Mark's mind? Mark thought that everybody will have a mouth to cecum transit time which is longer than 90 minutes. Now what is mouth to cecum transit time in India? It is about 60 minutes, median mouth to cecum transit time. What is there in Taiwan? It is about 80 minutes. So according to Mark, all Indians have bacterial overgrowth. Mouth to cecum transit time is a physiological phenomenon. It cannot be a fixed number. So he said if any peak occurs before 90 minutes, it must have occurred from the small bowel. It has not occurred from the colon. Now later people have done studies like I remember Stephen Venner did a study published in Gut. He followed radionuclide along with lactulose. And by gamma camera he showed when peak occurred before 90 minutes, already the radionuclide was in the colon. And there is a problem in this Western journal. They have tremendous bias. So what happened is, those fallacious statements, those fallacious systems were all published one after another in big journal. So therefore, there is a sort of fallacious entity pushed onto our mind. Now whole world accepted that this gives you often false positivity.
Sir, this one small query. So CP increases SIBO, but if a patient on part not gaining weight, the first step which we take is adding a PPI. Adding PPI. I mean, patient on PART.
Oh, yeah, that's right.
So that increases the risk of severe. So how you tackle that?
Yeah, you see, it is like I'm not a clinician alone. I'm a clinician scientist. So I always explore. If you have to give PPI and PART, yes, you have to give. But then if the patient has come because of non-response, I'll not empirically like to give rifaximin. I'll test for bacterial overgrowth, because if I confidently diagnose the condition, I'm in a safer ground to treat him. If rifaximin doesn't work, I'll give next level antibiotic. He may require repeated courses. But if I fire in the darkness, like without testing, if I give rifaximin, whether the patient responded or not, I don't know. So my job is to do a simple test, reasonably cheap test to know, does my patient have bacterial overgrowth or not, rather than empirically giving rifaximin. Okay?
Sir, is there any correlation between zinc level and patient with chronic pancreatitis with SIBO?
Yeah, what is it? Zinc level?
Zinc level.
Oh, no study. It makes sense, your question is important, but there is no study, and it can be opening of a new study. And in fact, people don't know, those who have bacterial overgrowth, do they have different B12? Because pancreatitis patient may have B12 malabsorption, because we know that B12 get bound to the intrinsic factor and R factor, and then it is the pancreatic enzyme which breaks it and liberate the B12. So, is somebody having bacterial overgrowth plus chronic pancreatitis will have more B12? There is no literature. One study showed their B12 level increased after antibiotic treatment, only that information. There could be fat-soluble vitamin deficiency, all these requires further study.
Thank you. So, we are closing the sessions. Thank you.
So thank you, respected faculties and chairperson, for the excellent session. Now we move forward to our much awaited session by our chief guest. To chair this session, may I request Professor Jyotirmoy Pal sir, National President, Association of Physicians of India, currently Professor, Department of Medicine, College of Medicine and Sagar Datta Hospital, to please come on the dais, sir. May I request Professor Anita Datta Madam, former Professor, Department of Medicine, NRS Medical College, Kolkata, to please come on the stage, ma'am. I request Professor Nandini Chatterjee, ma'am, Professor, Department of Medicine, IPGMAR and SSKM Hospital, Kolkata, to please come on the stage. I request Professor Ashish Shah, sir, HOD, James Bajbaj, Kolkata, to please come on stage. I also request our organizing chairman, Dr. Ashokananda Konar, sir, Senior Director of Gastroenterology, Peerless Hospital, Kolkata, to please come on the stage, sir. Now, it is our honor to have as speaker Dr. D. Nageshwar Reddy, sir, among us. He needs no introduction, but to go with the custom to read out his introduction. Dr. D. Nageshwar Reddy is the chairman and founder of Asian Institute of Gastroenterology, AIG, at Hyderabad, Kolkata, India, which is the biggest gastroenterology hospital in the world. He received Padma Shri Award in 2002 and Padma Bhushan Award in 2016. And we are honored to announce that he has also received Padma Vibhushan Award in 2025. He is the recipient of Rudolf Schindler Award and also Master Endoscopic Award, which is considered equivalent to Nobel Prize in Endoscopy by the American Society of Gastrointestinal Endoscopy. He has published more than 450 articles in various national and international peer-reviewed journals and contributed numerous chapters to international gastroenterology textbooks and has edited 3 GI endoscopy textbooks. He is the mentor and teacher to many of current generation of gastroenterologists. So, it is a pleasure and honor to welcome D. Nageshwar Reddy, sir, on stage. Thank you, sir. Now, may I request Professor Nandini Chatterjee, ma'am, and Professor Anita Datta, ma'am, to kindly felicitate our esteemed chief guest, Dr. Reddy, sir. Requesting Professor Jyotirmoy Pal, sir, and our organizing chairman, Ashokananda Konar, sir, also to come forward to felicitate, sir. It is an honor to have sir among us. Thank you, sir, for coming all this way to Kolkata. Thank you. Thank you, sir. So over to, without wasting further time, I request our chief guest, sir, to address with your valuable speech, sir.
Just to, it is futile to introduce Dr. Reddy, and the subject is so dear to his heart, and we are really pleased that he is here to tell us all about endotherapy. I just remember 25 years back when I used to visit Hyderabad very often, and we first came to these novel words like secretin-induced MRCP, Professor Michael Kremer, and all these, and that was the beginning of endotherapy, maybe 25 years back in our country. So over to Nagi to tell us the story of endotherapy and where we stand today compared to yesteryears, and especially in relation to surgical, methods. Because there was a debate all the time whether the surgeons are much superior to us in modifying the natural history of chronic pancreatitis. Over to you, Nari.
Thank you, Ashokanand Kunar, and I'd like to thank the organizers for not only giving me this opportunity to be a part of this very important conference, but also that I have such a distinguished panel of chair people here. I think they are all very well known in their field, so I'd like to thank them for coming here. So I've been asked to talk on innovations in pancreatic endotherapy. Over the last 25 years, as Ashok had mentioned, there's been a better understanding of the physiology of the pancreas and better understanding of how to treat many of these. The controversies between surgery, endoscopic therapy and so on is to a large extent resolved now because of these studies. But it all started actually, if you see, in 1968, the first reports of pancreatic endotherapy was done by McCune, who was a surgeon. He tried to cannulate the pancreatic duct using a very, very primitive type of scope. To do a single ERCP, single pancreatic duct, he took about almost 4 hours for a single case, and after doing 50 cases he gave up because it was not very worthwhile. In 1970, Itaru Oi, a Japanese endoscopist, made a special endoscope, and then with that endoscope he is able to consistently cannulate the pancreatic duct and bile duct 70% of the times. So this is when the true pancreaticobiliary endotherapy started with Itoi in 1970. And most of the work in pancreatic endotherapy occurred with these pioneers you can see on this, and Michel Kremer, as you can see here, we have a point. Michel Kremer is seen here, very distinguished person, and he had come to Hyderabad, Ashok was mentioning. He is considered the father of pancreatic endotherapy. There were several others also who were contributing to what happened to pancreatic endotherapy. But there are 3 special people whom I think all of us in India have some of us have been trained with them, but they are the ones who contributed, are known as the pioneers in pancreatic endotherapy. Nip Sohendra in Germany, Peter Cotton was the one who gave all the terminology, and of course Michel Kremer. All of them have been to India, and of course I think many of the Indian endoscopists have been influenced by these individuals. One of the things that has happened over the last at least 5 years is that now pancreatic ERCP is no longer used as a diagnostic modality. If you look at historically, most of the classifications of say chronic pancreatitis and so on were done based on ERCP findings. Now we will never do an ERCP for diagnostic purpose on the pancreas because of the potential of developing pancreatitis, and also because we have better methods like MRCP, endoscopic ultrasound and so on, and therefore diagnostic ERCP is out. So let's come to what we can do in therapeutic endoscopy in different types of pancreatitis. We start with acute pancreatitis first, and we know that there are 3 areas where endoscopic therapy is useful. In the acute stage, when say there is a gallstone pancreatitis, we know that sometimes pancreatic endotherapy helps, especially if the stone is impacted like that. In 2 weeks time, when there is a ductal disruption, there is a little controversy in this area, but some pancreatologists have put in stents here to stop the leakage, and of course after 4 weeks, when there is a pancreatic walled-off necrosis, this is where endoscopic therapy comes in. Let me just go through a little of this. In fact, urgent ERCP, that is doing ERCP within 48 hours after the onset of gallstone pancreatitis, was a very controversial subject. Theoretically it should be useful, but if you look at the number of studies all of them having different outlines. You can see that this is because ERCP is an operator dependent procedure. So, good ERCPs can produce good results, a bad ERCPs will produce a bad result even in a good situation, and therefore, these types of randomized studies are very difficult to do properly, but the current recommendation by all societies is that only indication for urgent ERCP in patients with gallstone pancreatitis is when there is cholangitis. If there is no cholangitis, we do not do ERCP. That is very, very clear now, that has come. And it's become much easier now for us because of the advent of endoscopic ultrasound. When you do an endoscopic ultrasound, if you find the stone in the common bile duct with acute pancreatitis cholangitis, then you can go and do ERCP. So, our current algorithm has now changed a little. Earlier, suspected biliary pancreatitis, cholangitis, LFT, abnormal ERCP, and only in 40% of the cases were we finding CBD stones. But now, suspected biliary pancreatitis, we do LFT, we do an endoscopic ultrasound. In 90% of the cases, we have a stone which can be removed from the bile duct. So, a change that has occurred over the last 10 years. Coming to complications of acute pancreatitis, again this is very interesting. If you look at what happened in patients who developed a walled-off necrosis, we started first in 75 with aspirations, pistulotomy. 1990 the stents came. We started putting these plastic stents. Then endoscopic ultrasound guided drainage. We stopped endoscopic drainage, went into US guided drainage, and then 2000 the first necrosectomy actually was reported by Todd Barron, a very heroic procedure. The director of the hospital called him and scolded him for doing this procedure because it was so dangerous, make an opening in the stomach and going in. But soon it became the standard procedure once these new types of stent came. So, we started using this lumen opposing stent soon. So, the first necrotectomies were actually like Notes procedures, going in, removing necrotic tissue. The mortality rate was 50% in these patients, but still some of the people pursued till the stents came. With stents it was much safer. We have these specialized stents which is put between the stomach and the walled-off necrosis. We have 3 of them now available commercially, which are used very often in our procedures, and this has made it very easy to do these procedures. So, in patients who have plain pseudocysts or very minimal necrosis, we put the plastic stents, but patients who have 30% or more necrosis, we put this biflange stents. So, this is the standard of treatment now. So, there are various ways of doing this endoscopic walled-off necrosis, necrosectomy, and this my colleague Sandeep has described this step-up approach. Of course, I think there are also experts like Rajesh Puri here, Sandeep is there. What they have now described is not to directly and do a necrosectomy, but to put a stent inside, wait till all the liquid material goes in, and then go inside and try and remove this using different techniques. So, this is called a step-up approach, and we have found that using step-up approach it's extremely safe to do this procedure to completely clear the necrotic material. So, the 3 important clinical questions that have come up which I will try and answer. One is, should we use self-expanding metal stents which are costly, or should we go for plastic stents which are cheaper? The second is, when you remove the stem, sometimes there is recurrence of this fluid. So, should we use plastic stents after this or only in some people? And the third important clinical question is, if the patient has a walled-off necrosis, should we go in symptomatic patients before 4 weeks, that is before a wall has formed? So, these were not answered till recently, till we now have studies which have answered them. For example, this is my colleague Kriti who just published this paper where she looked at plastic stents versus this special biflanged stent in patients with walled-off necrosis. And you can see that the overall clinical success, whether they use plastic stents or this metal stents, were similar. The only difference is people who had plastic stents required more interventions. Therefore, if you want to do only one intervention, not multiple, then metal stents are better, but they are costlier than plastic stents. There are problems with metal stents also, and this is a paper which Shyam Vardharajulu group published, where they showed that when you use plastic stents, it can hit against an artery and the chances of bleeds are there. So, some complications with metal stents one should be aware of. The second important question that we try to answer is that what happens is many of these patients with walled-off necrosis have a disruption of the pancreatic duct. So after 4 weeks, when you remove the metal stents, the fluid can again collect, recurrent. So therefore, some people have advocated that in all patients with walled-off necrosis, after removing the metal stents, put a plastic stent as a routine procedure. This is the Western standard. So we actually tried to see if this is true for us, and this again, Radhika Chavan was working with us, who's published this paper, where what we did is we randomized patients after 4 weeks into those who had a plastic stent and those who did not have a metal stent, only metal stents removed. This is metal stents removed and a plastic stent put in, and you can see that the difference is not so much whether you put. So at least from our standard, from Indian standards, we now say that all patients with walled-off necrosis, you don't have to replace the metal stent with a plastic stent. You have to see what is the type of patient. If the patient is a large one in the head and neck region, these are the group of patients who may require replacement of metal stents with plastic stents. So the third important question is, suppose the patient before 4 weeks, before the walled-off necrosis has developed an infection or fever, how should we drain these people? Should we do an endoscopic drainage? Here, the literature is very mixed. This is Guru's unit who showed that in early cases, even up to 2 weeks, they were starting to drain these patients endoscopic, but unfortunately the complication rate is very high. So what we can now do is follow the Dutch study which was published in New England Journal, where they showed that if you wait up to 4 weeks, then drain this walled-off necrosis endoscopically, it's safe. If you have to drain the patients before 4 weeks, we do it percutaneously. So again, very simple principle. Before 4 weeks, percutaneous. After 4 weeks, you can use a endoscopic drainage. Now, coming to recurrent acute pancreatitis, here also we have various indications for therapeutic intervention. For pancreas divisum, we do sphincterotomy stenting. For ampullary tumors, ampulectomy, and of course parasites seen in some parts of our country. So if a patient has a pancreas divisum with a Santinero seal like this, we know that this patient will dramatically respond to endoscopic therapy. But most important, all patients of pancreas divisum don't respond. So in clinical practice, if you have a patient coming with recurrent pain, MRCP shows pancreas divisum, it does not mean that this patient should undergo ERCP and stenting. In fact, recent studies are against sphincterotomy and stenting these patients. But you can decide which patients are likely to respond, and you can see Rupjyoti's article in this. Pancreas division patients who have abnormal genetic associations, like for example cathepsin B or CFTR mutations, these patients will respond. So nowadays in our unit, what we do is MRCP in a pancreas division, we do genetic analysis. We can divide those patients who will respond to endoscopic therapy, those who don't. Then this care can be done. Now, chronic pancreatitis is the area I think you've been hearing a lot about chronic pancreatitis. The cause of pain in chronic pancreatitis is very complex, and the only indication for intervention is pain, no other thing. You don't do endoscopic intervention for diabetes or malabsorption syndrome. And so you heard a very nice talk by Uday now. For all those things, endoscopic intervention is not there, only for pain. Pain is very complex, and again this is Rupjyoti has published this very nice cartoon on why pain occurs in this patient, but basically it's two causes. We used to think that ductal hypertension was the main cause of pain earlier, but now we are shifting slowly. Now we think that pancreatic neuropathy is the more important cause. So this is a very important concept. I'll tell you why. Because if we earlier on we saw patients like this with stones in the pancreatic duct or strictures, we would be very happy as endoscopists. We go and remove the stones, or we can go and put stents. Stones are not easy to remove. Look at this. This is from G.V. Rao, my colleague, who is a pancreatic surgeon. Even after doing pancreatic surgery, opening up, these stones are difficult to remove because they're stuck to the mucosa. They don't come out easily. So endoscopically, not easy to remove them. And this is a very historical slide that I borrowed from Michel Kramer. You can see the stones here stuck there. The first case of pancreatic endotherapy, true pancreatic endotherapy for chronic pancreatitis, was done in a unit where they did a combination of extracorporeal shock lithotripsy. They borrowed this from the urologist at that time, broke the stone into small bits and took it out. And that has become the standard now therapy. So in patients, again I think Sushant has presented this, patients have stones larger than 5 millimeters, we would do extracorporeal shock wave lithotripsy, break this into small bits, and then remove these stones after doing endoscopic sphincterotomy. This has become the standard technique. And of course, sometimes we have to put in stent if strictures are there. Now, this procedure has not been duplicated in rest of the parts of the country and many parts of the world. They tried it, but they can't do, because there are three important things when you're doing this procedure for success rate. One is the machine. There is a very standardized, this is an extremely expensive lithotripter, not what the urologists use. This is a third generation lithotripter costing more than 10 crores. So most hospitals don't want to invest in this. Second is the operator. This doctor here, Dr. Vinod, in our unit, for last 20 years has only been doing this, nothing else. His only goal is to break stones in the pancreatic duct. It's a boring job, but he likes it. So he's become a real expert in this, so operator. And third is that we have now we actually do epidural anesthesia, and this is the way to achieve success in this. If we have these three combinations, your success rate goes to 90%. If you don't, then it's very disappointing. If you send your patient with pancreatic calculate urologist to break the stones, the success rate is very low. They don't do it and you don't get good results. So, very important. Because the ultimate aim is to break this into such small, like sand, so that you can easily flush out. Ultimate result should be less than 3 millimeter stone. And this is an example. You can see this is a patient, we had a large stone here, broke, and then you can see completely cleared the duct. We have now got the world's largest experience with this type of modality. We have completed almost now 15,000 cases where we have done chronic pancreatitis stone, and this is a earlier series that we published in 2019, 5,000 cases. You can see that in over 90% of the cases we can actually break these stones into small bits, and then we can actually remove them very easily through endoscopic therapy. But can we predict which patient is likely to respond? This is very important, because patients come to us, say, okay doctor, you can do this endoscopic therapy, but I'm spending so much money. If I don't respond, what should I do? Are you sure I'll respond? So again, Nitin, one of my colleagues, has published this very important article where they shown there are certain features that suggest that this patient is likely to respond to endoscopic therapy. If the stone is in the head, duration of the disease is less than 5 years, intermittent pain is there, not continuous pain, there is no narcotic use, and if the patient stops smoking and alcoholism. These are the patients. So if I get a patient, I'll immediately put him and see, does he fall into this category? If he falls into this category, I'll tell him very confidently, you will respond to endoscopic therapy, let's go ahead with that. What about long-term treatment? I think this is long-term response. And again, Manu Tandon has published this from our unit, very large study showing that even after 8 years, many of these patients who had endoscopic therapy will respond, they'll be pain-free. And this is a landmark article, one of the most important articles in pancreatology published from India, came from, again, Roop Jyoti has shown by the so-called SHOK trial, published in Annals of Internal Medicine, that endoscopic therapy, ESWL with endoscopic therapy, definitely has an impact in decreasing pain, at least up to 3 months. The longest term studies are being done in these patients who have underwent this form of therapy. If the patient has a radiolucent stone like this, you don't require any ESWL. Very simple. I am very happy if I see a patient whose stones are not having calcification, only on ERCP we see. We do a balloon dilatation and just remove this very, very soft proteinous stones. They come out very easily. So if they are very large, if they are not radio-opaque, they can be removed very easily from the pancreatic duct. This is example. For pancreatic strictures, we put in stents, but our philosophy of stenting has changed in these patients in recent years. We don't put one stent, we do a balloon dilatation, put in multiple stents, at least 3 or 4 stents, which remain for a while, 1 year, not shorter, 1 year minimum, and then remove the stents, and these patients will then respond. Again, we learn from our mistakes in the earlier days, just putting a stent, coming out, putting a stent, it doesn't help. Unless you put multiple stents, dilate the strictures to a large area, they don't help at all. So single strictures, multiple stents, stenting for more than 1 year, your success rate goes again to more than 90%. There have been some studies, and we have also been doing some. We have started to use this special type of metal. It's called the bumpy stent. It's made in Korea, specially for pancreatic therapies, and we find that if you put these stents for about 6 months, it's as good as putting multiple plastic stents. Still not completely established, still not in the guidelines, but this is a therapy that we have been using in some of our patients. If ERCP fails, for example, if the stone is very dense, completely blocking the duct, then we can actually go through endoscopic ultrasound guidance and then put in these wires and all through the pancreatic duct. I think this is an alternative that we have. But I think truly doing randomized control studies like earlier Uday was mentioning in say bacterial overload, even in ERCP is going to be not so easy in this patient. So there's been a lot of issues, debates among surgeons and physicians whether they should do surgery or endoscopic therapy. And let me show you a classic example of these controversies. This is a very famous trial called the ESCAPE trial, which was published in JAMA, and you know that JAMA has got a very high impact factor like annals. So in this ESCAPE trial, when they first published it, they did this study, compared endoscopic therapy with ESWL with surgery. And you can see the two lines are very separate. Surgery people did very well, endoscopic therapy did not do well. And the conclusion from this study is surgery is better than endoscopic therapy. This was a study published in JAMA, people accept. But actually when we took this study and dissected it carefully, we found it's not 2 graphs but 3 graphs. This green one is patients with endoscopic therapy who underwent complete clearance of the duct. And this one is not complete clearance of the duct. So if we took patients who actually responded well to endoscopic therapy, the results are same as surgery. But unfortunately, the authors when they presented didn't do this, so you got a wrong result. So therefore, it's a very complex issue. There's a lot of debates going on, but I like to simplify this. In fact, me and a famous pancreatic surgeon, Winston, wrote an editorial on this sometime back in gastroenterology. And what we believe is we want to simplify the whole thing. If you had stones in the head region, dilated duct, these patients will respond to endoscopic therapy. If you have multiple stones, dilated duct, good expertise, this patient will respond. But if you have a situation like this, multiple stones, strictures and so on, these patients don't respond, they should go for surgery. So very simple, just based on a plain X-ray and MRCP, you can decide on your patients with chronic pancreatitis, should they go for endoscopic therapy or surgery. Important, a little controversial, but a philosophical view is that patients with pain for chronic pancreatitis, the pain is because again, Shashant, I think Shashant has very nicely told about pancreatic, ductal hypertension, pancreatic. All these years we thought because of the block of the pancreatic duct, pressure increasing, the pain is coming. But is this true? In fact, most of the studies were based on these very old studies on cats. You know, very difficult to actually say whether the cat has pain or not, but most of the studies were published on that. Some human studies were done in surgeons long back, but humans, again, it was a very studies which didn't show a pattern which was there. In fact, our group, Sandeep, Rupjyoti, and along with Johnson Hopkins group was doing this, where we can now measure the pressure in the pancreatic duct using these cardiac catheters. And again, the view seems to be that it's all over. There's no evidence suggests that clearing the pancreatic duct of stones actually relieves complete pressure. So what we believe is that sometimes extracorporeal shock wave is not only actually clearing the duct, but is acting in a different way. And we got this example from our orthopedic surgeons. They are using extracorporeal shock wave for osteoarthritis, for shoulder pain and so on, very effectively. Over 1,000 articles have been published in this area in orthopedics, and as gastroenterology we ignored that, we didn't look at it. They got a lot of not only articles, but also they've shown a pathophysiological pathways, how extracorporeal shock lithotripsy actually decreases the inflammatory cytokines and produces relief of pain because of this effect on bare nerve ending. So based on this, we have started a small study now. We've taken patients who have non-obstructive caliculi or non-calicular chronic pancreatitis with pain, very small group, you can see that extracorporeal shock wave is given not to completely clear the duct, but just to hit the nerve endings. We know that the bare nerve endings, I think Roop again has done a lot of work in this area, bare nerve are hypertrophied, they become very big, they are very sensitive and they are hypersensitive. And when you do extracorporeal shock wave, you actually hit this and break those, and then you can see the pain score is coming down. So these patients, so it's a combination effect that ESWL actually is doing, and this is a new concept that we are working on. Of course, if you can't break these stones or when there is no facility for ESWL, people have done pancreaticoscopy with laser to try and clear the stones, but this is a procedure we can do, but I'm not for it because I think basic principles of treating pancreatic pain is not clearing pancreatic stones. You can clear using laser, but that's not the principle, because even after clearing the stones, they still continue to have pain, many of these patients. But in Europe, United States, where facilities are not there for ESWL, they're trying to promote this technique of using pancreaticoscopic laser to break the stone. I think this is something that I would not suggest very strongly. So just to conclude what is happening in this area, if you have a patient with dilated ducts, stones, single or multiple, combination of extracorporeal shock wave lithotripsy with endoscopic therapy is good. You can actually completely clear this. But if you have a patient head mass or multiple stones with strictures, these patients should go directly for surgery. We should not mess with them. Because they are patients, the most difficult patients with chronic pancreatitis are non-dilated ducts and node stones. How do you treat them? We can do celiac ganglion block, but unfortunately it's very short term. There are other techniques, again Sushant has discussed this, but I think these are the most difficult patients to treat. But generally it's a combination of a teamwork, physicians, endoscopists, surgeons, interventional radiologists, all coming together. And this is very important to emphasize, that it's not a turf war between endoscopists, surgeons and physicians. It's that we all get together to treat these patients. Two other important indications of pancreatic endotherapy in recent years. This is patient neuroendocrine tumor, especially functioning neuroendocrine tumor. Again, my colleague Sandeep has described this for the first time, where in these patients who have insulinema, this patient actually had severe hypoglycemia, very obese. The surgeons didn't want to take him for surgery. Using radiofrequency ablation, we could obliterate this insulinoma completely with dramatic results. And since then, it's now become the standard of therapy in patients with insulinoma, especially if they can't go for surgery. Similarly, another indication for RFA is advanced pancreatic cancers. You can't do surgery for these patients. They give them palliation, they give them chemotherapy. But now a very recent article, again this is the work that we have done with our Korean colleagues, have shown that a combination of radiofrequency ablation with chemotherapy can not only decrease pain in these patients, but can actually prolong survival. So a very interesting concept that's coming up, and I think many patients with advanced pancreatic cancers are now going to be treated with this combination of radiofrequency and very good chemotherapeutic agents. So this is finally, I think it's very important that when you're treating patients with all forms of pancreatic disease, chronic pancreatitis, acute pancreatitis, pancreatic tumors, a team is very important. And this is a pancreatic board that we usually have. All patients with complex chronic pancreatitis, walled off necrosis or pancreatic tumor goes into the pancreatic board. And then we decide, and we find that when we do this, you get a balanced opinion. Sometimes what endoscopists think they can do, we now realize that surgeons can do better. And what surgeons were doing unnecessarily, endoscopists can be true in a less minimal invasive way. So this is a very important way to treat patients with chronic pancreas, because pancreas is a very complex organ, very difficult to treat very easily, and therefore I think it should be a team effort. And finally, for the postgraduates, I strongly recommend the new edition has just come out, ERCP. This is a Bible of ERCP standard textbook, where all these concepts are very well molded together. It's worth going through it, especially for the postgraduates. Thank you very much for your kind attention.
Actually, we are not having any questions.
Okay.
So if you have any questions, you can talk to Dr. Reddy during tea time. Thank you so much.
Thank you.
For the next session, may I call on stage Dr. Kingshuk Dhar, ex-HOD, Department of Gastroenterology, RGCAR, to please chair this session. Dr. Partho Sarkar, ex-professor, CNMC, Department of Medicine. Dr. Trombok Samanto, Associate Professor, Department of Gastroenterology, Medical College. And Dr. Shambho Samrat Samadar, Consultant, Diabetes and Allergy Asthma Therapeutic Specialty Clinic, to kindly chair this session. And may I please invite on stage our next speaker, Dr. Roopjyoti Talukdar, Director of Pancreatology, AIG, Hyderabad.
So I'll start. Yeah.
Okay. Thank you for this next session. Please start the session since we
Very good evening, and let me begin by thanking Dr. Konar, my friend Sanjay, for having me here. So this year actually I have been assigned a little complicated and maybe conscientious topic, but I think I'd like to speak on this because we can bring out many newer ideas or see actually what we are doing, has it been correct all these years. So we have been talking about lots of studies in pancreatitis and trials in pancreas. Several results are the randomized controlled observational study. But why this question now after so many years and so many studies? Are we doing it right, all the studies in chronic pancreatitis? So first let's begin with pain. In fact, Charles Darwin had told several years back, pain is a homeostatic emotion, and that is essential for the survival of species, which is very correct, as long as it is short-term pain, the fight and flight response. But when it comes to chronic pancreatitis or chronic pain for any reason whatsoever, things becomes very messed up and becomes complicated. So let's look at the results of some of the recent studies on chronic pancreatitis and pain. So this is a landmark study published several years back in New England Journal, and where they compared surgical drainage versus endoscopic drainage of the pancreatic duct. And the initial results at 2 years of follow-up showed that surgery is better in pain reduction. But when the study was followed till 5 years, then if you see the primary outcome, the SBK score, there was no difference in the pain relief in the surgical and the endoscopic arm. And the same group actually had published this study called the ESCAPE trial a couple of years back. And if you see here, this looks very impressive. The red indicates the endoscopy first approach, the blue indicates the surgery first approach, and there was a significant improvement in pain in patients who underwent surgery. These are all comers. But if we dissect this patient, and when they themselves publish this data, a patient who actually underwent endotherapy and actually underwent surgery, there was no difference in pain. So even though surgeons might believe that surgery is better, but this supplementary data tells us that actually surgery and endotherapy are similar. And again, what they did was they followed these patients up till 8 years. We heard that a few minutes back by someone in the audience. So they said that the early surgery but not endotherapy should be the first approach. But again, if we look carefully, this follow-up study was grossly flawed. There were non-standardized follow-up, retrospective nature, one time point in the analysis, non-standardized interventions. And statistically speaking, the effect size became very small because many of the patients dropped out. 30% of the patients dropped out. And locations of the intraductal calculi and distribution of strictures are not described. So that's where we wrote this letter to JAMA Surgery, where Dr. Jivira and Dr. Reddy was also involved, and this actually shows the flaws of this study, and therefore we cannot say that surgery is better than endotherapy. It still holds that surgery could be same as endotherapy, right? So that was about surgery. Now let's look about the endotherapy literature. Again, this is a list of several studies, including 3 from our group headed by Dr. Tandon. If we look at the results, now if the patients, so these are very good numbers, 85% pain relief, 84%, 82%. If we look at the follow-up, it was just around 6 to 12 months. But if these patients are followed for a longer time, 5 years, 6 years, there is a drastic reduction in the proportion of patients who has pain relief. This indicates that there are issues with durability of the treatment. They respond early, but their response may not be sustained for a long time, a question of durability. And again, Dr. Reddy just talked about this article where we compared endotherapy ESW with sham, and it's always, there should be a sham or placebo group that only will give you the right kind of response rather than just comparing one-arm study. So here, when the patients who underwent endotherapy, there was a significant reduction in pain, and the primary outcome of the study was at 3 months, and at 3 months there was significant improvement in pain compared to the sham. There was a significant reduction in the days requiring opiates and days requiring pain medications and hospitalizations. That's at 3 months. Now let's look at something a little bit more into the other time points. Now, you had heard about the concept of confidence interval in Dr. Uday Ghoshal's talk. So these, the lines above and below the dots are the confidence interval. If there is an overlap in the confidence interval, for example, here, there is some overlap between this and this, so this is not significant. But if we follow this study, even at 13 weeks, 14 weeks, 16, 17, 19, 20, all these time points also there was a non-overlap of the confidence interval, which means that this benefit was sustained up till 23 months. But in between there were periods where the benefit was not there. Again, this means that the results beyond 3 months were heterogeneous. So why is this happening? Before coming to that, let's look at the another study where again a discussion on this happened on a non-enteric coated enzyme in pain. So if we look here, again the concept of non-enteric coated enzyme is to reduce enzyme secretion into the pancreatic duct. That will reduce the pancreatic hypertension, ductal hypertension, less pain. And this is a randomized control trial we finished a few months back, where we compared placebo with non-enteric coated enzyme. And if you see here, there was no difference between the placebo and the treatment arm. So again, showing that all kind of treatments are not effective or viable. So all these studies that had shown dealt with ductal hypertension, the so-called ductal hypertension or ductal pathology. Now let's look at the studies which dealt with the parenchymal or acinar injury or acinar events like oxidative stress and pancreatic neuropathy. So if we see here, this is a famous study from the AIMS group, Dr. Pramod Garg and his team, way back in 2019, where they could show that there was a significant improvement in patients on pain who received antioxidant, and that persisted to 6 months and beyond. Again, another study on the mechanistic aspects, the neuropathy, the use of neuromodulator like pregabalin showed a beneficial response, and this is a study where we combined antioxidant and neurotropic pregabalin, and again combination of these two had a sustained pain response beyond 6 months. So why this difference? So in the interventional trial which dealt with the pancreatic ductal pathology, they did not fare well, or there was non-sustained response, but in the medical or mechanistic test studies there was a sustained response. So to answer that question, first let's look at the structure of RCTs in general. What is a randomized control trial? So first a hypothesis and a research question is generated, and then enrollment and randomization will happen. So one group will be assigned to a treatment arm, it can be anything, the other can be in the placebo arm, and then there will be a primary outcome which is evaluated, right? So let's look at examples. So let's take the example of malaria. There are many physicians here, so let's take the example of a new anti-malarial drug. So what will happen? The primary outcome would be parasite count after giving the drug. What is the parasite count in the treatment arm and what is the parasite count in the non-treatment or placebo arm? So, similarly, suppose let's try a new anti-arrhythmic drug. The primary outcome would be ECG change. What is the ECG change in the treatment arm and in the non-treatment arm? So these, if you see parasite count, ECG change, LFT levels, bilirubin levels, these are very objective outcomes, objective parameters. It won't be affected by patient's psychology, patient's physiology. It's pathological. But what happens in chronic pancreatitis? So let's quickly look at the pain. So this is how the progression of pancreatitis, chronic pancreatitis happens from recurrent acute to chronic, and there will be lots of pathophysiological events. With time, there will be development of sensitization. Again, even later on in the disease, there will be anxiety and depression. So we already see beyond ductal hypertension, there will be something called sensitization, and so the objectivity here is gone. There are 3-4 mechanisms involved. Again, a similar kind of concept. As the disease progresses, there will be nociception. As the disease progresses further, there will be involvement of spinal cord causing spinal hypersensitivity, and finally there will be central neuroplasticity. So when we do a treatment dealing with the ductal pressure or ductal stone, we just think about the morphology of the pancreas, stone in the duct and pain. So this is very linear. But as I showed in the earlier 2 slides, as the disease progresses, there will be changes in the brain metabolites, neuroplasticity, depression, and several things comes in. So even if we take a patient who has a stone, he will also, or he may also have several other mechanisms, anxiety, depression, altered metabolite, sensitization. So here the linearity is gone. Even though we believe that we are treating a patient with a stone, but we are actually treating a patient with multiple comorbidities, multiple other factors. And we don't know which patient has which factor at that given time. So the linearity is gone. So it is non-linear. So this is a major difference from the objective outcomes like antimalarials and antiarrhythmics. Now, if we see, the disease begins with nociception. When the pain receptors within the pancreas gets activated, there will be pain transmission. And this is because of the acute stimuli. These are transient pain. There will be sensory features of pain, the quality, the location, the duration. So the patient can tell us the pain is like stabbing. We have, the pain is localized in the epigastrium, it goes to the back, the duration is like 5 minutes, 1 or 2 or whatever. So this is during the acute phases, early stage. But as the disease progresses, there will be involvement of recurring pain, and because of recurring pain, many other areas of the brain like the nucleus accumbens, hippocampus, hypothalamus, all these areas are involved. And these are the areas that are responsible for the emotional processing of pain. The patient will have pain memory, there will be emotional responses, motivational responses. So at this point, it's not only the nociception that is affecting. So the disease gets converted from a peripheral pancreatic disease of pain transmission to a brain disease of pain perception and experience. And this is where the subjectivity of the response comes. So this is where, based on the patient's baseline emotional response, they'll relate to the pain or react to the pain differently. Some patient will react to the pain in a positive way, they will have significant improvement, some may not have. So this is subjectivity. And finally, let's look at pain phenotypes that we can, and these are actual true patient phenotypes, and you will relate to this patient. Let's take example of patient A. So, and this is the pain pattern for a 1 year period from 0 month to 12 months. So he has pain of this pattern initially. Let's say, look at pain, patient B, he has pain, again there is a real improvement of pain, and then again there will be a relapse of pain with a higher intensity, and this is a patient who has almost continuous pain all over the year, all through the year. Let's put them in a clinical trial. This is where we enroll the patient, and they all fulfill the definition of chronic pain. And let's look at the outcome measure at this point, endpoint 6 months trial, hypothetically. Now if we look at patient A, and we treat, and he falls in the active arm, there will be no pain, relapse in the 6 months period, so it will appear that the patient has a true effect. If the patient is in a placebo or sham group, it may appear that the patient has a placebo effect. But these patients, even if you don't do anything, by virtue of the natural history, you'll never have pain. So the placebo or active or true effect is actually not the real effect that we are looking for, but the drug will get the label that, okay, this drug is working on this patient, which may not be correct. Let's look at patient B. Initially he has a improvement, but then again he relapses with a severe pain. Probably acute exacerbation has happened, probably neuropathy has set in. So a new mechanism might start. We treated the patient for a different mechanism, but he has got a new mechanism but this will give a wrong impression that the main treatment is not effective. Patient C, the patient might be having neuropathic pain from the beginning. If you see the same kind of pain, same intensity, and is going on. So here we are treating them for a ductal cause, but actually the patient has a neuropathic mechanism. We are changing the wrong target. So there is lots of heterogeneity, and because of this heterogeneity, all these trials may not show like durability of response, or they may not show efficacy at all. So how to correct this? So we have to redefine clinical trials. So this non-linearity, subjectivity, heterogeneity has to be considered in designing randomized controlled trials. How to do that? We have to redefine the clinical trial design. The sample size should be robust. Now usually when we do all this sample size calculation, is based on one outcome, pain, and usually the sample size for most of the trial comes to around 50 to 60 in each group. But remember from the previous slides, each patient may have actually many pathophysiology going on. So we have to factor those in, and therefore the sample size should be much higher than what we calculate. Follow-up should be longer because this is a heterogeneous disease. So longer follow-up would give a more realistic response. Analytics, again, those who are interested in statistics, we have to go with advanced statistical modeling to factor all the changes in pain at different time points. Subgroup analysis is very important. Disease duration, etiology, psychological status, pain patterns. These have never been evaluated in the existing clinical trials, which is important. Pre-enrollment evaluation pain phenotyping is extremely important, which I'll just closely touch upon. And inclusion criteria, the patient should have a homogeneous group, and that will come from a good pain phenotyping. So how to do pain phenotyping? It has to be a multidimensional evaluation. Simple clinical history can give us lots of insights, the type of pain. So you can just take out this chart and put it in front of the patient, which is your pain. And that will give you the pattern of pain. Simple history like pattern, character, triggers of pain, character of change, involvement of new areas. So these are some of the factors that has to be asked before putting the patient into trial. And for that matter, for a routine clinical practice also. And there are different ways to do meticulous history. I told the pain assessment. I think Sushant had described all these things. I'll not go into the details. The psychological assessment, hospital anxiety, depression, pain, catastrophizing, all these should be included in the questionnaires before enrolling the patient. And finally, can we predict? Again, we had heard from Dr. Reddy's talk that our study on prediction of pain response. So this is something that we are still doing, and we have used machine learning using hundreds of variables. Out of that, these are the top few variables which shows the predictability of pain. So the if the red colored dots are on the right side, that means it's a strong predictor of pain response after treatment. I mean pain relapse after treatment. So if the patient has a change in pain character, if the patient has spontaneous pain without any triggers, if there is development of new areas of pain, if the pain predominant is persistent pain with in between fluctuations. So these are the patients who are going to have a relapse of pain. So before even enrolling, we can decide this patient may not have a good outcome. So these are the pain related outcomes. The morphology related outcome, MPD stricture. If the patient has single or multiple strictures, they are more prone to have a relapse of pain, and that was also shown in the previous study. So this is something called SHAP analysis, and based on that we can predict, and that's how we can put the right patient in the right kind of arm. So this is, and I think because of time I'll stop. I'll not go to the studies on chronic pancreatic insufficiency, so we can have some questions.
Thank you, Dr. Talukdar, for the brilliant exposition of the subject that you have mentioned, mainly stressing upon the fact that for clinical trials it should be redefined, should be made more objective, and homogeneous group of subjects has to be taken and then to be compared. Then the clinical trials will be a reasonable one. So if there is any question from the audience, so Dr. Talukdar will be happy to answer. Thank you.
Mike.
Dr. Goenka, please.
Rupa, we know about antioxidant studies from All India Institute, and then it was not reproduced subsequently.
Yeah.
Do you think that the factors which you described in your heterogeneity could be responsible for that, and can a meta-analysis or a network analysis to some extent can take care of all these factors?
Yeah. So if we compare the AIM study with the Anticipate trial from Sirivardhana, Manchester, so their study, the patients were older, they were having high dose of narcotics, and they almost had burnt out. This is very advanced disease. On the contrary, the Indian study showed young patients, no narcotics, and so if the patient is taking narcotics, that will come again in the history before enrollment. High dose of narcotics, age, older patient, they are not going to benefit. So that is an important concept, parameter that has to be considered while. Yeah. It depends. If they have been included in the study, then it will. But if they have not considered in the enrollment, then it won't. We had done a meta-analysis where combination of the same combination appeared to work, and based on that we strongly can say that methionine containing antioxidant will work. But again, in those individual studies, these parameters were not included, so we cannot.
Telling about this meta-analysis, one of the major issue would be the sensitivity analysis, because if you do the sensitivity analysis, automatically those studies will be excluded,
Yeah.
and we need to take care of those studies who are
Yeah.
showing some
So-
heterogeneous results.
Yeah, so the studies with the highest effect size can be excluded one by one in a sense. But again, that won't answer the question of parameters which are not included in the study.
That's true.
Yeah. Thank you. Yeah.
Yes.
We now break for a short tea break. We will be back at 5:35 to restart the next session. Thank you.
Hello.
That's the mass which was seen.
I'd like to thank the organizer for giving me this opportunity. Thank the organizer for giving me this opportunity.
That's the mass which was seen.
Thank the organizer for giving me this opportunity.
Manipal Hospital, Broadway, Kolkata. Dr. Obhijit Sarkar, Senior Consultant, Gastroenterologist, Dishan Hospital, Kolkata. Dr. Nikhil Sonthalia, Senior Consultant, Gastroenterology, Apollo, Kolkata. And may I invite on stage Dr. Malay Sharma, Senior Consultant, Gastroenterology, Aryabhat Hospital for the lecture, please.
So I thank the organizers for inviting me to speak on this topic. The pancreas is divided into head, neck, body and tail. Head into anterior and posterior part, and these are the ducts. And these ducts are, there are sort of 5 ducts in the pancreatic duct. These are the 5 different parts of the pancreatic duct. We come to pancreatic lesions, solid lesion. Pancreatic cancer, we do CPN, we do fiducial placement, radiofrequency injection, and so we do EUS for solid pancreatic lesion, therapeutic lesion. We do EUS, we combine diagnosis with ablation by pressing fiducials, injection, drug delivery, FNAC, FNAB. And then we do EUS guided tumor ablation by ethanol, radiofrequency ablation, microwave. And these are the modalities to do fiducial placement and target therapy when we do EUS guided therapy of a pen. And these procedures are safe when we do the therapy as a palliative option and we select the patient. The next is celiac ganglion block, where exactly above the celiac artery in this picture, and this is the place above celiac artery, anterior to aorta, celiac ganglion block, above pancreas, posterior to stomach, anterior to aorta, in the gastrophrenic ligament, after identifying the vessels. So these are the takeaways we took that EUS is for pancreatic cancer, solid lesion. What about cystic lesion? Cystic lesions are there when we have single, solitary, non-operable cystic lesion, no IPMN, we eradicate the epithelium of the pancreas, cystic neoplasm. And the lesion can be MCN, IPMN, cystadenoma, FNA, alcohol, and then ethanol plus paclitaxel injection, radiofrequency. So these are the outcomes are okay, reasonably good, cystic lesions of pancreas. So I test solid lesions, I test cystic lesions, and I am now coming to the EUS guided celiac ganglion block. But these are the 2 rivers, the ducts, 2 rivers, pancreatic duct, bile duct. They must flow smoothly, but they can flood, they can block, they can obstruct, and they leak. And basic principle of our principle is like bile duct is a chimera, very dangerous. It is a chimera, but pancreas is no less, like a double-headed dragon, and it must be tamed, and we must do the therapy. If there is a stone or a stricture, we must relieve it. And if it is leaking, bile duct is leaking into peritoneum, retroperitoneum or subperitoneum, we must identify where is the leak and where is the obstruction and how we are going to release the obstruction or leak. So leak in acute phase, it is flooding the pancreas, flooding around. When this is leaking, it is causing duct disruption, and we have to identify where the duct disruption, where is this leak happening, and it is happening into 3 spaces, retroperitoneum, subperitoneum, and peritoneum spaces. And these are the leak around the retroperitoneum structures, anterior pararenal space, perirenal space, and portium. So when you see embryologically, what is subperitoneum? When vessels come from posteriorly along the ligament, this is subperitoneum, and the pancreas is the retroperitoneal organ, leaks into subperitoneum, collects into spaces in subperitoneum, and these are ligaments, and this spread occurs from posterior to anterior. And this posterior to anterior spreads. That is why falciform ligament is very rarely involved in pancreatitis. So these are the spread to subperitoneum is in gastrosplenic and gastrohepatic ligament, and these ligaments collection is an important part. So the spread of pancreatitis to lesser sac and greater sac can also happen, and this is the way pancreatic fluid goes into the lesser sac and the greater sac, and that is the superior. For example, when we see this is the superior recess of lesser sac, sometimes people say this is a pseudocyst. No, it is not, it is superior recess. So the 3 recesses are superior recess, inferior recess of pancreas, and this is lesser sac. This is not a pseudocyst. Majority of collections that we train are lesser sac collections and not pseudocyst as people believe, and this is splenic recess, superior recess, and then. So these recesses we see on CT. We train and we do cystogastrostomy to superior, inferior, and lesser sac recess, and these recesses are drained by EUS guided tap. And so when you're draining a fluid by cystogastrostomy, identify what are you draining. You are draining peritoneal cavity, lesser sac, or you are draining subperitoneal cavity, the ligament, and that is why you must know which is the drainable area that you can identify. So apart from this, in acute pancreatitis, there is an aneurysm, you do coil, glue injection, thrombosis. You can do EUS guided glue injection of thrombosis. Then there is EUS guided difficult duct access, you can puncture. So in acute pancreatitis, you have to take a balance sometimes. You have to do EUS and you have to do therapy of acute pancreatitis. For example, this is aggressive therapy. Pancreatic duct disruption leaked, you do therapy, EUS guided puncture of pancreatic duct, then you do pancreatic duct, you catch it with a snare, pass through the strain, and then you pass in a guide wire, you catch the guide wire, and then you catch the guide wire, pull it back, and through the same stent, you do a rendezvous procedure, and this is EUS guided rendezvous along with the and then you release it, and then you place a stent to EUS guided therapy. So these are the different ways to be aggressive when you do. Dear friends, coming back to acute fluid collections, they can be acute less than 4 weeks, more than weeks, clear necrotic collection, and the pancreatic fluid, as I've said, it already spreads, and the cystocastrostomy boils down to subperitoneal compartment or the lesser sac compartment, and you have the option of management. Whether it is a lesser sac or pseudocyst is always a question before you drain, and the indications of course are clear. When you do a cystocastrostomy, though they are changing in India, we are different. How are we different in India compared to others? Because in USA and many other places, the itch is to put in a expandable covered stent, Axios or LAMP, whatever it is. But I believe plastic stents generally do well because you have to calculate the volume of the solid content. In majority of cases, it is almost always less than 10%, and it is not. So you have to perform a successful cystocastrostomy, you have to have a checklist of cystocastrostomy, and you have to identify what is the cyst, wall thickness, vessel content, character, clinical, you have to use the devices and electrosurgical settings, and then do the cystocastrostomy. We all know what are the ways to do a cystocastrostomy. Like taking the needle out of the scope, simple steps, coming down to very simple things are more beautiful in the sense that how to select puncture site, where to puncture, how to take the needle out of the scope, how to puncture the angle, how to avoid diaphragm, and understanding the artifact of the needle going slow here, because these are basically selecting puncture site. Now this is the maximum site of convexity. This is a pseudocyst. You convex and rotate scope in this clockwise direction, and then you convex at maximum convexity. The problem is when you do EUS guided cystocastrostomy, I don't know how many of you have experienced that sometimes if you lose the position, it is very difficult to come back to that position again. Because you are nervous, you are rotating the scope, so always remember the moment you have identified that I am sitting on top of the pseudocyst on EUS, be very careful, fix your scope, fix your position, fix everything, and finish the procedure in the same position. If you move this way or this way slightly, you lose this. So, because once the maximum convexity, you are standing on top of a mountain, you slide either way, you lose the position and very difficult to regain it. Taking the needle out of the scope, be careful, move the down scope down. So when you are doing the cyst, maximum convexity of cyst by up knob up, see, then move the up knob down in the same position. You will lose the vision of cyst. Don't worry, you can always move up, see the cyst, move it down again. Now take the needle out, but don't take it out like this. If you don't do this, this will come out like this. And taking the needle out the scope, you have to keep it down, keep on moving it down. And keep it down with the ring finger. And then you will lose the USB, don't worry. Then you can check the needle is coming out by checking on the US scope, endoscopic vision, US vision, move the needle up and down by elevator, and you can check, okay, this is out. Puncture it, proceed with puncture, and select the puncture angle. You have to adjust the angle. Again, 30, 45, 60 degree, 90 degree. What is the best angle to puncture when you are puncturing a pseudocell? You cannot go to 90 degree, that is not possible. 60 degree is your aim, but generally you puncture at 45 degree angle. That is what people generally achieve. 30 degree is dangerous because when you are puncturing at 30 degree, you may slip on the upper wall of the pseudocyst. So don't do this mistake, don't make the mistake of puncturing at 30 degree angle, 45 degree. Then take the avoiding puncture to diaphragm. Now that is a very interesting position, interesting question, how to avoid puncture through the diaphragm. See, the diaphragm is a T10. And when you rotate the scope, do not push it in and out. Identify T10 or T8, 9, 10 vertebra, by EUS scope you identify the diaphragm, keep it at a higher level. Diaphragm goes like this, from posterior to anterior. So once you have identified the diaphragm, because your problem is you want to see on EUS scope, and if you find the best puncture site of pseudocyst, you move aside, you are afraid, you can't see the lumen of endoscope, and you may puncture to the diaphragm. So what to do? Identify vertebral level of EUS scope at diaphragm T10. See that it is at the same level, go 5 centimeter beyond that and identify the problem. So collection in the superior recess of lesser sac, like this is the superior recess of lesser sac, and puncture can happen as in this case, just around the G junction, but you have to be careful because this vertebral level that you are. If you are able to see vertebral artery or celiac artery origin, and you are able to puncture at that place, you are safe. Don't worry. So if you find the aorta, and you find the aorta celiac artery origin, and then you rotate the scope, same, don't push in and out, then you are safe, you will be able to. So this is the way to avoid diaphragm when you are doing it, and then understanding the artifact of needle. This is interesting. You see the tip of the needle. Sometimes when you push in the needle, it disappears. You see, this is the missing part of the needle in between the artifact. Be careful, because when you see, this is a needle being introduced into the water, and when you see there are reverberating artifacts, the proximal part of the needle, this is the missing part of the needle. You see where it is gone, because sound waves are coming, traversing around it, and then this is the displaced part of the needle, because there is internal reflection of this. In the middle part, the sound waves are entering it, they are having internal reflection, going to tip and coming back. That is why the middle part of the needle is seen at a different part, at a distant part. So this is the missing part of needle. And the tip has got multiple ghost-like artifacts, and they are called the grating lobe artifacts. So these 3 artifacts of the needle are there: reverberation artifact, missing part of the needle, this is displacement artifact, and the ghost tip up. So this is like when you are puncturing a cyst, be careful to identify the T artifacts, because that will help you in identifying the tip of the needle. Do the lowest gain, decrease the gain, decrease dynamic range, remove compound harmonic imaging. Don't use compound imaging, you should tissue harmonic imaging so that you can see the needle better, decrease the basal gain a lot. So in the fingers, when you see grating lobe artifact, the most distant is the most important part of the needle, and identify these artifacts this way. So then make 2 loops. I think these are all standard procedures. People know how to make 2 loops and then puncture it, and place the stem. The only thing is sometimes when you puncture, you see the black area. Why this black area is there? Because these sound waves are being reflected by the guide wire. Don't worry about this black area, nothing is happening. Go on, finish the procedure. So this is advance the dilator. Be careful that you won't push the dilator along the cyst, as you can land in trouble. Puncturing by cystotome, rule out the tip, apply pure current, and be careful, because we have burned our finger. You don't have to use the jaguar, you use the the current. So these are the way you place 2 stents, and then you follow up after cystogastroscopy. Always follow up. Do not pseudocysts are notorious, and they can have a ball and they can bleed like they did in this case, and you have to follow up. And you can control by moving the tip up, applying clips and all, but balloon tamponade generally works the best. And you do is just press it up, keep it up, and you will be able to do it. So then there is infection, you can remove the infection, necrosectomy, and follow the sick, and then necrosectomy, there can be perforation, be careful, identify the perforation, and there is reposition the stone. And these are the complications that I have said they can happen along the set. Misplacement, and then stent migration into the cavity, which you can remove by stent migrated into the cavity. These are the stent. Axios stent can migrate internally, and then you can remove this migrated structure stent which have got maintained. Chronic pancreatitis is an interesting thing. Last 20 seconds. This is the place where chronic pancreatitis can block, and you have to place stents like in pancreas divisum, US guided, or in pancreatic strictures. This is the area when you can do endotherapy, and we can see there are stones, pancreatic stones, which can require endotherapy, and US is helpful in identifying which place you require endoscopic ultrasound can predict which place you need to. Thank you very much.
Excellent lecture, Dr. Sharma. You have shown clearly in last 3 decades how we started the journey from US guided FNA in 1992 and reached here. How do you think in 10 years down the line what US guided pancreatic endotherapy will be? How do you foresee it?
I believe you cannot imagine a gastroenterologist practicing without US. Like there was a time when you cannot imagine a gastroenterologist practicing without ERCP. In India today, data shows that there are 4 lakhs ERCP done every year, 4 lakhs US done every year, about 10,000 EMR, ESD, POEM procedures every year, only 1,000 ESG. So when you see this data and compare it, I believe US is going to overtake the number of ERCP in India. So those who are interested in therapeutic endoscopy will be doing more and more US. It will replace, the demand is there.
No, I am asking the clinical areas. Which are the clinical areas still unexplored, which can be in the US zone in 10 years down the line? I'm not asking about the number of endoscopies doing in the US. That's it's obvious that US will take place and more and more people will do US.
More and more people.
Yeah, but what I'm asking, what are the clinical areas you are thinking that in 10 years down the line, you will explode with the US in pancreas?
In 10 years, we will be getting, I can say, what has happened in bile duct will happen in pancreatic duct. You are happening bile duct reconstruction, complete transaction, we are doing magnetic transaction to the, I think the same will happen in pancreas. There is same aggression which has followed in bile duct will follow in pancreatic duct.
Ideal case, will you recommend in mucinous only or serous also? Which is the selection criteria for cystic neoplasm ablation using EUS? And alcohol plus paclitaxel or only paclitaxel?
See, the answer to this question can be theoretical and practical. I don't want to give a theoretical answer. I am saying only practical answer. In mucinous cysts are probably much less common in India. So what we are going to do, whether we are going to inject alcohol, whether we are going to do radiofrequency injection, radiofrequency ablation, the number will always be small. Okay, and then the surgeon is always behind you. What I am saying is, dear friends, for CBD stone, for bile duct leak, for everything, because of sheer numbers, India has decided what is the correct treatment. As Dr. Nageshwar Reddy has shown, India has decided what is the correct treatment for pancreatic endotherapy. Same way, hopefully, because of sheer numbers, we will decide someday at some center what is the correct therapy. As of today, there is no standard protocol.
Any question from the audience? If there's no other question, shall we close the session? Thank you, Dr. Sharma.
Okay.
For the next session, may I kindly invite on chair Dr. Ashokananda Konar, Director of Gastroenterology, PLS Hospital, Kolkata, Dr. Jayanto Dasgupta, Professor and Head, Department of Gastroenterology, IILDS, Kolkata, Dr. Kishalay, Associate Professor, Department of Gastroenterology, IILDS, Kolkata, and Dr. Rakesh Khan, Senior Consultant Surgeon, ILS Damdam Hospital, Kolkata. And may I please invite on stage Dr. Shonmur Mohapatra, Director of Advanced Endoscopy, Sai Institute of Gastroenterology and Liver Diseases, Bhubaneswar, Odisha.
I would also request Dr. Nikhil Shanthalia, please join our chairperson on the dais.
Good evening, everyone. It's actually a privilege to share the stage with such distinguished faculties from India. So I'm going to present today a very simple case of walled-off pancreatic necrosis. So this is a 21-year-old male, moderately severe acute pancreatitis, questionable etiology, actually referred to me by a surgeon for endoscopic drainage. Week 3, at that time he had early satiety, abdominal pain, was unable to tolerate solids. So these are the CT scan picture. So day 4 CT, as you can see, there is acute necrotizing pancreatitis with peripancreatic and pancreatic necrotic collections. In the right hand side, there is a large, around 15 by 10 centimeter pseudocyst as reported in the CT. It's kind of compressing the stomach and the duodenum. So my question to the panel, as well as the audience, what would be the next best step of management? Do nothing, even no drainage, just treat conservatively, perform endoscopic drainage now with plastic stent, perform endoscopic drainage now with LAMS, with or without plastic stent, wait for more than 4 weeks for drainage, or send the patient for percutaneous drainage. So, question for the panel.
Yeah, so as we know, whenever we get a symptomatic pancreatic fluid collection, we want to drain it. So the patient has symptoms. Now you have to decide between the options of methods of drainage. So when we choose percutaneous over endoscopy, it's more of an early stage of disease where encapsulation is not there. So time to onset concept has been translated to time to encapsulation. Even if we get an encapsulated collection at 3 weeks, we are okay to drain it endoscopically. It provides us much larger access to do necrosectomy if required. So I will consider an endoscopic drainage. I will do a diagnostic endoscopic ultrasound evaluation and review my CT images for encapsulation. And if I see that the collection is well encapsulated and patient can tolerate endoscopic procedure, I will go ahead with endoscopic drainage in this case.
With LAMS or plastic stent?
Yeah, so CT is not a good modality to show us how much debris is there. So either we do an MRI or we do a diagnostic EUS and assess. If it's less than 10%, even a plastic stent is a good option. If it's a higher amount of necrosome, I'll go for LAMS.
So a very nice answer. So he would proceed with an EUS and based on the EUS decide for drainage. So couple of things. So today my agenda, I would cover the indications and timing for endoscopic approach, choice of initial stent placement, endoscopic necrosectomy, timing and frequency, chemical necrolytic agents, then strategies for endoscopic management of large collections. So I would like to start my presentation by doing some literature review, and then I'll show you how I manage the patient. So in 1980s, surgery was the only modality to treat necrotizing acute pancreatitis. Until recently, there have been multiple trials that have shown that medical management, in fact, is better than surgery and, in fact, some drainage procedures. And if drainage, then minimally invasive approach is the best thing to do. So indications, as you know, 60% of the pancreatic necrosis is spontaneously resolved. However, intervention is indicated if it's infected or if it's sterile but have obstruction, intestinal obstruction or organ failure or intractable pain or disconnected pancreatic duct with fluid collection. So these are the options available that can be done alone or with combination. Largely at this point, the endoscopic drainage has taken over compared to the perc drain and surgery, but still they do have a role when, especially if the collection is large, extending to the paracolic gutter, or if it's the left side, then surgery would have been an option. Endoscopic management, first thing is to create a tract, that is the cyst enterostomy tract, and then place the stent across the cystostomy, either plastic stent or metal stent, and then perform necrosectomy, that is directly enter with your scope into the cavity and perform debridement. That can be mechanical or chemical, and this step needs to be repeated until it resolves. So is endoscopic step up is better than surgery? And the answer is at this point, yes. When there are multiple trials, randomized trials that have showed that the mortality is no different compared to surgery. And there is a MISA trial which also said that endoscopy is more cost effective compared to surgery. So at this point, to summarize, the literature behind the step-up approach is pretty robust, and it shows that there is reduced physiological stress, there is reduced occurrence of new onset multi-organ failure, shorter hospital stay, reduced total cost, significantly reduced fistulae, and no significant difference in mortality. So to me, at this time and era, the first line of management, whenever an intervention is necessary, is the endoscopic step-up approach, especially if the collection is endoscopically accessible and expertise is available. Now, when is the right time? And in my case, it is 3 weeks. The current guideline, it recommends waiting for endoscopic drainage till the collection is walled off within this arbitrary number of 4 weeks. But is that something true? That can we delay the intervention all the time? What if the patient is an ICU and with multi-organ failure, or what if the patient is severely symptomatic? So this is one of the study that Reddy sir already shown in his slide, very early study comparing early versus standard endoscopically step-up approach. So the patients that was selected in the early group are sick. They were having either infection or kidney failure or septic shock or renal respiratory failure. But interesting is the step-up approach has shown improvement in the organ failure. So, and especially if you see the early group, they do have a more robust response compared to the standard approach. So in terms of mortality, there is a higher mortality with the early group, but we have to remember that all these patients are in the ICU, very sick, with organ failure, and 13.2% is not something, it's actually better than historical 20% or 30%. So this finding also, it's replicated in several other studies from India, also from the United States. But then this Dutch study came up in NEJM showing immediate versus postponed intervention. And they just said that not to rush, just relax and start the patient on antibiotics and see how the patients do. So this is the pointer trial comparing 55 patients in the immediate drainage, 49 in the postponed drainage. What they looked at is something called comprehensive complication index score, and that didn't differ in both the groups. In fact, the secondary outcomes such as death, new onset organ failure, bleeding, nothing differed between those two, all groups. However, they did say that the interventions in immediate group were more compared to the postponed group, and in fact 1/3 of the patients in the postponed drainage group they didn't require any intervention. So their conclusion was no matter how sick the patient is, start them on antibiotics and avoid endoscopic drainage until 4 weeks or more. However, I just want to ask the panel, what are your thoughts on antibiotics? How many days? 7 days, 10 days, 14 days? How many days you generally do? Is there any recommendations you follow?
Hello. In the management of such patients, we have to be very dynamic because they're assessed every 72 hours. So you are beginning one line of therapy, starting antibiotics, assessed at 72 hours. If they're responding, you can continue. Then you need to step up. You need to step up your therapy depending upon the response, and you have to assess them every 72 hours, whether they're responding to a particular line of therapy or not.
Okay, so at this point, the guidelines, they recommend empirical broad-spectrum antibiotics in suspected infected necrosis, but antibiotics, they're widely and inconsistently administered in around 80% of the necrotic pancreatitis patient without any proven infection. And empirical antibiotics provides insufficient coverage. Around 50% patient only have pancreatic culture, and prolonged antibiotics can result in opportunistic colonization with enterococcus and can be associated with new or persistent organ failure. So the question is targeted antibiotics based on FNA, which is not currently recommended, is superior to empiric antibiotics? Optimal duration of the antibiotics, it needs to be better defined. Then when to declare antibiotic failure and pursue drainage needs to be addressed. Then perhaps degree of encapsulation, as he said, is more important than the time of onset of acute pancreatitis, and then early endoscopic approach may be considered in critically ill patient with organ failure. These are all kind of questions that do not have right answer at this point. Choice of stent, plastic versus metal stents. So at this point, there is no difference that has been shown between the plastic and metal stents, except the procedural duration is something shorter with the lamps compared to the plastic stent. And of course, lamps is something more expensive. This is a study from India. They said that even with necrotic debris, around 20% of the necrosis, plastic stent, they can be placed, and the outcomes are no different than metal stent. Again, another RCT from AIG, Reddy sir already showed this study as well. It showed that there is kind of fewer reintervention needed with the LAMS with shorter hospital stay. However, overall clinical success and everything remain same. To me, plastic stent probably is something can be thought about if the size of the cyst is small and it's predominantly liquid content and patient compliance is poor and the patient is stable compared to a large size of the cyst or necrotic collection, significant solid component, and patient has a poor follow-up and critically ill patient. Again, placement of coaxial double pigtail stent through LAMS. I would like to ask the panel or anybody from the audience, do you do it or just place the LAMS in?
Routinely place coaxial stent. It has certain advantages. It prevents the stents from declogging. It prevents the opposite wall getting rubbed against the axias, which has slightly sharper edges as compared to Spaxer stent. And does not preclude your subsequent necrosectomy because these are 7-fen stent. So there is no downside in putting it. So wherever it's feasible, we do put double pigtail plastic stent.
Yes.
I just wanted to make a comment on plastic versus metal. So the question may not be that important in patients who have 6 weeks, 8 weeks or established time period. But when we are considering for early drainage or early intervention, I think metal has slightly more edge because the walls may not be adherent enough and there is chances of cyst getting separated, and encapsulation may not be 100% as strong as lead. So early drainage should always be attempted with a metal stent
Yes.
as compared to.
Agree. The rationale behind placing a coaxial stent is it reduces the risk of infection by reducing the food reflux in the cavity. It prevents direct contact of the mucosa from vessels, so perhaps less bleeding and vascular injury, especially when the cyst collapse. And it also prevents stent migration, probably. So this is a recent study that's showing that the rate of adverse events are less when we do place coaxial stents in. So this is something at this point we do. So coming back to the case, so I performed EUS, large collection, at least 12 centimeter, predominantly liquid, but I would say probably 20 to 30% solid necrotic debris. The wall is somewhat in some area very ill-defined and thin. So what do you change your mind at this point or stick to your decision?
You can proceed with putting in a metal stent because of the solid debris inside, and wall, I think it looks good enough to put in a metal stent in this particular case.
And also, I think that because we have that luxury of placing the lamps, especially we have 3 types of lamps available in India. What about like a poor patient who cannot really afford the metal stent? What would you do?
If you look in terms of data,
say it again.
If you look in terms of data, the overall outcomes of patients, when we compare the lamps with plastic stents, with multiple plastic stents, in terms of outcomes, the difference is not that much to show. With lamps, we have an ease of placement, doing subsequent necrosectomies, that helps us. But in terms of outcomes, overall outcomes, there is little to choose between the two. So yes, we can also go for placing multiple plastic stents if patients cannot afford the metal stents.
Yeah, that's very important to know that I think plastic stent can be placed here as well. If from the audience anybody would like to argue, but I did place lumen opposing metal stent. This is the Axios stent. It's of course very expensive here, and the patient they're kind of reluctant to afford that much of money. But I did place a plastic stent as well within the lamps. So coming to upfront versus step-up approach. So at this point, we kind of do step-up approach, and it's pretty much very well validated and practiced in India. So first US guided drainage and then perform direct necrosectomy if the patient doesn't get better, and additional session of necrosectomy if persistent symptoms. So, however, recent studies are assessing the upfront necrosectomy in selected group of patients, and it probably has a role, especially if the patient is stable. Then we can do immediate necrosectomy as well, especially that would decrease the future reintervention rate. So coming to managing large collections, again, either a multi-gated approach, like putting multiple metal or plastic stents, or multi-modality approach when you do PERC as well as the endoscopic drainage. So my patient, he actually showed up again after 4 weeks with fever, chills. And I did go in, and there was complete blockage of the metal stent, and I did perform necrosectomy, of course, and a large amount of necrotic debris, it came out. And then this is the cavity, clearing the cavity, and then again, at this point, we didn't have to put available of a plastic stent to put in, so I didn't put a plastic stent within. But the patient again came in after 10-12 days with same thing, fever, chills, and as you can see, there are actually a lot of food, and the patient was like drinking this protein shake, and pus mixed with the food, it is there in the cavity, and it was pretty angry looking inside the cavity. So I kind of cleaned it and again suctioned and placed double pigtail stent in. Further hospital course, the patient had this stent removal lamps in 4 weeks, and there was no plastic stent placed because the collection was too small at that time. And this is the MRI MRCP in 3 months, just showing a focal defect in the mid-body, and there was small peripancreatic collection, probably like 30 to 7 millimeter, but it's just too small to drain anything. But this has been 3 months more, and the patient is clinically doing a lot better and completely normal. So to take home message, endoscopic drainage should be governed by the degree of encapsulation rather than the time from onset of acute pancreatitis. The choice of the stent must be individualized, and plastic stent, it's not like it's the wrong thing to do. So it can be done, and it all depends on the patient's clinical status, morphology of the collection, patient compliance, and financial consideration. Then multi-gateway and multi-modality drainage for large collection and step-up approach is something preferred at this time. Thank you so much.
Can I request Dr. Sandeep, Dr. Laktakia for your comment on this case?
That was a nice presentation, Sanmun, and you raised the appropriate debates which are going around in management of pancreatic fluid collection, which was either draining early or late. Some collections do mature early. Nobody waits till 4 weeks. There are collections which mature by 3 weeks, and there are some which do not mature by 6 weeks also. So case to case basis one should decide, and if need arises, then we can drain early. You can use metal or plastic, and my decision making for using one over the other is if there is a chance of a direct endoscopic necrosectomy which is likely to come up, especially which happens in patients who have large volume of debris inside, then I place an upfront metal. We can choose any of those. Axios is the commonest, but it's the most expensive also.
Yes.
So there are several versions available, including one designed by Dr. Reddy. The Nagi stent is actually quite good. These soft stents prevent bleed from happening. Axios gets fixed well and cannot move, and if you rub your Axios on hand, you can actually get abrasions, whereas Nagi is very flexible and actually can move out on its own, which is a blessing in disguise sometimes. So plumber stent and similar stents can also be used, whichever is available in the setup.
Okay.
Plastic using inside, coaxial we use if a patient has significant debris and pus inside upfront, and we try not to dilate and necrosectomy at the same session because of risk of more complications. However, the Destin trial showed otherwise.
Yes.
But my patients in that cohort were mainly in fact, I had a few bleeds when we tried to do dilate, and that which was not seen by others, and that's why that adverse event is not so mentioned in that paper per se. So these are my way of approaching these things. So whenever debris more, metal over plastic.
Thank you.
Thank you. I think we are running short of time, so I would end the session. Thank you.
For the next session, may I invite to chair the session Dr. Sujit Chaudhary, Senior Consultant, Monipal Hospital, Broadway, Kolkata; Dr. Pradipta Guho, Consultant, Zenith Super Speciality Hospital, Kolkata; Dr. Vijay Rai, Director, Live Gastro, Kolkata; Dr. Prashant Debnath, Consultant, Medica Super Speciality, Kolkata. And may I invite the speaker, Dr. Rajesh Puri, Vice Chairman, Medanta Medicity, Gurgaon.
Good evening, everyone. At the outset, I would like to thank Dr. Sanjay Banerjee and the organizing team for giving this opportunity. And next 15 minutes, I'm going to talk incidentally detected pancreatic cystic lesion. As you know that carcinoma pancreas has a grave prognosis, and more than 85% of these patients dies within 2 years. And cystic lesion of the pancreas being a precancerous condition, and we have an screening tool available. So if we use these screening tools judiciously, we can diagnose carcinoma pancreas in these group of patients early, and we can prevent a significant morbidity and mortality related to the carcinoma pancreas, similar to carcinoma colon or breast or the prostate cancer. So pancreatic cystic lesions are very common, and most of these cystic lesions are incidentally detected. And recently published systemic review, the global prevalence of cystic lesion of the pancreas is 13 to 18%. And this percent keep on going as the age advances. And patient who is more than 70 years, the prevalence is up to the tune of 40%. So the question comes, why we care about pancreatic cyst? As I said, they are precancerous. 0.25% of these patients has the diagnosis when you evaluate, and 0.25% of the patient they develop every year when you follow these patients. And among 2/3 of all pancreatic cystic lesions, they are cystic neoplasm, and 90% of them are IPMN, MCN, serous cyst adenoma, or SPEN. We don't have a data from the India. There are 2 or 3 studies available. That is a skewed data because they are the surgical series, but most common pancreatic cystic neoplasm or solid neoplasm is SPEN, seen in the young patients. So the question comes, why it is important to differentiate? Because the pseudocyst and serous cyst adenoma, they have no malignant potential, and if they are asymptomatic, they don't need any treatment, and you can tell the patient that you don't require any kind of surveillance. While MCN and IPMN has a malignant potential, so these patients require surveillance and if required a surgery, while pancreatic ductal adenocarcinoma require a upfront surgery. Now let's discuss a case. A 50-year-old female presented with 25 millimeter pancreatic cyst found incidentally on the CT scan which was done for the lower abdominal pain, and she denies the history of pancreatitis and there is no symptoms of obstructive jaundice. So what do you do now? Will you tell the patient to go to the surgeon and get it done surgery? Or you tell the patient to do MRI either 1 yearly or 18 month or 6 month? Or you tell the patient now you should go for a EUS and EUS FNA, or you say patients then you don't require any follow-up. So when the patient comes to you, he's worried and he always says, I've got a tumor in the pancreas and I'm going to die. Doc, please do something for this. And same worries with you because you want to differentiate. Are you dealing with the mucinous cystic neoplasm or a non-mucinous cystic neoplasm? Is it a malignant cystic neoplasm or likely to be become malignant? And what should be the management? Will you send the patient for resection, or you do a follow-up, or you tell the patient nothing to be done, you can go home and you don't require follow-up? So in approach, beside demography and good medical history, conventionally these patients require a dynamic CT or MRI, an EUS, but not in all patients. Those indeterminate cysts which is not classified on the basis of CT and MRI, these patients require EUS, and the management, as I said, a regular surveillance versus surgery or no surveillance. As I said, a good clinical history is important, and always ask the history of pancreatitis because that favors about pseudocyst. A young patient a female come with an incident-detected cyst. Commonly these patients might have a simple cyst or an SPEN or a pseudocyst and cystic NET. While a 60-year-old female comes, it could be a serous MCN, IPMN or pseudocyst. Or if an elderly male present, then the IPMN is on the card. So a good history demographic profile is important before subjecting these patients. Now the question comes, out of CT scan or MRI, which is a better test? Conventionally we do a CT scan, but MRI is better than multiphasic CT. The reason is that within the cyst there is a small solid nodule or the mural nodules or a small cystic lesion. MRI give the better finding, demonstration of the fluid content, is it a liquid, solid, how much it is, and relationship of the cystic lesion with the pancreatic duct, and it has a lack of radiation exposure, especially when these patients require a surveillance. CT scan, if you find a characteristic feature of serous cyst adenoma, SPEN, MCN and IPMN, and depending on the basis of that, you can plan that either this patient go for a surgery or nothing to be done. If you are very sure on the MRI or CT scan, you are dealing with the pseudocyst or you are dealing with the serous cyst adenoma, then you can tell the patient even you don't require an EUS. So the very important question, because majority of the surgical colleague or a gastroenterologist, whenever a cyst comes, patient is referred for EUS and FNA. So the question comes, is EUS required in all the cases? The answer is no. If there is a classical MRI and CT finding, you don't require to do EUS. And if the cyst is less than 1 centimeter, a cyst is arising in the second of acute pancreatitis, or patient is elderly, even cyst has a high risk feature, but he is not a surgical candidate, you don't require to do the EUS. You know that this patient has solid cystic lesion, high likelihood of malignancy, but is an 80-year-old male with a poor cardiac condition, and you are not going to do anything. You don't require to do EUS or EUS FNA. So what is the indication of EUS? The indication according to various guidelines, if the cyst is more than 3 centimeter, a dilated MPT more than 5 millimeter, and solid component of the mural nodules. All these guidelines says, if these features are there, that is a patient who has a worrisome features. These are, or the growth of the cyst in different guidelines is different, ranging from 3 millimeter per year to 5 millimeter every 2 years, or if patient has a jaundice, if patient has a pancreatitis or high CA19-9. A very important point which I would like to say, this is very common. People do the CA19-9, so in the jury is still not out on CA19-9 or no, because there's some paper says, if you do a sequential CA19-9 and if start rising, that indicate the possibility of development of pancreatic cancer. But most of the literature talk there's a no role of CA19-9, both in the serum as well as in the pancreatic fluid. Now let's talk if the patient has an indeterminate or cyst which is more than 3 centimeter, PD is more than 5 millimeter, these patients require an EUS. And what is the accuracy of EUS morphology? It is only 50%. That if a patient comes to me and I, on the basis of endosonomorphologically, with the 50% accuracy, you can say this patient is dealing with the IPMN or serous cyst adenoma or SPEN. And there is a low inter-observer agreement. So EUS is not pinnacle. That's very important for us to know. And on the basis of risk stratification, a size more than 3 centimeter, a mural nodules, or a dilatation of MPD more than 5 millimeter has a high odds ratio. Most important question, how good we are detecting a mural nodule, because this is a very common problem. A solid debris is present in the cyst. Is it a mucinous globule or mural nodule? So EUS has a sensitivity of 75% with a specificity of 80% to diagnose. That means it is not very accurate. But if you do a contrast EUS, that is sonoview or sonozoid, if you inject, and if these lesions start showing the vascular signal, if you look at the left video on the right image, that is a contrast enhanced image, and you can see the periphery of the lesion is lighting up. That indicates you are dealing with the mucinous nodule. While on the lower image, you see on the contrast image, only you see a anechoic lesion, there is no enhancement that indicate. So contrast EUS has an accuracy of more than 90% to differentiate are you dealing with the mucinous or are you dealing with this. The another question is, will you do EUS FNA, and when you do the EUS FNA, what you are going to send? Because majority of the people keep on sending the CA19-9, which has no relevance. So you can look at the viscosity, that is a string sign. If you are able to make more than 1 centimeter string for more than 1 second, that is a very high specificity. And CA value cutoff of more than 192 differentiate you are dealing between mucinous versus non-mucinous. One important point, CA level high does not indicate this is a malignant cyst. That only indicate is a mucinous cyst if it is more than 192. It has no role in differentiating malignant versus non-malignant. It only differentiate mucinous versus non-mucinous. Nowadays people talk about the glucose, that is very good, and in patient with the IPN and MCN, glucose value is less. So if you summarize EUS on the morphology, it is only 50% accurate in depicting about the nature of the cyst. And a string sign has a very high specificity. If the string sign is there, then you can say, yes, you are dealing with a mucinous cyst, a cyst fluid cytology, again 63%. So this is a recent and is a very accurate as well as is very easy to do it. Because many of the time in the mucinous cyst, the content is so thick, when you send the lab, it is very difficult them to run through the micrometer tubes and find out about the CA, and they dilute of their own, and you don't get an accurate. But glucose, you can do it at the time of endoscopic ultrasound with the strips, and if that value is more than 90, or if you send to the lab then more than 50, that indicate to differentiate a mucinous versus non-mucinous. Less than 50 is mucinous, more than 50 goes in favor of serous, and which has a very high sensitivity of 90% with a specificity of 86%. I think the people talk about the microbiopsy, they're not clinically used and associated with the pancreatitis or the bleeding. I don't use in my practice, and similarly confocal laser microscopy, there is a data, but in day-to-day practice you don't use, is a costly device. Now I think this is a game changer, new molecular marker that is very important. I think the day has gone of guessing that what nature of the cyst, because you see on EUS 63% accuracy you can diagnose, on morphology 50%, by doing a CTI MRI has not very good sensitivity. I think that new molecular marker, that is a next generation sequencing, is very important, and that will remove the guess. So these cystic neoplasm has a mutation. The VHL mutation is seen in serous cyst adenoma, KRAS mutation is seen in IPMN and as well as MCN, but GNAS is specific for the IPMN, and if you see a TP53, SMAD4 or the mTOR mutation, that indicate these patients has a high risk of developing the malignancy. So if you diagnose the GNRAS, BRAF or the KRAS, that indicate even a cyst has a very high chances going to develop the malignancy, and which has a sensitivity of 90% with a specificity of 98%. So this is a very important article which was published in Gastroenterology 2023, which compare the next generation sequencing versus standard criteria. So you look at here, when these mTOR, SMDA, TP53 mutations are there, that indicate a low risk versus high risk. If the value is there, if these mutations are present, that indicate this patient is a high risk of developing the invasive cancer in comparison to the rest of the criteria, that is size, dilated pancreatic duct, or increasing size or the mural nodule. So I think these molecular markers, the problem is either their complete panel is not available, or even if it is available, they are very costly, but they have a very high accuracy, which cyst is going to develop a malignant potential. Artificial intelligence is in predicting the invasive cancer in the IPMN is gaining lot of news, and this is a app-based tool, that is a DART1 IPMN tool. If somebody wants to, you can scan this barcode, you can download on your mobile, and when patient comes to your OPD, depending upon the size of the cyst, is the patient is smoker or not, is the cyst is multifocal, or does the patient has a history of acute pancreatitis, you can predict at 3 years What is the percentage of development of the invasive malignancy, or what is the risk at 5 years? So if patient comes to you in your OPD and depending on these parameters, you can tell how much percentage chances. That is going to give the patient a big relief, because patient always think a tumor in the pancreas is going to be cancerous. But if you have this model, you can download on your mobile. Similarly, the artificial intelligence, that is the machine learning, the deep learning, 3 international centers, and on the basis of MRI scan, that shows even best of the radiologists, the area under the curve of these artificial intelligence is same as best of the radiologist who is going. So area under the curve, when you use the artificial intelligence for predicting or prognosis of the IPMN, is there. Now management, if you look at, there are various guidelines, right from 2016 to 2024, the Tokyo guidelines, that only indicate we are not still sure how to diagnose and how to treat these patients. But this is the latest Kyoto International Guidelines. And just briefly tell you, if patient has a high risk stigmata, what is high risk stigmata? If the obstructive jaundice, if patient has a mural nodule of more than 5 millimeter or the dilated MPD of more than 10 millimeter, the patient can be directly subjected to surgery if he is fit to go for a surgery. If the worrisome feature is there, then you do the EUS. And if the multiple worrisome features and the EUS finding favors about malignancy, or an FNA shows that chances of malignancy is there, it is better to subject. But where there is a no worrisome feature, no risk feature, then you take the size of the cyst. If the cyst is more than 3 centimeter, you do every 6 monthly. If the cyst is between 2 centimeter to 3 centimeter, then you do either EUS or MRI every 12 monthly. And if it is less than 20 millimeter, you do a 6 month once, and then every 18 months. And if there is no progression, at least for 5 years, then you can stop surveillance. That does not mean a patient who has a suspected MCN at the age of 40, after 5 years you stop. You have to assess in total what is the age of patient, what is the likelihood of nature of this cystic lesion, then you can take the call. If cyst is 1 centimeter, appears to be simple, you do it for 5 years and then you stop the surveillance. So ladies and gentlemen, to summarize, I think pancreatic cystic lesions are common, but have a very low risk of malignant potential. Contrast enhanced MRI is the first line of investigation in comparison to EUS or CT scan. Depiction of the morphology on EUS alone or the fluid sampling has a low sensitivity to pick up the lesion at the high risk of cancer. New molecular marker in the cyst fluid have a considerably high sensitivity and specificity for predicting the invasive nature of the cancer. I think app-based tool and the AI has a promising role in predicting the accurate diagnosis as well as predicting the risk of malignancy. Thank you for the patience, and I would like to invite all of you for the upcoming India-US Summit, and all those who wanted to learn EUS or who want to see the interventional EUS, I invite you all for the 7th Indian US Summit. Thank you.
Thank you, sir, for such a lucid presentation. And I want to ask that, have you experienced any condition in which the patient is subjected for the surgery and the result is negative, in spite of your diagnosis that yes, it could be a malignant cyst, not the benign cyst, and how you handle the situation and what are the learning from that?
Yeah, I think it's a very relevant question. So if you look at the JAMA study 2019, 1300 patient who was suspected to be a cancer and MCN IPMN, 22% of these patients are benign. And among the IPMN and MCN, 50% of these patients has a low-grade neoplasia, that is not high-grade neoplasia. So unless until you diagnose a cancer, then you will confidently say that yes. Otherwise, if the fluid cytology is negative, and even if the patient has a worrisome features, that does not mean, and this is a dilemma, and you want to avoid unnecessarily surgery because these surgery has a significant morbidity on the risk of missing the lesion. So that balance is very important, and you have to take the decision on case-to-case basis. I think that's more important.
Thank you, sir. So, any question from the audience? So I think we close this session now. Thank you very much.
To chair the next session, may I invite on stage Dr. Madhuchanda Kaur, Senior Consultant Oncologist, PLS Hospital, Kolkata, Dr. Shomik Ghosh, Senior Consultant Oncologist, Ruby Hospital, Kolkata, Dr. Abhishek Banerjee, Consultant Gastroenterologist, Manipal Hospital, Broadway, Kolkata, Dr. Sheikh Mohiuddin Ahmed, Associate Professor, Department of Hepatology, SSKM and IPGMER Hospital, Kolkata. And may I invite on stage our speaker, Dr. Sandeep Lakhtarkia, Senior Consultant Gastroenterologist, AIG, Hyderabad.
May I? Okay.
Good evening. We now move on to a session of pancreatic net, and we all know a very heterogeneous disease where we can expect that the patient will have a long journey full of hope and empathy. So over to Dr. Sandeep Nakhatia.
Thank you, madam. And good evening, everybody. At the outset, I would like to thank Dr. Sanjay Banerjee and his entire team for inviting me here to Kolkata once again. So I'll be speaking on pancreatic neuroendocrine tumor, the management aspect of it. In this, I would like to cover a few of these issues. What are these pancreatic neuroendocrine tumors? How are they treated? What are the controversy in management? And what are the endoscopic options in the treatment? If you look at this graph of patients who have pancreatic neuroendocrine tumors of the GI tract, or in general, there are several of them. All these are neuroendocrine tumors in different organs, starting from lungs, stomach, small intestines. This is where the pancreatic neuroendocrine tumor lies. And you see the graph shows that the frequency of this disease is rising in the recent past. Although this graph finishes in 2012, but the way it is going up, it's likely to go in the same manner, and it's going to overwhelm other sites of neuroendocrine tumor. And if this wave keeps going on, then all of us will have more problems at hand, and how will we manage them? So this neuroendocrine tumor, currently the best treatment option available, or the current gold standard, is surgery. But is there alternate option of chemotherapy or endoscopic ablation of tumors is what I will discuss here. Neuroendocrine tumors per se are very heterogeneous tumors. Most often they are found incidentally and they are asymptomatic. You do CT scan or imaging, cross-sectional imaging for something else, and you will find neuroendocrine tumors in some parts of the GI tract and often in the pancreas. If you take all pancreatic tumors, they constitute only about 2% or less. But if you take all GI tumors of neuroendocrine tumors, pancreas is about 1/3 of them. Mostly they are non-functional, but about 10% of them tumors can be hormone producing, which includes insulinoma, glucagonoma and others. And so the prognosis of a neuroendocrine tumor in pancreas is dependent largely on the grade of the tumor that is available there. And this is dependent on the KI index. If somebody does a tissue diagnosis or a biopsy, this dictates the overall management plan in a patient. Also, size of the tumor and stage of the tumor also dictate which way the patient would go forward. WHO has classified them into well-differentiated and poorly differentiated tumors. The well-differentiated are further subclassified based on the KI index of grade 1, which have less than 3% Ki67, grade 2 is 3 to 20, and grade 3 is more than 20. Those who have very high Ki index are called as high-grade neuroendocrine carcinomas. Surgery is considered a gold standard for tumors which are large than 2 centimeters in the pancreatic. And if the tumor is on the surface of the pancreas, then enucleation is a way to go forward. But if they are within the pancreatic parenchyma, Then depending on the location, if it's in the body or tail, then distal pancreatectomy is done. If it's in the head, then Whipple's procedure is considered. However, surgery itself has its own morbidity and even mortality. And this is accepted by the surgical guidelines. For example, delayed gastric emptying after surgery is seen in up to 18%. Pancreatic fistula, a very common problem faced by us, referred by surgeons after the procedure is done, is pancreatic fistula is seen almost up to 60%. Bleeding can occur in about 1 to 7%. Exocrine and endocrine deficiency depends on how much volume of pancreas has been removed. Mortality up to 3 to 6% is described and accepted. And this is what pinches most of us who see that patient is totally asymptomatic, you undergo surgery and they come with complications which can sometimes be debilitating and all prolonged. Also, patients who have high risk for surgery cannot be considered for these tumors, for this management. So what are the options? I used this review article very recently from Nirav Sosani and his group, which came this year only. It's a very beautifully written article, and I'll take some of the slides from this. So non-functional neuroendocrine tumors, in fact all neuroendocrine tumors require DOTA scan to see whether how far the disease has spread. And once, if the tumor is less than 1 centimeter, because they are generally picked up incidentally, or if they are more than 1 centimeter, 2 centimeter in size. So there are two broad categories. If you look only at 1 centimeter, which is a common indication of the patient referred to you, the decision is generally surveillance, because they do not die on prolonged follow-up even after 5 years or more. So tumor which are non-functioning, less than centimeter, just watch. That's the guidelines. What about tumors which are bigger than 1 centimeter, 1 or 2 centimeters? Look at this graph very carefully. I'll subdivide it. If it's grade 1, that means you have done a biopsy and the chance of such tumor to have a lymph node metastasis is very less than 5%. It's again either surveillance or ablation. If it's grade 2, where the chance of lymph node metastasis is about 16%, then either surgery or ablation is still considered. But if the biopsy grade is grade 3, that means they have high Ki index, then the lymph node metastasis is more than 80%, and it's better to do surgery in such patients. So tumors which are 2 centimeters or approximately same size, do a EUS biopsy before, confirm the grade, get the Ki index and grade accordingly, and then decide the management plan. Those which are small, the yield is much lesser and you cannot always say. So I'll get back the same graph now complete. So less than 1 centimeter, survey. More than 1 or 2 centimeters, do something depending on the grade of the tumors. What about functional neuroendocrine tumors? This is either insulinoma or non-insulinoma. They are two categorized because insulinoma are very less likely to malignant. Less than 15% of them are malignant. But in other non-insulinoma functional tumors, more than 60% can be malignant. Plus, risk of metastasis is 15 and that's 60. So if the tumor is small in size, less than 2 centimeters, then either surgery or endoscopic ablation. More than 2 centimeters, or if they're grade 1, on biopsy, surgery is preferred. Or if they have no information on these things, then surgery is considered. So insulinoma, small tumors, you can consider for endoscopic ablation. This trial, which came 3 years back in British Journal of Surgery, Aspen trial, which addresses management of asymptomatic, sporadic, non-functional PNETs, no larger than 2 centimeter. That's interim analysis. And this is the commonest problem that we all face. I'm sure everybody in this hall would have seen non-functional neuroendocrine tumors referred to you. What should we do? Because patient has no symptoms. So this trial says that those patients should be observed if the tumor is less than 2 centimeter in size. And keep watching them yearly by imaging and see if the tumor grows, then act upon it. If it remains the same size, keep following. But that's where the problem lies. How long can you keep watching? It's an anxiety to the patient and anxiety to the doctors too. So the decision of observation or operation depends on the tumor size, patient's age, comorbidities, location of the tumor, growth in size over time, and also patient's preference. So there are several gray zones of hesitation. For example, if the tumor is 15 millimeters or 18 millimeters, what would you do? Patient's age, a 70-year-old fit man is actually quite good for a surgery. Comorbidities, everybody has now diabetes, hypertension, do you consider not doing? Location of the tumor, yes, if it's on the surface, you can enucleate, which is an easy surgery to do than chopping off a large chunk of pancreas. So what are the non-surgical options of PNETs? Guidelines say less than 2 centimeter, observe, more than 2 centimeter, if it's comorbidity, then also observe. Chemotherapy, I'm sorry madam, most oncologists believe in just stabilizing the tumor. You give treatment and see that the tumor does not grow in size, which is as good as observation. And then there are tumors where targeted therapies are used, especially those that have metastatic disease where PRRT, TAE, TACE or TARE has been used. So all these things cause a lot of anxiety. Small tumors, leave it like that. Large tumors, you can't do much. So there comes the role of endoscopic ablation therapies, and EUS RFA is one of the most preferred modality in endoscopic therapy. So RFA can be considered in PNETs, which are mild disease, and RFA itself by EUS is a very minimally invasive and potentially definitive therapy for treating these tumors. So instead of using a knife or a surgery, we can require, it's not required for tumors which are asymptomatic to kill an ant. How to do EUS RFA? It's pretty easy. Anybody who's doing EUS and FNA can actually do RFA. If I can do, I'm sure anybody else can do also. And little bit of knowledge of generator and the device is required. Once you know this, probably anybody can start doing it with some expertise in EUS and FNA. How does RFA work? It's a high frequency alternating current which gives local heat to the tumor, and this causes coagulative necrosis. The depth of injury or ablation of the tumor depends on the wattage used. So slow cooking, that is low watt for a prolonged period of time, causes more damage than a fast cooking. And because as you slowly cook, more area gets ablated, and there is also a penumbra of injury, which means something is visible on screen, but the damage is much more than what is visible on the EUS screen. This is a device which is currently available, USRA from StarMed Korea, and the needle, the device which is used is just like an FNA needle. This one has an internal cooling mechanism. For those who do not know, the tip of the needle, which is just like an FNA, has a uncoated area at the tip, which is about 1 centimeter in length, but this can be different available and you can select one depending on the size of the tumor. The rest of the entire length within the sheath is insulated. So in this cartoon, if I can show, this is a pancreas and this is a tumor. From the stomach, you can puncture the gastric wall, enter the tumor, go deeper down and start ablating from deep down. Keep pulling back your electrode and then superficially ablate in one trajectory. Once you have finished, you can change direction and go in a different direction. So start from the more difficult area and then touch upon the more easy area of access. How do we select our patients for EUS RFA? So we have to select patients who are most likely going to benefit from EUS RFA compared to surgery. For example, patients who have functional neuroendocrine tumors, insuloma being the commonest, the goal of the treatment is to reduce the hormonal secretion. One need not do a complete destruction of tumor because we do not want complications to occur. So even incomplete ablation can also cause significant reduction of hormone production, and that would reduce the symptoms. And these tumors, obviously we know they have low malignant potential and then can be observed. In case the tumor increases in size or the symptoms reoccur, you can actually do it again. What about non-functional? Here we don't have the advantage of hormones being observed or symptoms of hypoglycemia being controlled. So there we have to try as much ablation as possible without residual disease if possible. So carefully stage the tumor, select the tumors which are easily accessible. Those without metastatic lymph nodes or distant metastasis should be considered for EUS RFA, especially if they're smaller than 2 centimeters in size. And that's where once again the step-up approach is being recommended. We heard the step approach from Sunmoon Mahapatra on walled-off necrosis. If the tumors are small, you can do EUS RFA first. If it doesn't regress or response is suboptimal or the tumor comes back, you can always consider surgery at a later date. We cannot do a vice versa. because the tumor is already gone and the complication have already occurred now. So that's where the recent guidelines from Europe, the European Neuroendocrine Tumor Society has started suggesting that tumors which are less than 2 centimeters, localized insulinomas who are unfit for surgery can be considered for RFA. I'm glad at least now they have started accepting that this is one of the methods. The previous guidelines had no mentions of RFA, although it has been there for more than almost a decade now. Let me show how it's done. So this is a pancreas. This is a tumor here, the black one, and the small duct going as a PD. This is very vascular and that's why it's lightening up on ultrasound. This is about 1 centimeter in size. This is how the needle goes inside and you can actually see under vision. So you are actually doing real-time RFA. The burn, this white colored bubbles appearing is burning the tumor. You can keep burning in different direction depending on the size. You can also use contrast enhanced EUS to see the completion of therapy. There are several publications. We were one of the pioneers in using this method of treatment. A small baby step we took in 2016. We published our experience of 3 patients. Now it's gone up to 20 and we found that the EUS RFA is very, very effective. The hypoglycemia, for which the patient has been suffering for months or years, rapidly drops within the first 24 hours itself. And if there are no complications, he goes home the next day. There are many other publications now. The experience has grown up widely and PNETs are now supposed to be best treated by RFA in endoscopic publications. There are randomized controlled trials also. This is one from France which showed the sustained benefit. Also from Korea, showing sustained benefit. And the recent meta-analysis which came 2 years back showed a clinical efficacy of 95% in functional and 93% in non-functional tumors. We also published our experience of, just a minute more ma'am, of EUS guided RFA for insulinoma versus surgery. This came in CGH 2 years back. And in this series of 89, comparative series of 89 patients in surgical versus non-surgical arm, the EUS RFA, the adverse event rates is much, much lesser compared to surgery, 18 versus 61%. The serious adverse events were mainly in the surgical arm. The relapse rates were higher in endoscopy because surgeons obviously remove the tumor, but that also can be addressed by a second RFA. Hospital stay is much, much shorter, 3 days compared to 11 days in surgery. Follow-up, although it's about 2 years compared to 3 years for surgery, but it's a trend which shows that a safer method can be done by EUS RFA. Does size of tumor matter? Yes. Tumors which are less than 2 centimeters, and in this study 18 millimeters was the ideal by which RFA is good to ablate. There are several factors for clinical success and I'll skip the slides. The guidelines now say that EUS RFA may be considered as a treatment option in patients with small, less than 2 centimeters localized insulinomas, as I said earlier. So I'm re-emphasizing the reason why the guidelines have not taken over is because by allowing endoscopists to tackle this is because the experience is growing world over. The relapse rate is much, much lower and future studies obviously will guide towards it. RFA does not preclude surgery and they can be considered for surgery later on, although we need to compile our results, accumulate and give the long-term results too. There are some complications which can occur with this, which includes pancreatitis, which can be prevented by giving indomethacin suppository, even using PD stent placement upfront if the tumor is very close to the margin of the PD. GI bleeds and perforations are some of the other complications. I'll skip these videos. The risk factor for pancreatitis is maximum when the tumor is less than 1 millimeter away from the margin of the tumor. So let me give you a very bold statement. EUS RFA will soon be a treatment of choice for small pancreatic neuroendocrine tumors. Any tumor less than 2 centimeters, functional, yes. Non-functional, also almost yes. Let me conclude here by saying that management of pancreatic neuroendocrine tumor, yes, they are very common and increasingly being diagnosed. Surgery remains the gold standard for tumors which are larger than 2 centimeters, especially high grade, locally advanced, but RFA for PNETs can be considered both for functional and non-functional tumors, especially less than 2 centimeters. It is precise, minimally invasive, safe, effective and sustained benefit. Obviously balance the risk is important. One should not undertreat just by observing and not overtreat by doing surgery in a patients who are totally asymptomatic. More studies and longer term follow-ups are required for efficacy. Thank you very much for your kind attention.
Thank you, Dr. Laktakia sir. Especially you have emphasized on the EUS, and luckily I saw you doing EUS and diagnosing this pancreatic net during my stay at AIG. But really, as you mentioned, that chemotherapy has basically no role. Sometimes it works, it gives 40 to 50% result in case of the advanced stages, and most of the pancreatic nets, basically this is not usually discussed in the gastroenterology conferences or CMEs, but what happens, it is more than 50% are the incidental diagnosis, and EUS is the best method to diagnose, as because it can be can diagnose even 2 to 3 millimeter tumor also. That is not any other modality can give you that radiological imaging from this side. So nice presentation, sir. Thank you for that.
Thank you.
And now it's open to the house for any question or comment.
Sir, hello sir. Sir, I have one question. Yes, post RFA, what is the interval of surveillance and mode of surveillance?
So currently what we are doing is, after index intervention by US RFA, we do a cross-sectional imaging after 3 months or so. If they have an insuloma, that is functional tumors, then we follow obviously with insulin levels and the sugars, which rapidly come down, but we keep monitoring the sugar 3 monthly and for a year, and then yearly thereafter. For non-functional, we do a cross-sectional imaging at 3 months, and then at 1 year. If any residual tumor is remaining, then if possible, we do a repeat RFA, especially in a functional setting, but a non-functional imaging becomes the gold line, the standard of care for monitoring. But for hormone producing, it's the hormones and the sugar level.
Thank you, sir.
I have sir, most of the NETs are small and they are vascular. And what is the yield in your USFNA? And no other lesions, and there is, it's high probably, mostly it's NET. Do you go ahead with the RFA without diagnosis?
So let me repeat your question for the confirmation's sake, that most of these tumors are small and vascular, and FNA may not be always possible in some of them.
FNA is possible, but what is the yield?
So the yield, okay. So that's a very valid point. What is the yield? And because they are very vascular, you sometimes get blood in them. So it is best to use a core needle without any suction. So you get little blood, but you also get tumor tissue there. The importance of this is that you get a grade of tumor. If it's G1, then you're in a fairly safe zone of using RFA as a next modality of intervention. But if it's G3, then you immediately send them for surgery. Bleed is usually mild and self-limiting and is not a cause of concern. Having said that, if the tumor is less than 1 centimeter in size, the yield, pathological yield is much, much lesser, and then we rely more on imaging, that is DOTA scan and other things.
In that case, if you have imaging suggestive NET and we don't have diagnosis on cytology, so do you go ahead with RFA or do you wait for the diagnosis?
Yes, so if a DOTA scan is positive and clinical suspicion is diagnosis is suggestive for NET, you can still go for an RFA without a histological diagnosis.
Thank you, doctor. We must come to an end, and from the oncologist's point of view, for small NET, we never use primary chemotherapy because that's not an option. Only for advanced metastatic disease we use. Thank you for the wonderful presentation.
Yes.
Over to the organizers. We conclude this session. Big round of applause for this wonderful presentation.
For the next session, to chair the session, may I call on stage Dr. P.K. Shetty, Director, Gastroenterology, Medica Superspecialty, Kolkata, Dr. B.R. Medhi, Senior Consultant, BM Healthcare, Shillong, Dr. G.S. Reddy, Senior Consultant, Tata Medical Center, Kolkata. Dr. Amitabh Roy, Senior Consultant, Unity Gastro and Liver Hospital, Agartala. And may I invite on stage our speaker, Dr. Praveer Rai, Senior Professor, Department of Gastroenterology, SGPGI.
Our next topic is early diagnosis of pancreatic cancer. I request Professor Praveer Roy from SGPGI to start the session.
Yeah. Firstly, I would like to thank Dr. Sanjay and the Kolkata Pancreas Club for this wonderful opportunity. So I've been asked to talk about early diagnosis of pancreatic cancer. And to be honest, I think I have to commit at this point of time that this area still needs a lot of evidences, lot of studies. So I'll be just putting up what we have in the literature as of now. So pancreatic cancer is currently the most lethal type of cancer. The lowest 5-year survival rate among all cancer types, 8% for all pancreatic stages, cancer stages, and only 3% when diagnosed late. So very low survival. Up to 85% of patients that have cancers that are not surgically resectable when identified. So majority are inoperable when these patients approach us. And the dismal survival of pancreatic cancer is primarily due to early detection, due to lack of early detection and lack of effective treatment. So this slide just tells you that the number of cases of pancreatic cancer is around 4,58,000. Out of these, number of deaths around 4,32,000, which is a significant number. If we see this paper published in Indian Journal of Medical Sciences 2021, this tells you that in India, the number of cases are around 10,000 and it ranks around 25th of all the cancers that we have. And the mortality is around, the number of patients who die are around 4,700, and this ranks among 28 in the mortality. So what this tells you, not a very common cancer, and it's an uncommon one that we have. So another interesting thing is Mizoram is a state which has the maximum age-adjusted incidence in India. And as we see the second graph here, this tells you that this incidence is increasing since 1982 till 2012, the data that we have till date. So why do we need early detection, or what is early detection first? So early detection of lesions means detection at time when no symptoms are present, yet the biological signals, that is imaging, blood test, biomarkers, are present for detection. So this window of opportunity, so we are trying to diagnose this lesion or pick up a lesion before it has become symptomatic, because once this becomes symptomatic, majority, as I mentioned, are inoperable, more than 85%. So we are trying to pick up the lesion in a stage of low-grade dysplasia or high-grade dysplasia, because at this point of time, surgery can be offered which provides a cure if we are able to pick up this lesion. So this window of opportunity, the red area that is being shown here in this slide, is very, very important to provide an impact for this particular cancer. But why this early detection is difficult? So as I mentioned, in early stage, this cancer does not show any symptoms. If there are symptoms, these are usually non-specific symptoms. However, if one wants to recognize with symptoms, the symptoms include weight loss, abdominal pain, steatorrhea, new onset diabetes, or the deterioration of pre-existing diabetes. When the patient develops symptoms of jaundice, it's already very late in the course of the disease. Moreover, around 20% of the patients have lesions in the body and tail of the pancreas, where again, jaundice doesn't appear early, and we have a very late detection for lesions in the body and tail of the pancreas. So screening is primarily done early detection of pancreatic cancer, again, as I mentioned, is important to improve survival. The US Preventive Service for Task Force advises against screening for asymptomatic patients. Why is that? The reason is this is not a very common tumor. As you see, the incidence, as I showed earlier, is around 8 to 12 per 1 lakh per year, and 1.3% lifetime risk of developing the disease. So you have to offer screening for a disease only if it is, there are certain criteria for that. So in this particular cancer, this is not at all cost effective, and there is no supporting evidence to tell you that if screening is offered, it reduces the mortality. So for example, if the screening test is again 99% sensitive and specific, which will lead to unacceptably high rates of false positive findings if applied to the general population. This is because this tumor is again not very common. So this slide again is the most important of the whole presentation. One needs to remember define, enrich, and find strategy for early detection of pancreatic cancer. This has been proposed by Dr. Suresh Chari et al. And this proposes a 3-step 2-sieve approach. So what is it? So basically in the general population, you can't apply screening for all the population. So what you need to do is first to define a high-risk group. And this is done by picking up certain clinical indicators, one of which includes the new onset diabetes. After you have picked up a high-risk group, among this high group, you have to again find a group which carries further more increased risk, and this is known as enrich. This is done by clinical model and biomarkers. After one has done this, we need to find the lesion on imaging, and once we pick up a lesion, we have to confirm this on biopsy. So this is what the define, enrich, and find strategy for early detection of pancreatic cancer. So to define high risk of pancreatic cancer, as you know, there are hereditary disease which one needs to remember. Hereditary pancreatitis, familial atypical multiple nevi melanoma syndrome, hereditary breast cancer, ovarian syndrome, Lynch syndrome. Then we have sporadic pancreatic cancer and familial pancreatic cancer. These again carry increased risk of developing pancreatic cancer. And among lifestyle changes, smoking and alcohol use are considered to be high risk features for pancreatic cancer. Medical history, the presence of diabetes, I'll come to that again, and obesity are very important as predisposing factors for pancreatic cancer. Then we have chronic pancreatitis and pancreatic cystic tumors, especially the IPN, which are considered to be high-risk features, high-risk predisposition to pancreatic cancer. So if I just put up these, so once you have an average risk in the general population, more than 50, low risk, again, smoking, high BMI, long-standing diabetes, high risk, that is 6 to 8-fold in family members with pancreatic adenocarcinoma, new onset diabetes, this comes under high risk, that is 6 to 8-fold high incidence of pancreatic cancer, and then very high risk group, that is hereditary pancreatitis and chronic pancreatitis. So as I mentioned, this diabetes is very, very important to be considered when we are trying to make a diagnosis of pancreatic cancer. The prevalence of diabetes ranges from around 4 to 65%. In a study, 47% of the pancreatic cancer were identified in individuals with diabetes versus 7% only in the control group. And 74% of those with diabetes and pancreatic cancer had new onset diabetes. So this word NOD, or the new onset diabetes, is very, very important in the context of pancreatic cancer. And a disturbance in glucose homeostasis is universally observed in all patients with pancreatic cancer. So a study again by Chari et al., what they showed was a very interesting finding that abnormalities in the fasting blood glucose have been detected 30 to 36 months before the diagnosis of pancreatic cancer, and the progressively increasing up to 126 milligram per deciliter approximately 6 to 12 months before pancreatic cancer diagnosis. So what does this mean? So this tells you that the patient has disturbed glucose homeostasis or the blood sugar starts increasing around 36 months before the onset of pancreatic cancer. So this is a particular group where screening or picking up this particular group may be relevant to change the outcome of pancreatic cancer. So this is what they showed in the study. Normal fasting glucose only in 9, impaired fasting glucose in 21, new onset diabetes in 22, long lasting diabetes 20%, advanced pre-diabetes in 13%. So second high risk group again includes the cystic lesions in the pancreas, and of these, as everyone knows, that mucinous cystic lesions are the ones which carry high risk for malignancy. Among these, IPMN again is the one which carries increased risk. However, in the branch duct IPMN, one needs to understand that all branch duct IPMN do not lead to pancreatic adenocarcinoma. And as you see that up to 25% of the patients undergoing surgical resection for cystic lesion of the pancreas have benign lesions that would have never progressed to malignancy. And up to 78% of patients with branch duct IPMN do not have cancer or high-grade dysplasia at the time of the resection. So this is again a subgroup of the patients where one needs to focus. Third group is the chronic pancreatitis group. Here again you have a high risk for the development of pancreatic cancer, and after excluding for patients with the diagnosis of pancreatic cancer within 2 years, the risk of pancreatic cancer is 16-fold in patients with chronic pancreatitis compared with the general population. So this again, patients with chronic pancreatitis, long-standing chronic pancreatitis are the ones which carry a high risk of development of a pancreatic cancer. Again, even though chronic pancreatitis is considered a strong risk factor, but less than 5% of the patients of chronic pancreatitis develop pancreatic cancer. That again is a problem. So it's a strong predisposition, but the number of patients which ultimately develop is less. And possible reason for increased risk of pancreatic cancer in CP includes exposure to tobacco, alcohol, chronic inflammation leading to carcinogenesis. So as I mentioned, first you find and then you enrich the high-risk population. So enrichment, as I mentioned, you are picking up subgroup of patients who again have more risk compared to the others who are in the high-risk group. So this is to detect really the high-risk group, that is 25 to 50-fold increased risk of pancreatic cancer, and this is achieved by usually using different clinical models or identifying a characteristic phenotype in the high-risk group on clinical model or a highly accurate biomarker. So clinical model, again, Dr. Chari's group, they have published a model which is known as enriching new onset diabetes for pancreatic cancer, which contains 3 components. What are these? Age, change in glucose, and change in weight. And this model stratifies patients in 3 groups: low, intermediate, and a very high, that is 4%. This model was able to predict 3-year risk of development of cancer with 78% sensitivity and 80% specificity in the high risk group. So again, good sensitivity and specificity, but not an excellent sensitivity and specificity. The problem is this clinical model has not been validated in many centers. So it's only one more center in which it has been externally validated, but not uniformly practiced by all. The second to enrich is the biomarker. So what is a biomarker? So biomarker is a biological molecule that can be objectively measured to indicate a normal or a pathological process or a response to therapy. And these could again play an important role in enriching the high risk group. So one of the most common markers that every one of us use is CA19-9. However, the reason why the CA19-9 is predominantly used is for prognostication. So this one needs to remember, it's not primarily meant for screening tool or for diagnosis, and it has got a sensitivity of only 78% and specificity of around 83% for identifying pancreatic carcinoma, which again is not great, and it has got false positive and false negative. That is, it can be found in many other malignancies like colorectal cancer, cholangiocarcinoma, and in some benign disease also you can have a high CA19-9. Other marker that is used is CEA. So CEA again is predominantly utilized as a prognostic marker. Again, the sensitivity, this elevated CA has been found in 30 to 60% of the patients. This again can give you false positive and false negative results. So we have number of markers, biomarkers which have come up. Unfortunately, these markers, you don't have very large studies to prove that these really are very effective for pancreatic cancer. But I have listed these including non-coding RNAs, protein-based, DNA methylation. And if you see, these have been used, markers have been derived either from saliva, pancreatic juice, serum, feces and urine. So I've just listed these markers based on KRAS mutation, P53, DNA methylation, histone modification, microRNA, long-standing microRNA, and again cytokine related, and again exosome. This is again more, we have few literature coming up for this exosomes also. So this is liquid biopsy, again a term just I wanted to introduce. This includes different things. This includes circulating tumor cells or the tumor DNA which can be detected. And there is a study, this is a systematic review and a meta-analysis of 19 studies around 1800 patients, which gives you overall sensitivity of 80%, specificity of 89%, and this of 95%. Again, the AUC, as you area under curve, as you can see, is not very good, and better diagnostic accuracy is clearly needed. So again, there are problems with the biomarker, and despite thousands of published papers, no single candidate biomarker has been translated to clinical use for the early detection of pancreatic cancer. So as you can see, the biomarkers are usually used in the initial phase to pick up a pancreatic cancer. But as I mentioned, we really need more literature on this. So just few words about imaging. As everyone knows, once you have to pick up a lesion, initial imaging modality is usually a CT scan. However, if there is an isoatenutic pancreatic cancer, that is, it is difficult to differentiate the pancreatic parenchyma, then the MRI is the one that you use. However, now we have something known as radiomics. So radiomics is primarily a subfield of computer vision analysis. So basically what you're doing, the imagings that you have, the number of imaging that you have, with the help of AI, this primarily helps you to give more accuracy for diagnosis of a lesion which can be missed by individual radiologists. Again, EUS is highly sensitive for picking up small tumors less than 2 centimeters. Its sensitivity and specificity is obviously better than CT scan or an MRI. So I'll just summarize. Significant progress has been made in the last decade to identify high-risk groups and improvement in imaging techniques. In the future, one needs to focus on the accurate identification of high-risk individuals in an automated fashion with the use of machine learning. We also need to develop validated non-invasive biomarkers that can be used for longitudinal surveillance of high-risk individuals. Radiomics and AI are going to play a crucial role in the early detection of pancreatic cancer. Thank you.
Sir, I have a question. Sir, we in clinical practice, we generally see if known diabetics, there is uncontrolled, well controlled till some time, and then they develop these uncontrolled sugars. That is the reason when they develop these pancreatic cancers during that time. So, but in your slide, it showed newly diagnosed diabetics, they have around 22% of them have got a pancreatic cancer. So, all those patients who are diagnosed to have diabetes, should they undergo evaluation for CA pancreas with CT scan, other things? That's one question I wanted to ask.
So I think if I got it right, basically one needs to be very clear about this term new onset diabetes. So again, new onset diabetes, we are talking about a specific entity which usually comes around 36 months before the onset of CA pancreas. The problem is that even in patients with long-standing diabetes, you may have worsening of diabetes in those patients as well. It may not necessarily be related to CA pancreas. However, if you have at the age of 50, if one has new onset diabetes, that is, the patient was not diabetic before and now he has developed a diabetes, or he has diabetes and now there is worsening of diabetes, these are the subgroups where especially we need to focus on picking up a pancreatic cancer. Again, if you ask me what modality should one use in these patients, I think again the biomarkers at this point of time are still unreliable. So the most commonly that we do in our settings, in our clinical settings, is to do a CT scan in these patients. Again, doing in all patients again is very, very difficult job, and that's the reason why we are trying to filter out a subgroup of patients with high risk.
With this, we'll conclude the session.
Thank you.
Thank you.
For the next session, may I request on stage the resource persons, Dr. D. Nageshwar Reddy, Chairman, AIG, Hyderabad, Dr. Mahesh Goenka, Director, Apollo Multispeciality Hospital, Gastroenterology Institute. May I also invite on stage the chairpersons, Dr. Kalidas Bishwas, Professor and Head, Department of Gastroenterology, Medical College, Kolkata, Dr. Shoibal Das, Scientist, Grade D, Medical, ICMR, National Institute for Research in Bacterial Infections, Kolkata. And may I invite on stage our speaker, Dr. Abhinav Sharma, Senior Consultant Gastroenterologist, CK Birla Hospital, Jaipur.
Good evening. I bring greetings from Jaipur, and before I forget, I invite you all to Endocon, which is happening in Jaipur this time. And my wholehearted thanks to Dr. Sanjay Banerjee for organizing this wonderful meeting and for inviting me. Thank you very much. So this is basically not a talk. This is just a update on what is happening in pancreatology, and topic given to me is this year in pancreatology. So pancreas is happening. Lot of conferences are occurring in India as well as around the world, but hardly any hardcore research is happening in the field of pancreatitis. So I have willingly omitted pancreatic cancer because there is plethora of information which is beyond the scope of discussion to this and not of interest to this audience. So coming to acute pancreatitis, which interests us all, we know that this disease is basically, it evolves into phases, and I remember a talk from Dr. C.S. Mani, probably he delivered in Vizag, and he showed, his very first slide he showed was trends of mortality in severe acute pancreatitis, and his opening statement was that we have hardly made any dent to the mortality in acute pancreatitis. And the same trend, it is still reflected here that we have hardly made any dent on mortality in acute pancreatitis despite all the advances in critical care. The problem is it's difficult to judge which patient is going to evolve into severe acute pancreatitis despite all the scores and all the parameters we assess. They hardly reach post-test probability of 50%, which is equal to tossing a coin. So there are biochemical parameters, there are clinical parameters, and there are radiological parameters. But our pursuit of finding a good predictor is still lacking. So still new papers are coming up which are targeting prediction of acute pancreatitis, and new molecule which has been picked from critical care, particularly in sepsis, is phosphorus nowadays. And this paper, it is a retrospective review. Patient with acute pancreatitis, 300 odd patient, 3 tertiary hospitals in UK, and out of these 25% had hypophosphatemia defined by phosphorus level less than 2 milligram per deciliter. 30% of these patients had acute pancreatitis. Now let us look at data. So they looked at severity of pancreatitis, ICU admission, and length of stay, and we can see that those patients who had hypophosphatemia, they divided into 24 hours after admission and within 48 hour admission and total, and all those patients who had hypophosphatemia, they had severe pancreatitis, they required more of ICU, and their likelihood of staying long in hospital was high. Now these are the odds ratio. Dr. Ghoshal was talking about odds ratio, and odds were high for severe pancreatitis, SIRS, bicep score more than 2, and ICU admission. This study was not powered enough for mortality, so mortality difference has not been demonstrated, and this is how the authors conclude that hypophosphatemia is associated with severe pancreatitis with odds of 3, ICU admission, and longer hospital stay. They also noted that those patients who had normal phosphorus at the time of admission, but they developed hypophosphatemia later, they had more likelihood of landing up into severe pancreatitis. So their conclusion on early phosphatemia during admission for acute pancreatitis is associated with increased acute pancreatitis severity, more likelihood of ICU admission, and longer stay. One more study on phosphorus, again similar study from other group in USA, 8 months down the line, similar kind of study design, but more number of patients, 1500 odd patient. They also had only 33% were documented with phosphorus level within 48 hours, and so this highlights that we are not measuring phosphorus routinely as investigative armamentarium in acute pancreatitis. And this is how they derived their cutoff with this histogram. Their cutoff was 2.3 as compared to previous study where they took a cutoff 2. Interestingly, the more of alcoholic patient, they had more of hypophosphatemia, which they explained by poor nutrition in alcoholics. Coming to the results. So those patients who had hypophosphatemia, they are more likely to land up into ICU, and they had more propensity to develop moderate or severe acute pancreatitis, conforming to previous study. And this Kaplan-Meier plot, you can see that red line is shifted towards right. That means they had longer hospital stay. So same kind of study, more number of patients, a similar result. Hypophosphatemia patients have severe pancreatitis, more likelihood of ICU admission and longer stay. They also observed that we infrequently measure serum phosphate in acute pancreatitis, and it can be a promising prognostic marker in acute pancreatitis. The third study on phosphorus which I found is they went ahead and they not only measured phosphorus, but they derived a phosphorus to calcium ratio. And this study is very interesting because this study is true example of globalization. The patients was admitted in USA. Data was uploaded in a MIMIC database, and this data was taken out by Chinese researchers, and then they applied statistics, and they put the calcium phosphorus ratio they categorized by using a software called Xtile to find out the optimal cutoff value. Now this is the study design. The Xtile, with the help of Xtile, they divided phosphorus to calcium ratio, we call it PCR here, into 3 categories. Low, that is 3.4, intermediate, that is 0.54, and high, that is 1. 0.3, 0.5 and 1, group 1, group 2 and group 3. Let us see the result. They looked at mortality, 28 and 90 days mortality. The red line here shows those patients who had low calcium to phosphorus ratio, and in green intermediate, and the blue one is high calcium to phosphorus ratio. And with this Kaplan-Meier, it is very well evident that those patients who had higher PCR had more likelihood of mortality. So this study is related to mortality. So conclusion is phosphorus to calcium ratio has a strong correlation with in-hospital mortality in patients with acute pancreatitis. So phosphorus is the new molecule, sir. So I was asked to stop between the studies so that my mentors can come in.
Thank you. I think Abhinav, that was very nice that you extracted an unusual thing that actually prognosticates pancreatitis. Traditionally, the problem is this has to be validated. When you look at all prognostic markers coming for pancreatitis, there are almost 20 now, and every time they go into validation, you'll find that because of various reasons not valid. In an ICU setup, people would look at, let's say, Ranson and Apache to say which patients are likely to go into more severe pancreatitis, but very few of us as gastroenterologists. In my opinion, what we do in clinical practice, simple things like BUN, CRP and I think SIRS are very simple modalities which can actually tell you which patients are likely going to severe pancreatitis. That would be my comment.
Again, what is the explanation given in these studies that why phosphorus is correlating with the mortality? Is there any explanation given?
Yes. So they propose mechanism. Phosphorus is component of ATP, which is energy source, and phosphorus metabolism is closely related with calcium, which get altered in acute pancreatitis, and this destabilizes the membrane of cellular tissue. So that is the explanation.
Is there any of these studies have compared the standard prognostic markers like SIRS we talked about?
Yes, sir.
With phosphorus, and whether the phosphorus was better than SIRS? Or was there any comparison between the various prognostic markers?
They have mentioned these parameters, like here in this study, they have given the values of SIRS bicep score and correlated it with hypophosphatemia. So they have done that, but only thing is these are retrospective studies, and there are many confounding variables in.
At least it will open for more research being done in this area.
Yes, sir. Yes, sir. Yes, sir.
One thing I want to know, both hypocalcemia and hypercalcemia are seen to be associated with acute pancreatitis. If this is so, then how can you correlate with PCR as an important marker for prediction of severity?
This is just one more way to look at it, because we know that hypophosphatemia is related to severity of pancreatitis, hypocalcemia is also related to severity of pancreatitis. They have just tried the ratio, that how it fares well in prediction.
Dr. Dadish, you want to make a quick comment?
Two things. One, both these studies are retrospective, but again downgrade their validity. Second, there was no control group because all were ICU. Whether this is a cause or effect, we don't know. Was there other people in ICU, no pancreatitis, they also had hypophosphatemia, or only the pancreatitis people had hypophosphatemia? Because this could be because of its severity of illness.
So whether it's an epiphenomenon or something. I think there are many much more data to share. So let's move on.
Yeah. So they have shown just association. We can't say whether this is cause or effect. That is difficult. So moving on to second topic in acute pancreatitis, prediction of AKI. So there have been attempts to develop models that can predict AKI development in acute pancreatitis very early in the course, so that we can modify development of AKI. And this study is very simple, from China. Again, retrospective database. They divided 250 patients into two groups, AKI group and non-AKI group, and applied all kinds of statistics. So in univariate analysis, these many variables, they found that they are associated with development of AKI. But when put to multivariate analysis, only 3 variables were found to be independent predictor of AKI, which is age, procalcitonin level, and you see TYG here, which is triglyceride glucose index, which is natural logarithm of triglyceride multiplied by glucose divided by 2. And with the help of complicated statistics, they derived this kind of logistic equation where all these parameters have been laid down, and then you can calculate what is the patient's probability of ending up into severe acute pancreatitis leading to AKI. So this is how it is calculated. Now, when they applied this to their patient, when this equation was applied and all the parameters of patient were put into it, and then they look at whether patient landed up into AKI or not. So this came out, this is the data. The sensitivity was around 80%, specificity, positive predictive value, negative predictive value around 91%, and giving diagnostic accuracy of 91%. And when we see area of undercurve, the larger the area of curve, the better the predictor is. So this prediction model has largest area of undercurve, then Ranson score, and then bicep score and Apache score. So this model, in this study, it proved to be good. So that's what Dr. Namugoenka was pointing out, whether these parameters have been compared. There is another study, again retrospective, with larger number of patients. The problem with previous study was there are no internal or external validator cohorts. So the second study, though this is a retrospective database, but larger number of patients, and they divided the patient into 3 cohorts, 1 training and 2 training and external validation cohorts. So patients were taken from two hospitals. One hospital had training set and internal validation set, and patients from other hospital were taken to external validation cohort. Now these are the parameters, these are the variables which were found to be associated with AKI on univariate analysis, and in interesting term we see here is shock index, and shock index is nothing but heart rate to systolic blood pressure ratio. So these are the parameters, clinical and biomedical, and then they went on to develop a nomogram for development of AKI, and you can see that the points here, how each variable, how much weightage each variable carries, the total number of points, then linear predictor and likelihood of acute AKI in the setting of severe acute pancreatitis. Looks complicated, but not that complicated, is simple. Then when they put it to test, the area of under found to be under curve found to be very good, around 0.75% on ROC curve, and it showed high degree of calibration on calibration curve, and on DCA curve it proved to be robust clinical applicability. So nomogram which can be used clinically. Sir.
I think we have very less time, so we'll quickly. I think, Abhinav, whenever you have very complex predicting systems, people don't follow it.
Yes, sir.
Because so many variables are there, you can't have diagrams, plotting. The easiest thing, I think, for clinician is that if we have a BUN, which is not getting diluted in spite of giving a lot of fluids, this patient is likely to go into an AKI. That's a very simple factor.
Yes.
Naturally, procal indicating infection is going to go. So I think, I don't know whether we should actually really follow this very much. I would still suggest getting back to simple mechanism.
Yes. So now from prediction to intervention. So there is one study which attempted to mitigate severity of pancreatitis. Earlier, all kinds of plasmapheresis and hemofiltrations have been done. This study used this machine where they took out the blood from the patient, sent to plasma separator. The separated plasma was sent to plasma adsorber, and blood was sent to hemofilter, and then dialysate was taken out. So combination of heme filtration, heme adsorption with an idea to remove all inflammatory mediators so that we can mitigate the severity of pancreatitis. A randomized control trial, first randomized control trial in this presentation. A patient were divided equally into treatment group, and control group had simple veno-venous hemofiltration. Total 2 sessions were done 3 to 4 days apart, and each session lasting for 8 hours. So this diagram shows pro-inflammatory and anti-inflammatory mediator. Pro-inflammatory mediator are above the line, and anti-inflammatory mediators are down below the line. And the pro-inflammatory mediator shows significant reduction, and anti-inflammatory mediator shows significant increment after the 2 sessions of this process. And they also showed reduction in Apache and SOFI score. They also looked at capillary perfusion in sublingual area and showed improvement in capillary microcirculation after therapy with this machine. And their complication rate also went down, all those patients. So this is the conclusion: continuous plasma filtration and absorption in patients with acute pancreatitis. It removes inflammatory mediator, it improves microcirculation, and it improves therapeutic outcomes. Though they have commented on mortality rate, but I don't think this study has enough sample size to comment on mortality rate. Sir.
Mahesh takes up. I think this is a very important study. In fact, now in all our ICUs, we are using anti-cytokine absorption like
Plex
dialysis.
Yes,
Zyrex is called
Plex filter.
No, not Plex. Plex
Yes.
is plasma exchange.
Yes, sir.
This is specifically only for cytokine. It's called Zyrex or something.
Yes, sir.
We have recently started a study, especially in patients who have post-ERCP pancreatitis. You put them onto that, the cytokines are taken, they make remarkable progress. I think that's a important progress that occurred in.
Same thing I wanted to say, that for different diseases we have different types of filters, and cytosorb is something which we have been using not in only in pancreatitis but in hepatitis, hepatic failures also. I think this is something which is going to we will hearing more and more in the coming years.
Yeah. So coming to chronic pancreatitis, this study you
Since
already
the time
know.
is limited, let's move on and have less discussion.
Yes, sir.
More
So this
information.
study Dr. Nagi already alluded to, so I won't go. This is again a study from AIG group. I won't go into detail because this has already been discussed. This is important, and this is going to be last study. Risk factor and prediction model for pain recurrence after pancreatic stent removal to chronic pancreatitis. Patient with chronic pancreatitis, you have done endotherapy, you put in a stent. Now, whether to remove the stent or not, that is the question, whether patient have pain recurrence or not. So this is retrospective review. This is the study protocol. Around 95% of the patients were involved. They could remove a stent in 73 and 29 had pain recurrence. What other than biochemical parameter, they also looked at pancreatic parenchymal thickness, which they measured at lateral margin of vertebral body, and pancreatic thickness minus ductal diameter and vessels is equal to pancreatic parenchymal thickness. Complicated statistics, they tried various combinations, serum lipase plus pancreatic thickness, serum lipase plus age, pancreatic thickness plus age, all three parameters. On what they found out that serum lipase level of more than 44 and pancreatic thickness more than 14.2 millimeter had highest regression coefficients. So they gave them this, they gave those two parameters, 1 point each. If patient has these parameters present, 1 point. If doesn't have, then 0.0. Accordingly, they divided these patients into low risk, intermediate risk, high risk group. If patient's lipase level is below 44, if pancreatic thickness is less than 14.2, 0 points, low risk group. If any of these two parameters, one is present, low, intermediate risk. If both of the parameters are there, high risk. And then recurrence rates. Those patients who were in low risk group, that means no lipase is less than 44, pancreatic parenchymal thickness more less than 14.2, the recurrence rate was 19%, increasing intermediate and highest in high risk group. So those patients who have high lipase, 44 lipase more than 44 and pancreatic thickness more than 14.2, you cannot remove the stent if you have not done adequate endotherapy. So this is the algorithm they propose. Patients who have received pain relief after stenting, you see whether the obstruction has been cleared or not. If obstruction is successful, then all risk group patient you can remove the stent. But obstruction has not been completely removed. Means if some stone is remaining or if a stricture is there, then low risk patient where there is no risk factor, you can remove the stent. But intermediate risk and high risk patient probably would resort to continuous stent placement or surgery. Sir.
I think requires more validation. Yes. Looks interesting but requires more validation. We usually go by simple method that when we find that ductal anatomy is better, there are no stones, no strictures, we usually remove after keeping it for 1.5 to 2 years.
Yes.
I think again, Abhinav, you took a lot of effort to do these studies. I think you are now showing that to be a good pancreatologist, you have to be a good mathematician also.
So this is for you to read. Basically, problem with all of these studies, most of them are retrospective. So as they said, it requires a lot of validation, and probably prospective studies may not be randomized because randomization is difficult in setting of acute pancreatitis, these kind of study. But at least prospective studies, multi-center studies can be done. Thank you, sir.
Thank you so much. As Sir has already mentioned, that to adapt a clinical practice based out of data from model itself may not be a prudent approach. So we need to get it validated in our population and apply the clinical prudence more. Thank you so much for your presentation, sir.
Thank you.
So thank you, esteemed chairpersons and honorable speaker for the excellent session. Now we move on to the last session for today. To chair this session, may I request Dr. Somnath Mukherjee, Senior Consultant Gastroenterology, CMRI, Kolkata; Dr. Supriyo Ghatak, Senior Consultant GI Surgeon, Apollo Multi-Speciality Hospital, Kolkata; Dr. Deepak Shah, Director, Proton Clinic, Kolkata; and Dr. Joya Ghosh Chatterjee, Consultant Gastroenterologist, Peerless Hospital, Kolkata, to please come on the stage to start the session. Our esteemed speaker for this session is Dr. Sukanto Rai, Professor and Head, Department of GI Surgery, IPGMER and SSKM Hospital, Kolkata. Requesting Dr. Shukanto Rai sir to please come on the stage and start your deliberation.
Good evening, respected chairpersons, my seniors and juniors. Special thanks to Dr. Sanjay Banerjee and Kolkata Update, Pancreas Update for their kind opportunity. They gave me opportunity to tell something in front of this esteemed gathering. Today my topic is indication and outcomes of surgery for chronic pancreatitis. Chronic pancreatitis is a benign but progressive inflammatory disorder. Its management is a challenge. It requires a multidisciplinary team approach. It has a major clinical impact. The management of chronic pancreatitis is divided into three groups: medical management, endoscopic therapy, and surgery. 30 to 50% patient will require surgery. Before 1990, the management of chronic pancreatitis, particularly surgery, was indicated after failure of the medical management. But after 2000, the scenario has been changed and step-up approach. Surgery is indicated after failure of the endoscopic therapy. Though the early surgery is now a emerging option. Though in clinical practice, most of the centers still practice step-up approach. They exhaust their endoscopic therapy before referral to the surgery with the perceived idea that endoscopic therapy is less invasive and pain control is equivalent with the surgery. Although 3 randomized control trials have shown that long-term pain control is significantly better in surgery. Whatever may be the line of management, intractable pain is the indication for surgery, and about 40 to 60% of the patient with chronic pancreatitis ultimately fulfill this criteria and require surgery. Second important point is suspicion of malignancy. When there is any suspicion of malignancy, based on clinical parameters and imaging, surgery is the treatment, and in this case, resective surgery is the option. If the lesion is in the head of the pancreas, Whipple's separation, or in the distal body and tail, you have to perform the distal pancreatectomy with splenectomy. The lesser form of resective surgery like Cray and bigger procedure are not indicated in these cases, because if the postoperative biopsy comes as malignancy, there are little option in your hand. Even with total pancreatectomy and Whipple's separation, the overall survival of this group of patients is not good. The last option is peripancreatic local complications that are not amenable to endoscopic therapy or percutaneous technique. Nowadays, most of the peripancreatic complications like bile duct, biliary stricture, pseudoaneurysm, and pancreatic ascites, pancreatic pleural effusions are mostly managed by endoscopic therapy and medical management. Only a subset of the patient, about 5 to 10% of the patient, will require surgery. But this is ideal. This is for ideal situation. But these facilities are not available in all the institutions, or if available, they are not available round the clock. For example, if the patient comes to us with a pseudoaneurysm bleed, we will not be able to offer the angioembolization at night. So you have to rely on the surgery. So you have to assess the hospital resources and the local expertise for management of the peripancreatic local complications. Surgical outcomes of chronic pancreatitis is divided into 2 headings. One is short-term outcomes, that is mainly the post-operative complication and 90-day morbidity and mortality. Long-term outcomes are judged by pain control, improvement of the quality of life, preservation of exocrine and endocrine function, and overall survival of the patient. With the improvement of the perioperative care, better selection of the patient, and fine-tuning of the surgery, 90-day morbidity and mortality of pancreatic surgery has been diminished significantly. Overall complication developed in 9 to 39% of the patient, and mortality is about 1 to 3% of the patient. In our published research, the overall complication developed in 31% of the patient, but majority of the complications are minor one. Only 12% patients develop the major complications, and the mortality of pre-procedure was about 1%. The factors related to the 90-day morbidity and mortality are patient-related factors, disease-related factors, types of surgery. It is expected that the complications of Whipple's procedure is significantly more than that of lateral pancreatitis. It also depends upon the experience and skill of the surgeons. Healthcare system and hospital resources are also important. Adu Sodhi from the GP Pant Hospital has published his data regarding post-operative complications in chronic pancreatitis, and he had shown that endoscopic procedure prior to pre-procedure was the only factors that is statistical significance on multivariate analysis and most related to the infectious complications. The study performed by the Naptolion is a multi-center study, and it had shown that the preoperative diabetes, COPD and perioperative blood transfusion was the factors related to the 90-day morbidity and mortality. Similarly, our study showed that perioperative blood transfusion was the only predictors for post-operative major complication and mortality. Recently, we have presented our data in the IHPBA, where 576 patients are included in the study. 576 patients are included in the study, and overall complications developed in 29% of the patient and major complication in 8.7% of the patient. On multivariate analysis, endotherapy and pain duration are the major denominator for post-operative major complication. Both are modifiable factor by reducing the endotherapy, by limiting the endotherapy, and by providing early surgery, we can reduce the post-operative morbidity and mortality also. Long-term outcome is mainly judged by control of pain. Pain is the most disabling symptoms, and it is the symptom for which the patient seeks medical advice. So control of pain is the primary endpoint of any kind of intervention, including surgery. Overall pain relief can be achieved in about 70 to 90% of the patient with chronic pancreatitis. From this slide, it is evident that pain control varies from 65 to 95% of the patient, and pain control is almost similar irrespective of the type of surgery. So you have to identify what are the factors that are related to the good pain relief. The determinants of long-term pain relief are timing of the surgery, status of the preoperative opioid use, number of endoscopic intervention, type of pain, etiology and morphological factors, and also the ongoing alcohol and adequacy of the surgery. Nowadays, early surgery is an emerging option, but it is not a newer idea. The idea was first described by Nilon et al. In 1993, and he had shown that when surgery is performed early, the preservation of the pancreatic function is significantly more, 78% versus 25%. But this idea was not popularized unless Ahmed Ali from Dutch pancreatitis study group have shown that early surgery is beneficial. He had shown that when surgery is performed within 3 years of onset of pain, there was no preoperative opioid use and fewer than 5 endoscopic procedures were performed. The long-term pain control was significantly better in early surgery group. Similarly, Young et al. Have shown that when surgery is performed within 26.5 months of onset of pain, at 3 years follow-up, pain control was significantly better in early surgery group. Similarly, Nguyen et al. Have shown that the pain control was significantly better, as well as better preservation of pancreatic function, particularly exocrine and endocrine function, when surgery is performed within 3 years of onset of pain. Recently, long-term outcome of ESCAPE trial has been published. Over a mean follow-up of 98 months, they have shown that early surgery group have better pain relief and better satisfaction. Another important findings of this study was that about 51% of the patients who were initially treated with endoscopic procedure ultimately required surgery, and the pain control in this subset of the patient is significantly worse, 55% versus 12%. and they recommend early surgery was superior to an endoscopy first approach. Recently, SCOPA group has been published their data, and they have shown that the duration of the symptoms and the no use of opioid are directly related to the long-term pain relief. The role of pancreatic ductal parameter, pancreatic head size and etiology is also important. Beckman et al. Recently published their data, that is the chronic pancreatitis pain relief score based on 5 parameters. Initially, the 5 parameters reached statistical significance, that is the pancreatic head size, pancreatic ductal diameter, alcohol etiology, calcification and fibrosis. As calcification and fibrosis is assessed on post-operative biopsy, they discard this, and based on 3 parameters that can be assessed pre-operatively, like pancreatic head size, pancreatic ductal diameter and etiology, they developed the pancreatic pain relief score, and they have shown that when etiology is the alcohol, pancreatic ductal diameter is more than 4 millimeter and pancreatic head size is more than 4 centimeter. When all these 3 parameters are present, the pain relief is about 100% compared to only 5% when all these factors are absent. Quality of life is an important assessment for assessment of surgery, and it is the most important parameter that will dictates the satisfaction of surgery after chronic in cases of chronic pancreatitis. Several modules are used, like short form 36, short form 12, URTC, quality of life, and most of the authors have shown that there is significant improvement of all the indices of health-related quality of life after surgery. But what are the important determinants for quality of life surgery improvement? Most important is pain control, and second is types of surgery. Beckman et al. Have shown that when there is adequate pain control, all the parameters of health-related quality of life was significantly improved than the patients who had inadequate pain control. Similarly, he had shown that the quality of life is better when duodenum preserving pancreatic head dissection like Frey-Beger procedure is performed over pancreatorrhinectomy. Long-term survival after surgery is also an important aspect of the surgery for chronic pancreatitis. Most of the studies have shown that long-term pain control, long-term survival varies from 67 to 82% of the patient, and studies have shown that chronic pancreatitis patient, that is 4.5 times increased risks of mortality than the general age-matched general population. And extrapancreatic causes are the major cause of mortality in long term, and behavioral risk factors like alcohol abuse, persistence of smoking and persistence of opioid use are major determinant factor for long term mortality. And they have also shown that when the follow-up period is increased up to 10 years, about 1/3 of the patient will die during the follow-up. Recently, one study was published from the Cincinnati University. 493 patients are included in the study. They have shown that 1 year, 5 year, and 10 year survival was 95%, 81%, and 63%, and median survival was 202 months. And they have shown that alcohol and smoking at etiology and persistence of smoking in the follow-up and persistence of opioid use are associated with decreased mortality. On the other hand, diabetes had little effect on the long-term mortality. That is the waterfall plot of the same study, and they have shown that the most common cause of mortality is infectious, and followed by cardiovascular event, and pancreatic cancer is also important, and suicidal tendency accounts for 3.6% of the cases of mortality in this group of patients. So mental health is also important in the follow-up. In summary, chronic pancreatitis requires multidisciplinary approach. Surgery plays an important role with good long-term results. Early surgery is an emerging option, but further studies are necessary for its generalization. Limiting the number of endoscopic procedures, we can improve the long-term and as well as short-term morbidity and mortality. patient optimization, surgeon training and experience are important, and long-term follow-up is recommended. Thank you for your attention.
Excellent presentation, Dr. Sukanta Rai. I think he is consistently publishing good data from PG assistant hospitals. And as we have seen this surgical topic we are discussing at the end of the day, we as surgeons also get our patients with chronic pancreatitis at the end of the day after a long period of failed therapy. But to highlight the point that in chronic pancreatitis we are aware that if we prolong the surgery and the patient remains painful, there is CNS imprinting of peripheral pain stimuli. And even if the stimuli is removed, the pain sensation remains. So early surgery is very important, and spectral, as he has said, there is a particular question asked to the participants whether they will undergo the same procedure, whether they will go for surgery or the endoscopic procedures after the end of the trial. Majority of them who have undergone surgery said they will recommend the same thing to other patients, whereas the endoscopic arms were not that confident. Thirdly, the American Society of Gastrointestinal Endoscopy, they have published their recommendations, and it is any patients with painful chronic pancreatitis, when they come for the first time, they should be evaluated for surgery, and if they are not fit for surgery, then you should consider endotherapy. This is coming from the American Society of Gastrointestinal Endoscopy, published in 2025 guideline.
I think following on from what Supriya said, after the ESCAPE trial and with 8 years robust follow-up, you have been very modest in saying that it is an emerging thing, but I think early referral for pain in chronic pancreatitis to the surgeon is the call of the hour at this point. But what I wanted to ask you a second part to the question, that this part Supriya has said, which is the subset which has got non-dilated pancreatic duct,
yes,
which we do not very much discuss, which
yes,
is clearly
yes,
outside the endoscopic
yes,
area.
yes, yes,
and if you are given the choice of surgery in these cases, which is the one you are going to choose, i.e.
Yes, non-dilated pancreatic duct is encountered in several situations. One is small duct disease. Small duct disease does not mean the pancreatic duct itself is only small in diameter. But if you see this group of patients, you will see that the pancreas is studded with, side branches are studded with multiple small stones. In this group of patients, best treatment is total pancreatectomy with islet cell transplantation. But this facility is not available in most of the sophisticated center also. In our setup, what we do is the HBK modification or Hammack's procedure, where a well-shaped pancreatic resection is performed in the body and tail. What is the advantage? It will open up the pancreatic side branches well, and the pancreatic ductal diameter is effectively increased. That's the diameter of the pancreatic jejunectomy is increased. That's why pen relief is adequate. And HBK itself had shown that in a long-term follow-up, 78% of the patient have complete pen relief.
It's slightly dependent on the location of the disease, like a head
Yes,
dominant disease,
yes,
body dominant
yes,
disease, and
yes.
a
Small
tail
duct
dominant
disease, I already told, small duct disease does not mean the diameter of the pancreatic duct is. If the head is enlarged, for example, you can do the burn procedure also.
So if there are no more questions, can we close the session? So I hand it over to the organizers. Thank you.
Thank you.
So thank you, sirs, for providing your valuable insights. So on behalf of the organizing committee, I must thank and express our deepest gratitude to all our respected speakers and chairpersons for providing your valuable insights in the recent advances of pancreatic diseases. I must also thank all our delegates without whom our conference would not have been successful. So thank you all from the core of our heart. So looking forward to a very successful fourth update in the next year. Request all to kindly join for our cocktail dinner waiting outside. So thank we. So we close here. Thank you all.